80s reported the first case of intracutaneous fistula. And it's interesting to know how data keeps on swinging. He said that the chances are higher in the subfacial plane if you put in a mesh than the onlay plane, which is comparatively different to what we think today. So I'll be putting up a lot of slides and you will wonder how the pendulum keeps on swinging from one end to other end. So intracutaneous fistula in our practice, we have two varieties. One is which is post-laparotomy. We do any procedure in the new develop with a fistula. And second scenario is where you develop after a hernia surgery. So the clinical presentations are different, the investigations required are different, and the management is also different. But my focus today will be on this because when the topic was given to me, I was a little bit skewed, and then I had to think that what exactly I'm going to talk about. So this is where we are going to focus about. So it starts with the story of the first scenario. This was a patient referred to our unit at KM, ischemic bowel, anastomosis done, leaked, then the patient was re-explored, and then someone did a re-anastomosis on that patient, and then finally they sent it to me with this early in the morning at 8 o'clock on the rounds. When I was there, I said, what is this? He said, this is the story of the patient. And you can see that there is a leak which has been referred to us. This is a potential or a perfect recipe for a patient to land up into a hernia later. So here everything is under tension. The patient is under tension, the sutures are under tension, and even the surgeon who's going to treat me, I'm also going to be under tension. Let me start off with the story of a gentleman of an ECF fistula, which is a 10-year-old story. He had an open bilateral inguinal hernia in one of the centers of repute in Western India. And this is what he came to me. And I asked him, since when is this? He said, sir, it's a long story. Can you spare me some time? I said, yes. So 2011, laparoscopic inguinal hernia got infected. Then there was drainage of collection. First half of 2012, then the surgeon decided to open and explant a mesh. Second half, then they thought that let's start an AKT. After that, he saw 5 more surgeons for the same problem, and everyone said it's a difficult operation, but we will try to remove the mesh. Then he saw the 7th surgeon who then attempted a laparoscopic removal. So he's moved from West to North India to South India to centers of repute. And then the 8th surgeon said, nothing doing, let's continue with the dressings. And finally, for 7 years, there was a sabbatical. There was no discharge until when he came to me, I said, what's happening? He said, sir, I'm getting food particles, which is looking like stools, which is coming from that midline wound. And this is where he came to me and he said, your name has been recommended to me. And, the stories were 10 years. And now I'm having stools coming from that wound. So he came to me, then we planned for a scopy. And then I said that we'll make a plan for this patient and let's see what happens. And this is the classical case of how an intracutaneous fistula can develop even after 10 years. So this was a scan. And if you can see there, this is where it is. So you can see that that's a communication. Straight away, the communication is with the sigmoid colon. And the stool is directly coming from there. And this is a story of a patient who's undergone a laparoscopic inguinal hernia repair. I'll stop the story there and we'll continue it later. So ECF and hernia, very interestingly, article published in 2000. And you can look at that. Intraperitoneal mesh is not associated with intracutaneous fistula. So people have used proline and recommended that it doesn't cause a fistula. And then there was a response by Professor Amit, and he was a little skeptical and he said, it doesn't seem to be sensible that we should use a proline mesh in a case like this. We fast track it to 2017. And again, I was surprised to see this article of around 700 patients where they have said no fistula with an uncoated polypropylene mesh. So see how the data, we keep on talking about composite mesh, and now suddenly you look at that there is a polypropylene been still recommended in some of the centers. And this is evidence-based medicine. So what are the principles of ECF in general? These are the approaches which we have to look into intracutaneous fistula in any patient. We know the classification, high, low, and moderate, depending on what is coming out. So this will remain the same whether the patient has got a mesh repair or without a mesh repair. But this is a nice mnemonic to kind of decide what has to be done. So it's a snap theory. How do you snap the problem? You take care of the skin and the sepsis. Nutrition, we have a talk in the afternoon. Anatomy of the fistula with the mesh is important. And then we have to plan a procedure. Certain conditions where you will be adopting a non-operative protocol. So that's a list of things where probably you will not go into. This might heal on their own. But there are unfavorable situations where probably we will have to intervene. And these are the patients who will not perform well. So in ECF, who are the friend of fistula? So the friend of fistula, the first on the list is a foreign body. That's a mesh, and that's what is our, focus area. And then there are so on many other cases, scenarios where you can have a persistent fistula in patients like this. And the ones which are smaller ones are always easy to close, but the ones which are bigger and they are high output, they are very difficult and they will never close at all. One has to intervene rightly and do a good source control as surgeons. And these are the other standard managements of an ECF fistula and medical management. But when you come to specifically intracutaneous fistula and hernia, some nice data about 16 to up to 50% mortality because of sepsis and malnutrition. So as surgeons, we always take this as a backseat. We leave it to other people to take care of the malnutrition, but we need to be there. If you have a high risk patient and if you're operating a patient like this, and there is up to 17% chance of 1 in 5 patient is going to develop a fistula there. Mesh migration is there in about 10% of population. But surprisingly, I saw the data and about 20 to 30% they have reported that they can have a spontaneous closure, which was very difficult for me to understand. But as I told you, the data is very anecdotal because this is a very small problem out of the big spectrum. And when can you not salvage? So if you have a patient who is a smoker with a heavyweight mesh, or you have a PTFE mesh written in your op notes, at the index surgery, or a multifilament mesh, or a patient with MRSA, this patients, it is very, very difficult and you will have to do something very, very actively. So there are 3 pointers. One is an enterotomy at the time of index surgery, an unplanned bowel resection. That means, I was just discussing with a colleague. He went in for an umbilical hernia repair and then they found that the bowel was stuck there. There was a fistula. He had to do a resection anastomosis. So these are unplanned. But what happens with that is you have a 7% high chance that these patients will go up into developing an intracutaneous fistula. So a message for all of us who are Tarzans and eat FRS, be watchful, because the moment you're going to have a scenario like this, you are going to land up in about 7% of cases with a fistula. What are the guiding principles of ECF hernia fistula in general? Source control. We always talk about that. You have a collection. So I was always taught, that try to make an indirect fistula into a direct fistula by putting in some catheter, establish the GI continuity, and either do a staged or, you can do a one-shot repair and try to do whatever it is, a stable AWR repair all the time. Timing of surgery. Very, very interesting to know what happens and how does one time. So this is one paper which was looking into that. And what came out of those papers was, if you try to plan it in the first 3 months, of the patient getting a fistula, then you have about 28% of recurrence, which is very, very interesting. So that means you have to wait more. If you wait for 6 months, then probably you have taken care of the nutrition and sepsis because this is a relatively stable patient. But if you wait for about a year, then what will happen is that this patient is into perfect homeostasis. So probably tells us that this is a way a surgeon has to wait and delay his surgery until you are forced to go ahead and operate these patients. So some of the data coming up, this very interesting study called COBRA study, which looked into use of mesh in a contaminated ventral hernia. And this was by a famous Mike Rosen group. This is a very important paper, which if someone wants to really read, it's from the Todd Henniford group. And this is where they talk about that what should be the optimal management. So they have a huge database of almost about 14, 15 years, which they have assimilated. And what came out of this paper was bowel prep is absolutely mandatory when you're operating a patient of ECF fistula. What they do is when they take up the patient, they temporarily close the fistula with a figure of stitch. What we have done is we slap it on a small piece of betadine and then we cover up with a nice tegaderm. So we isolate that area and then we go there at the last because we do not want to contaminate. Work away from the fistula. That's a principle. So always have a pedicalized approach. So go all around the fistula, work around there and then come back to the fistula. Very interestingly, this is a very important point is partial mesh excision versus total mesh, 4.5 times higher chance. That means an attempt has to be made by a surgeon with the best of the team members that you should try and remove the entire mesh. Otherwise, if you just do a superficial job, then you are making a 5 times higher chance that the patient is going to come back. And then you can do a suture repair, put in a biological mesh, and preferably in his group, they preferred a pre-peritoneal plane. And finally, what they done in all the patients was they just whacked it. That what you do is that once you have done all the surgery and everything, just put a whack and come out because they saw that whenever they did a closure, the patient had again a chance that there was a wound infection. In the review of literature, again, a very interesting study by Dr. Ajita Prabhu and their team when they collaborated this data. 170 patients were pulled into this with fistulas, and they had sublay mesh, a biological or a medium weight polypropylene. So now we can see again from pre-peritoneal, the plane of mesh has changed to subfacial. And we saw Kaufman talking about subplay mesh, where he said that sublay is not good. So see what happens in about 20 years of time, that the data keeps on changing with or without myofascial release. So this is what you should plan whenever you are operating a patient with a EC fistula. But the wound morbidity in all these patients is very, very high. So remember that when you're doing an ECF, you should probably think about WAC as your option, because this is where the patients can have SSOs related to that. Again, another paper where they looked into ECF with AWR versus ECF alone. That means just to do a suture repair, fistula rate about 10%. So even if you do a reconstruction or you don't do a reconstruction, so it's a very skewed data. So at the end of the talk, probably you will feel that whether we should do an AWR, we should not do an AWR. It is relatively the same, because the data is coming from different pockets. So can we prevent a mesh-related ECF? So there is some data which is coming on that as a prevention. So that's where the role of P4HB comes into the picture. This is again a systematic review and a pooled analysis. And P4HB is something which was created by the MIT scientists in 1993. The source is E. coli. It's a monomer. It gets absorbed by hydrolysis and breaks down into CO2 and water. And the beautiful part is that the mesh disappears over a period of time. But when the mesh disappears, we really don't know that whether the strength is going to be adequate or not. But yes, it's definitely going to take care of your fistula. And why? Because of this, again, they mentioned that it demonstrates a bacterial clearance for MRS. And if you saw my first slide, MRS is one of the culprits to keep the fistula patent all the time. So E. coli also is associated with this kind of situation. And this is where it takes care of that. It also prevents colonization. So it has got an ability that the colonization, that means the biofilm formation also doesn't happen if you're going to use a mesh like this over a period of time. And then it keeps the bacteria away. And again, a multicentric trial, which came to a conclusion that it demonstrates that in patients with high risk SSOs, that means you have a patient with diabetes, immunocompromised, again, it's going to be very, very useful. So the long-term results of a mesh like this with P4HB is going to be very, very useful. And there is a good 3 and 5 year data now that if you use this a mesh like this, and now you can select that whether you want to put it in a pre-peritoneal plane or an onlay plane or whatever plane of your choice, you will probably have less chances. So to complete my story of that patient who had a decade-long problem after a lap hernia. So this is what was found on the sigmoidoscopy. And when we injected methylene blue, we found that. So I told my endoscopist that we should tattoo that area so that I can see at the time of surgery. So we typically use an India ink because it doesn't disappear. If you tattoo it with methylene blue, after 12 hours, it is gone. And I said, let's attempt, with a laparoscopic approach. So the patient was a little skeptical. I said, let me do with a laparoscopic approach. What we did interestingly was I always use this fluoro. I call this as a poor man's ICG. So whenever you do not have an ICG, use fluoro. So we marked this and I found this particular tacker. So we marked it with a spinal needle. So I said, this has to come out at the time of surgery. And that's where we reinforced. So this is the fistula of the patient. Just to show a short video. So there was a communication with the sigmoid colon. We could see where the fistula was. I used in a blue cartridge and then disconnected that fistula. Luckily for me, the end of the sigmoid. So on table, we were also ready with a colonoscope. So after I put my stapler before firing, I told my endoscopist, can you put in a scope? And he said, there is no lumen compromise because it's just communicating with one of the walls of the sigmoid colon. So we fired the stapler. And after firing the stapler, then I could disconnect it completely. And once I could disconnect, so this is where you can see that the fistula is getting disconnected. We checked again, and you can see that India ink, which is present there. So I had used this echelon. I reinforced. I said nothing, no taking chance. So this is where the fistula was. So you don't touch, just give me last 30 seconds. So don't touch that area on the top. You keep the fistula on the skin part intact because you don't want to lose on the gas. And then finally you close this with a V-lock suture and then you come out. So this is what was done for this patient. And finally, this is what I brought out. So there were two pieces. So you need to be a little bit more adventurous, get more people on the team. So I had with me another colleague of mine because we have to go into that area where you're with the iliacs, you have to remove that tacker. And this was the culprit, the polyester. A typical mycobacteria was not targeted for last 10 years by anyone. People had put into small groups of AKT. AKT doesn't work in a typical. You have to give drugs which are, and you need to do a radical job is my plea. So anyone who comes in this area and has a patient, please do a complete mesh excision and try to see that you do a radical job at index surgery, because otherwise the patient can become a problem like this. Keep an ID specialist in your team. And this is what the price the patient had to pay. A combination of Lizo, Moxie, Clary for 9 months. There is nothing like 6 weeks and 3 months and treatment. You have to give them radically, at least for 9 months. We have sometimes even gone up to 1 year. Then you do the outside part and remove the skin. So this is where I dress the patients with amikacin, kept the wound open. And that's the final healing of the patient, which you can see at the end of 10 years. But when I thought that I was very proud, that I've done a surgery after 10 years, I found this paper where they have removed after 30 years. After 30 years, there's a fistula. So I said, there are still more senior people and I need to get more gray hair on my scalp. So to end, ladies and gentlemen, mesh and EC fistula, try to attempt complete excision, try to do a tissue repair if you can, a preperitoneal repair if you're an expert, a sublar repair, but please don't jump straight away to an AWR at the time of your ECF surgery, unless you are an expert, because if you're going to do it straight away there, you're going to burn all the possible options. So please don't do that. Get people involved in your team before you're going to venture into that. So AWR and ECF or intracutaneous fistula is not like a everyday horse riding. One needs to be a little bit more expert, a little bit more tuned to knowing things. And then only I think you can do and take up cases like this. Thank you very much for your kind attention. I'll be very happy to take any questions.
Thank you, sir, for that great talk. So I think we can have the panel discussion and then move on to the question answer session from the audience altogether towards the end. So our next session is a panel discussion on the management of intracutaneous and intraatmospheric fistula. For the panel, I would like to invite also Dr. Ramanna and Dr. Vinay Shaw to please join us. Dr. Ramanna is a surgeon with a vivacious personality and has great experience in the management of obesity, complex hernia, and abdominal wall reconstructions. With a surgical career spanning over 30 years, he has traveled across India, conducted workshops, courses, and conferences. He's a pioneer of abdominal wall reconstruction in India and a leading name in the same segment of surgery. Dr. Vinay Shaw is an accomplished, well-trained laparoscopic GI and bariatric surgeon. He has been trained rigorously at AMRI Kolkata, VMMC Safdarjung, and followed by a minimal access fellowship in South Korea. So let's start with our panel. So we'll be discussing the management of intracutaneous and intraatmospheric fistula. So our story starts with a 28-year-old gentleman who presented to us following a laparotomy for blunt abdominal trauma. He had been operated somewhere else where they had done a resection and anastomosis of the ileum. He presented to us on second post-operative day in shock. A CT with oral contrast was done, which showed a leak from the duodenum. And because the patient was hemodynamically unstable, had peritonitis, he was taken up for an emergency laparotomy. And this is what we found. The duodenum was open. There was gangrene of the right colon ileocecal region. We ended up repairing the duodenum, performing a right hemicolectomy with an ileostomy and distal mucus fistula. 12 days into the surgery, this is what happened to the patient. There was enteric discharge from the midline wound. We got a CT with oral contrast done. There was no intra-abdominal leak. Whatever was there was coming out from the main wound. The main wound was open and a wound manager was placed, but the patient bled, became unstable and was taken to OT. And after 4 laparotomies for control of bleeding, this is what happened to the abdominal wound. Finally, after 4 surgeries, the bleeding was controlled. This is what was after the first operation that we had performed, and this is what was after control of bleeding. So my first question here is for Dr. Vinay Shaw. So if this is the abdominal wound of a patient following 10 days after the last surgery, what would we like to do for the patient?
It looks like a very complex wound and a difficult situation to be in. And first, I would like to see the patient's condition, like in such case, I mean, We have to stabilize the patient. There are a lot of, electrolyte and protein loss. So we have to correct that also. So far as the wound is concerned, I will probably say this is a good candidate for a VAC dressing. And is there, that is a pouting, that's the mucosa that.
Yes, sir. So this is what happened to the patient's wound after 10 days following the last leprotomy. The ileal anastomosis probably gave away.
Yeah.
The
So if
bowel is seen floating in the wound. This
Yeah.
is the ileostomy, and this is the colonic fistula.
Okay. This ileum is it's a distal ileum,
So mid-ileum.
mid ileum. So I think it's mid ileum. No matter how much you do, you'll still even if it's a control fistula, and if you look for any intra-abdominal abscess or other sorts of collection intra-abdominally, first you have to ensure that it's a control fistula. If you have an intra-abdominal abscess or other collection, we have to drain it by USG guided drainage or pictal placement and ensure that it is a control fistula. VAC dressing or other things which can be used, like you can have some biofilms over this granulation tissue, and over that you can put a bag or so that it's controlled. The skin and as Dr. Jignesh also mentioned, skin care has to be very much meticulous in this patient. Otherwise, the skin is going to be very difficult to manage.
I would ask Dr. Gandhi and Dr. Ramana to please chip in with this. So I think there are three things, very important things that need to be addressed at this point of time: control of sepsis, wound management, and nutrition for the patient.
Absolutely. The important thing here that I would like to share, which is pretty obvious to someone like yourself, but for the rest who do not work in institutions like this, the most important thing in a management of this kind of complication is that this is not for the occasional surgeon. This patient needs tertiary referral absolutely as an emergency basis. Do not attempt to manage something like this on your own unless you're very experienced in this. This is not the kind of case you want to get experienced with as an independent practitioner. So apart from this, a full multidisciplinary team would be needed to take the patient out through the crisis, and it's extremely labor intensive. If you manage patients like this, you know that you need people around this patient literally 24/7. Of course, having wound managers and VACs has made our lives much easier. Previously, our dressings used to be nightmarish, and I remember in the early 2000s, I learned a technique of kind of whacking it using baby feeding bottles and nipples, and then connecting the proximal lumen to the distal lumen so that you don't lose more fluid, electrolytes, and proteins, and you refeed it through the distal opening. It's still a valid, I think, approach, that you don't lose succus entericus as much as possible. And directly connecting the VAC is something I'm not very happy with, because I think you can have more fistulae coming up, and that's going to be a nightmare. So there are specialized techniques of covering the wound with foam and a non-adhesive barrier, and then applying ostomy bags specifically to the pouting mucosa.
I think most of things are covered. Only two things, at Diksha, what we have been doing at our center and we're going to publish now is never do a distal mucous fistula. It's a complete waste of the bowel. So what we have started doing is we close, staple, and we put in a feeding tube. And I can tell you, even if you have about 2 or 3 or 4 feet of bowel, it's going to be worth this, because your enterocytes will be alive. Your enterocytes are alive and a patient will do very well. So use the distal bowel in an ischemic bowel by using it into a feeding tube. So that's what we do. We don't create a distal mucous fistula. I've already mentioned about that. So Apthera is one of the dressings which are available now. So local control and systemic control. Always try to cover, make indirect fistula into a direct fistula. And in patients like this, obviously, there is a role emerging now of putting in a vicryl mesh to cover up most of the wounds which is granulating. And the time period from the vicryl mesh to putting a skin graft over it is usually in the literature. Now there's a paper come out which talks about around 4 to 6 weeks. You can go and put in a split thickness graft. So what happens is you tend to contract the wound. So, it's good to give a patient a life and then do the rest of it later.
But vicryl mesh is inflammatory. Why would you want to inflame more exposed
No,
serocytes?
it is, to avoid more atmospheric fistulas, because otherwise the rest of the areas which are there, you will see more popping out of mucosas there soon. So it's just as a
This
cover.
is
It is a cover.
not a definitive settled issue, but I would say that a lot of experts would dispute that and not want vicryl mesh on bowel, or even to bridge peritoneal gaps with vicryl when you have a bowel resection or inflamed bowel underneath, because vicryl is very inflammatory and can trigger adhesions and fistulas.
Yeah, I'm just quoting about from the paper. I have not personally used it, but there are centers which have started using it, and also you can put in a mesh. But obviously, when things are much settled down, but these are the options because the rest of the wound will have more pouting mucosa.
Right. So what we did for this patient, we got a CT scan done, made sure there were no undrained collections. We managed the wound initially with dressings, followed by a wound bag, so that we could protect the surrounding skin so that it could be used for reconstruction whenever the time came. This is what was of the patient 8 months down the line. We had established feeding. We had put in a feeding tube from the distal most fistulous opening. Also, there is a feeding tube in the colon. So water was given and saline feeds were given via the colon so that some water reabsorption would happen. So what is your take on nutritional supplementation in these patients? Would you keep the patient nearby mouth in the initial setting, and when would you like to start with enteral feeding?
I feel enteral feeding is the key in these patients, and TPN has its own complications of cardiopulmonary issues are always there, and it's costly, and never control it. I mean, enteral feeding is always better, and I can see a beautiful pouting distal mucosa as well. So to maintain the electrolyte imbalance, what we can do a refeeding, we can sieve it, and we can add some formula protein feeds with it, and you can use the distal loop as for feeding. Less of the nutritional calorie goal can be given by oral output, unless and until the patient, because you have already managed the critical catabolic state. Now is the anabolic state. There is no role of, I think, TPN in this patient.
Yes, so that's what we do. We initially manage the patient with a nil by mouth status for the initial few days, start him or her on a parenteral nutritional support. And once the fistula starts maturing, we try and put in attempt fistula crisis, put in a feeding catheter into the distal most fistulous opening, confirm that with a CT or a contrast study, and start feeding the patient. When would you orally allow the patient for diet?
So,
Yeah, please.
so just to sum up the previous part, because we surgeons are very poor at nutrition part, it should be TPN followed by PPN followed by EN. Very easy to remember. So TPN, then partial parenteral nutrition, and then enteral nutrition. Because if you follow this algorithm, then things are much faster. Yes, sir, you can continue.
Yes, I agree with you. No problem. So early, when the patient is not, if you see, it's just to maintain the calorie goal. You need a good high protein requirement. This patient will require more than normal require, maybe around 1.5 grams protein per day, or maybe the calorie goal is higher initially when they're in the catabolic phase. But now in this patient, the catabolic phase is already over. So I don't think this patient will require TPN, and enteral formula feeds can be well tolerated. Especially unless and until if you are still having a very high fistula, like 2 liters, 1500 ml, then definitely there are a lot of protein losses, then you can think of like that. But having said that, looking at the patient, I feel he has now resolved the crisis, and now it's better to tolerate the oral feeds.
Yes. So this was the patient status 8th month following the last surgery. He had gained weight. He was taking a normal oral diet. We were completing his caloric requirement using a fistula crisis catheter. His albumin was 3.8. Dr. Ramanna, sir, when would you like to plan surgery for this patient, and what would be the principles in planning an operation when we go ahead and do it?
I think, just off the top of my head, I would blindly say, I'm not going to touch this patient before 1 year at least, and as long away from this catastrophic period as possible. So one of the markers of well-being is obviously, stuff like albumin and ferritin, transferrin, and all that. But overall, the catabolic stage has to be seen through. Nutritionally and sepsis-wise, the patient is optimized. Now, that part is the difficult part, and that's taken care of. Let's assume that you've done a splendid job. Now, the patient is actually waiting for the surgery. Now, we have to keep this in mind, that this has to be almost the last major operation for this patient, and there are no minor operations here. So, you can genuinely screw up all the good that has been done so far if you do an enterotomy again, or if your mesh gets infected, or if you don't manage to close the peritoneum PRX complex, or anything else for that matter. So I would not look at the calendar per se, other than saying 1 year is the minimum time I would take. And I would take whatever time is necessary to garner the most formidable team possible to help this patient.
So what would be your aspects of planning surgery in a patient?
Yeah, so you saw in my talk, that slide which I put about the calendar. So
Right.
waiting for a year is a good time. Establishing GI continuity, keep a team in place so that you can have a repair done. As I told you, it could be a single stage or a staged repair. And then the choice of mesh. Today, one should probably think about either a biological or a biosynthetic mesh, which talked about, and the plane of the mesh, as far as the evidence goes today, is preperitoneal or subfacial. So you can put in a retromuscular or a preperitoneal mesh in a situation like this. Having said that, it is not to be used as a bridge repair. It has to be a reinforcement. So it's a challenging scenario. It changes case to case basis. And now with the advent of a new technology called fasciotens, which I don't know how many of you are aware of. So there's a technology where these kind of patients, probably you can think about that, where you can do a primary closure, because the idea is the skin has to get closed. If you don't close a skin at any point in time, you are into trouble. And finally, the wound which is left over, I'll whack it.
So I'll just add 2 points here. One is, fasciotens in open abdomen management is showing absolutely stunning results, but it's extremely expensive. It's not yet available in India, and we'll hopefully find a way to bring it in. But it's even in Europe and elsewhere, the cost is prohibitive. So very few people are going to be able to afford it. And there is no evidence today to say that one mesh or the other is better than plain old synthetic polypropylene in the extraperitoneal spaces after complex reconstruction like this. So I would just use macroporous polypropylene after AWR.
The only thing I'd like to, first I'll be more interested in restoration of the guts continuity first, and then I'll have to think of the hernia and mesh later.
Yes.
Because as a hernia surgeon, our senior surgeons are really looking after the hernia aspect. But as far as my concern is concerned, first I'll ensure that hernia is on a back seat right now, and the restoration of the gut continues to be priority. And I think waiting more and that should be a priority.
Priority is good, but the abdominal wall integrity is also crucial to protection of the organs as well.
Absolutely. So I believe at this point, there are 3 important principles: the right time for surgery for the patient, defining the anatomy with respect to both the gut and the hernial defect which needs to be addressed, and planning the surgery correctly. So with respect to the gut continuity and abdominal wall closure, I think both and all of these tenets are important. So this was what the patient's anatomy looked like. There was a leak from the duodenum. There was a segment of bowel between the gastrojejunostomy and the ileal fistula. There was a segment of bowel between the ileal fistula and the ileostomy, via which we were refeeding. And there was a segment of colon, which was on the left side following the right hemicolectomy. And all of these areas had to be addressed.
So this is where I was talking about, use a distal gut, put in a feeding tube next time, you should probably not use a mucous fistula. And one more thing is we've seen drying of secretions. I don't know how many of you have used, but octreotide in the strength of 20 milligrams or 30 milligrams as single bolus. I'm talking about milligrams and not micrograms. There is a good evidence that it works well in fistulas like this in the initial space when you are using a TPN.
Okay.
Octreotide 20 or 30 milligrams, single shot intramuscular.
Dr. Ramanna, what would be the important principles of planning abdominal wall closure in a patient like this?
The crucial thing, I think, is going to be, once again, surgical team experience and expertise. So do the repair that you are best at. So this picture is an excellent one. It's a great indication for an anterior component separation. If you know how to do it, then this is a very good way to do it even without using a mesh. Normally, we wouldn't recommend doing component separations without mesh, but this would be one such situation where it is acceptable to just close the midline fascia and not put in a mesh because you're worried or the patient refuses. It could be some indication or the other. So the basic principle is to provide peritoneal cover using native tissue. So typically we wouldn't have much omentum left, but if you're able to mobilize the peritoneum well and you can close the peritoneum completely, that's the best way. That's the best tissue or prosthetic material for peritoneal closure, peritoneum itself. And you try to close the midline, and here I would say it's a good idea to use Botox. So you want to avoid doing a complex AWR, then use Botox. And if we can get fasciotens down the line, then that would be a good way to avoid a complex AWR. Otherwise, an open preperitoneal repair is very difficult. Most people have not even seen one, let alone knowing how to do it well. So I would say for most people, the answer would be either an anterior component separation or a bilateral TAR.
Right. Let's go back to this image. I just want to point out over here that although the wound has shrunk a lot, there is a lot of atrophic skin around the main wound. And we must keep in mind that this is the skin that we are ultimately going to lose when we plan surgery. Now, this may be the scenario sometimes when we are unable to get a closure at all of the skin or the fascia. So what is your experience with the bridging mesh in a scenario like this?
This is going to be a situation where you call for a plastic reconstructive surgeon. So in a complex reconstruction with exposed mesh, I'm definitely not happy leaving this open and putting a VAC or whatever it is. I'm just not okay with it because you don't want the mesh to be explanted later because it got infected. So what I would do is with the plastic surgeon, we would plan the case and consider something like an anterolateral thigh flap. So this is a very useful flap in midline soft tissue and skin deficits. And I think bringing in a plastic surgeon is of paramount importance.
That's a very important point made here by Dr. Ramanna. It's important to involve plastic surgery where they can help. Unfortunately, for this patient, he had a blast injury and he had lost a lot of skin, if we can see from the right anterior aspect, laterally, abdominal wall, and from the thighs. So this would be the best case scenario. We've closed the fascia, we've had a primary closure of the skin. But what is your experience with VAC, sir, with negative pressure therapy, if a mesh is being placed and if the skin cannot be closed primarily?
So I don't see any reason why you want to put in a mesh if you're going to whack it, because in the scenario that you showed, probably a polypropylene mesh in that space is not going to work at all. It might come as a
space was the mesh placed? Onlay?
Onlay.
Yeah, they put in an onlay.
Oh, okay.
So probably I would not place the mesh in the first place, but the VAC has got definitely good promising results. So probably in the scenario which you showed earlier, I would probably directly put in a VAC. Normally they would go on for about 6 to 8 settings until we start getting good granulation tissue coming up. And then you can continue with your normal dressings. And one thing again, which works very well, Dr. Adarsh is also aware about, is ointment which has got platelet-derived growth factor. So that is one cream which we use in patients like this. I can tell you the results of granulation tissue are fantastic with that. It's been a trial which we have already published in 2006. It's a platelet-derived growth factor. So you can use that for topical application unless you come to a situation like this. So VAC and PDGF.
Yes. Actually, there is some evidence now stating that if at all a mesh is placed, probably a delayed primary can be done by repeatedly using VAC so that the chances of surgical site infection and mesh explantation eventually are decreased. Moving on to the next case, we have a 48-year-old lady who underwent a laparoscopic intraperitoneal onlay mesh repair for a ventral hernia. She came to us 8 months following her index surgery, where she complained of repeated episodes of fever, pain, and foul smelling discharge from the midline wound. Eventually that got converted into an enteric leak from the mainline wound, and this was the CT that was performed, which showed communication with the small intestine. 8 months following the surgery, following the index surgery, when we took her up for an exploration, there was a communication with the small intestine of the infected mesh. So although Dr. Jignesh has already discussed all of these parameters in his previous talk, but I'd like to reinforce again here. So if there is a fistula with the mesh, what would be the tenets of managing such a patient?
So as I told you, try to convert indirect fistula into a direct fistula. This was a direct fistula, so we are lucky. But if it's an indirect fistula, probably I'll drain that cavity, put in a drain and try to make it into a direct fistula. Having said that, the message here for everyone is very clear that even composite mesh can land up into a fistula. So it is not only about we keep on blaming the polypropylene, even composite can cause that. And then you have the pedicalized approach, which you have rightly shown here, either laparoscopic or open, depending on your expertise. But we've done cases where we've even gone with laparoscopic approach, gone all around it, and then just the pedicle, and then put in a stapler and come out. So this is one of the ways of managing such patients.
So we wait for the fistula to dry.
Absolutely.
We try and as far as possible remove all the mesh that is possible.
It has to be a complete mesh excision, otherwise 5 times higher chance. So remember, when you're doing an ECF, take people with you. Don't do it as a standalone surgeon because the complete mesh has to come out.
And how would you close a defect like this? Would it be a primary closure?
Yeah, so this here in this patient, obviously primary closure would come up very comfortably. And as Dr. Raman has rightly pointed out today, anterior component separation, because you don't want to burn all the bridges, probably would be a good option. There are trials, what he mentioned about is medium well polypropylene is as good as a biological or a biosynthetic in scenarios like this. If you are an established AWR surgeon, then you would do a single stage. If you're not confident, you can do it as 2-staged.
Right. So this is what was done for the patient. The entire mesh was removed. We can see that there was a segment of bubble over here along with the infected mesh. We tried and found out all the segments or the islands of mesh that were lying elsewhere, and they were all excised completely. And we closed the abdomen primarily without a mesh.
Did you send it for histopathology? Could you make out what material it is?
Sorry?
What material it was? So plea to everyone here, because now we're going to start with the hernia registry soon at AWR. Start expanding this mesh and send it for histopathology, because it's very interesting to go and see the slides of what actually happens to the mesh. And by and large, looking at this mesh, I think it looks like a polyester mesh to me. So I'm a little skeptical about using in a polyester composite. So explant, histopath, and a typical mycobacteria to be ruled out.
Right. So just a take-home message from all of our panelists here. One message that all of you would like to give to the audience in managing complex intracutaneous and enteroatmospheric fistula. So what would be your message?
We can start with you.
I think I've already said what I did. This is a tertiary referral issue. Do not do this unless you are very well trained and exposed in handling these cases. And if you handle it, try not to do more harm, because there is a real danger of creating more complications, and you better be extremely sure about your outcomes.
Dr. Vinay?
I always feel that in such type of patient, if the patient, the main idea will be the source control. Always you have to have a good source control. The main idea, in GI, if the patient is eating well and is passing motion, most of the time he will come out. And then we can always defer and buy time for the definitive patient.
I think they've already said most important is we surgeons are very poor at knowing about nutrition. I have myself taken a keen interest, so I read about it a lot. Please take care of the nutrition of this patient, because whatever you do, ultimately when the patient comes on the table, don't chase the albumin. Albumin is just a surrogate marker. You need to see that your patient is up and about. Only then take up these patients, and not to forget, Diksha, that these are huge financial burdens to the patients. So psychological counseling of the relatives and patients are very important, because the treatment can go into lakhs at the end of 1 year. Thank you.
Thank you so much. So just if to summarize in one line, we need to be as patient as possible with the patient. So lots of waiting. Like Dr. Gandhi said, a lot of psychological support. We make sure sepsis is abated. We define the anatomy and plan the surgery with respect to restoration of the gut continuity and abdominal wall reconstruction. As far as possible, 1-stage reconstruction and closure of the fascia and skin, depending on the availability, vis-a-vis primary closure or WAC. Thank you so much.
Thank you.
If you want to sum up in one line, then I would probably say snap the fistula and whack the wound. Yeah, thank you.
Super. That's the end line.
Thank you. Very, very nice cases and very well done. Thank you very much.
Okay. So let's move on with the next session. Our session 2 is on optimization techniques. When are they really needed? Our first speaker is Dr. Ramanna, and his topic is loss of domain. Is there a good way to measure it and plan your surgery? The session after this will be by Dr. Ramesh Punjani on Botox and PPP techniques and their application, followed by the third talk by Dr. Chaudhary on preventing incisional hernia in GI surgery practice, a special technique or basic principle. I would request all the 3 speakers to please come on stage. Sorry.
Thanks. Morning, everyone. And I think a few weeks back, I looked at the program and I told Vikas that this was an exceptionally good program. And I'm very excited to be here because I'm sure that I'm going to learn a ton of material today. So my topic is on loss of domain. And we actually, last November 2021, we did a global summit on the subject where we had more than 10,000 surgeons across the world attending it. And the deliberations constitute probably around 16 hours of education. So I have probably 15 minutes, and you can well understand that I'm not going to be able to do any kind of justice to the subject. So it's a great privilege to be part of this community, and let's basically give you an outline of what I'm going to do. I'm going to talk of the definitions, what are the risks of loss of domain, how do you optimize, and what are the surgical approaches. Each of these is a major topic in itself, but I will try to give an outline of a practical guidance based on my travels throughout the country and seeing practice in various centers and with various surgeons. So when we define loss of domain, it's very important. You see a large hernia and you call it loss of domain. On what basis do you call it? So some people say, oh, it's a big hernia. The South Americans had a term for it, catastrophic hernias with an F instead of a PH. So giant hernias, catastrophic hernias, or hernias with loss of domain. Just a big hernia, is it loss of domain? So that could be just a simple definition, which is not really accurate. Or you could have a proper scientific definition, which becomes too complex. Let's explore this topic. So there are 2 papers, both by the first author was Sam Parker, and both these papers, one is a systematic review and the second is a Delphi consensus of the experts. These are very, very well cited papers on the subject. They agreed that LOD means 1, it's a big, big hernia, the biggest you have seen. 2, it is irreducible, important. If it reduces on lying down, it's not LOD, because the domain then is reclaimed by the contents. 3, if you want to close the gap primarily, you will have intra-abdominal hypertension and compartment syndrome. And lastly, it needs complex abdominal wall reconstruction. So these are the 4 criteria to define, or that define LOD. The problem with the Delphi consensus is that they didn't bother to call any one of us in this room or people in the entire
Southern Hemisphere almost, no one from Africa, no one from Asia Pacific. So their patient demographics and our patient demographics do not match, right? So that is one big drawback. Can we take those definitions to our patient populations? That's an open question. That definition is too complex for most surgeons, only for AWR experts. When you're comparing apples to apples in scientific papers, only then that's going to be useful. For most surgeons, it's not useful, which is why in practice, what do? People look at the CT scan, they'll say, oh, Tanaka index is 30%. So this is LOD. So that's how people simplify a complex subject. And anyhow, we won't discuss this paper any further. We will talk about the major elephant in the room, which is the intra-abdominal pressure. We diagnose loss of domain and the risk of raised intra-abdominal pressures, abdominal compartment syndrome, because we see that the bladder pressures, which we measure by connecting a manometer to the Foley's catheter, they are more than 20 millimeters of mercury in an intubated, ventilated patient. That is our definition of abdominal compartment syndrome or intra-abdominal hypertension, right? Now, the elephant in the room is that this entire hypothesis may be wrong. And this is a recent small study on 9 trauma patients by Samir Jona, and they found that the actual intraperitoneal pressures and the intravesical pressures just do not match. So are we looking at a complete redefinition of ACS? It's a very, very important topic, but we don't know any better today. So many cowboys would say, oh, this is a big hernia, let's do it, let's operate. I was one such at one point of time, fortunately long forgotten. But we have to understand that we should not do something like this. So this is crucial for any young surgeon in this room to understand that LOD patients have a special risk profile. And if you operate on LOD patients without due regard to those risks, you're going to have a patient on ventilation or patient actually fighting for her life. So what are these high-risk situations? Patient has had a previous mesh infection. Yes, it is an important point. The rest are pretty obvious, you know, the usual profiles, stereotypes, immunosuppressed, diabetics, people with low albumin, the obese, and importantly, patients who have lean muscle mass loss. So weight loss in the last 6 months is an important question to ask in the history. Those who have had previous hernia surgery, which is going to be pretty much everybody. Smokers, and these are things which you all know, elderly patients, and importantly, people coming to high volume centers have higher risks because obviously they're more complex. The highest risk comes from 3 categories of patients. If you handle an LOD with obstruction strangulation, or the patient has ascites, and the patient has a DNR, do not resuscitate order, which is pretty common in the Western world, but increasingly common in some of our urban patients. Patient who has already said, do not resuscitate if I go on a ventilator. I don't want to go on a ventilator. So that kind of patient will constitute the highest risk for LOD surgery. And I will, you know, at some point, if given a chance, I'll give you a 20-minute talk on frailty in AWR, but that's not today. Now, in order to have a broader understanding of the subject, I would like to introduce you to the concept of the triangle of outcomes, wherein every AWR patient is part of a triangle constituted by the hernia defect itself and the surgeon. 3 components which make for either good outcomes or bad outcomes. So if the patient is frail, if the hernia is big, and if the surgeon is inexpert, you have a catastrophe waiting to happen. It's not if, but when. On the other hand, if you have an optimized patient an optimized abdominal wall, Ramesh will talk about Botox, etc., and you have an expert team, then you have good outcomes. Now remember, this is three sides to the problem. So any one side is weak is going to affect or put a dent on your triangle. So optimizing the LOD patient is pretty standardized in terms of the headers: weight loss, nutrition support, diabetes, smoking cessation, treat infections like nasal Staph aureus or mesh infection for that matter, and pulmonary prehabilitation. So everyone of you know about all this. Now, what is important is to put this into practical action by building an MDT. The multidisciplinary team for optimizing an LOD patient needs a myriad specialists, not just the pulmonologist and cardiologist and endocrinologist for managing the diabetes, but you also need a stoma therapist, a physiotherapist. You may even need a psychiatrist, because many of these patients are in severe depression after multiple failed surgeries. And of course, weight loss is an important issue. So you would need a bariatric surgeon and a dietitian, etc., etc. An ID specialist is another one. But in practice, when you are actually ready to take up these cases, you also need some more people to assist you. So you need your hospital's insurance desk to make sure that the patient's treatment costs are borne by insurance. You would need suitable meshes, and not many hospitals have a ready-made stock in the OR every time. So you would need to make sure that the mesh that you want, the sizes that you want, are ready in the OR. So you would need to go out of your way and arrange for it. You will be busy through the day in the OR, but the patient may come out and the patient's relatives would get extremely nervous, anxious, and even angry. So you better have somebody, I'm going to take a little more time, I'm sorry, like a family doctor to interface with the patient. And other things like patient's family, your own family, and the entire surgical community are going to be very, very important in you handling an LOD case well. So practical nuggets in LOD management are, to sum up in one slide, is going to be weight and weight. These are the two most important things that I would say. So in terms of weight loss, you know that bariatric surgery, intragastric balloon, medically supervised weight loss, along with, take this chance to improve the aerobic conditioning and the lean muscle mass. So these are things which lead to good outcomes. The patient's diabetes management obviously is important, and you would also get good results if you help the patient to lose weight with the rest of your team. Non-smokers only, but at least give it 4 weeks. So again, while you're waiting for those 4 weeks, push pulmonary rehab, push it very hard, very hard. I cannot stress this enough. And Dr. Chaudhary will talk on nutrition. I'm really looking forward to that and not going to touch anything on it. I'll just give you a very short story on atypical mycobacterial infections after previous hernia surgeries. And this is from one of our friends and colleagues, where a patient had an IPOM done somewhere 2 years back. Patient came back with sinuses. The mesh was explanted, and subsequently, in 1 year's time, open TAR was done. Okay, so this was the initial story. The post-TAR, the patient had sinuses. The wound was opened up, lavaged, and VAC was instituted. And this is the second session of VAC. And after 3 sessions, the wound was closed and drained. The patient comes back at 3 months with sinus recurrence and multiple sinuses. So ultimately, after 4 or 5 sinuses came, the mesh was explanted. You see the PRS is fibrosed and well, and the entire mesh had to be explanted. But the patient is now an AW disaster, right? So in this kind of situation, I would say wait for 2 years before major AWR. So now that you have the patient ready for AWR, you still have to consider one thing. You should see whether you have an SICU backup, whether you're a well-trained surgeon for handling the case and the complications, and whether you have a co-surgeon, that's a very important consideration. What is your OR setup? Does your OR setup have these things? Just check. Every one of these is important, including a fluid warmer. Many people do not know that a fluid warmer is going to save the patient's life, especially when hypothermia occurs. And amongst the checklists, a plan B is very, very important. A plan B for any catastrophic complication intraoperatively, you need to have an answer for every one of these things. Now, which operation? Is there a logical algorithm? So I would say that open TAR is the go-to procedure for most people, but there are questions here. I'm just going to leave you with these because I'm going to wrap it up. And peritoneal flap is often a good idea in a frail patient. And you also have the extraperitoneal repairs, which are less known. There are some papers which serious hernia surgeons should read. And so I have listed a few of them. Whatever I have said so far is based on not just practical experience, but also about a study of the literature. So I recommend that you take these 2 slides into your phone so that you can go back and look it up when you need. The final point to note when you're doing AWR in a loss of domain case is that there is no turning back. It is either your credit or your disaster. You cannot escape. You have nowhere to hide after you take up this case. So thank you very much. And please be part of the AWR surgeons community. And we would love to have you. And once again, thank you, Vikas. Thank you, Professor Chaudhary. Sorry for taking too much time. I needed more actually.
That's a problem of knowing too much. Have the questions later, Diksha? And the end, yeah, that's right, that's right. Come
Thank you,
here.
Dr. Ramanna, for the talk. So you could please join there. The next speaker is Dr. Ramesh Punjani. His talk is on Botox and progressive preoperative pneumoperitoneum technique for loss of domain hernia. He's the managing director at Pooja Nursing Home, Mumbai, and also associated with Fortis Hospital, Jupiter Hospital, and Breach Candy Hospital. He's the chairman of Hernia Board and IAGES, and the president of Abdominal Wall Reconstruction Surgeons Community. So all to you. Thank you.
Fine, my topic is pretty technical and I would like to remain in the time frame. So Botox and PPP technique and their applications. No problem. लैपटॉप में काम कहीं प्रॉब्लम क्या हो रहा है नहीं उधर नहीं है उधर नहीं डॉक्टर काम उधर नहीं है ये प्रॉब्लम है कि ये प्रॉब्लम है तो दूसरा
Hello. While Dr. Punjani is setting up, if you have a audience question for Dr. Ramanna on his talk, we could take that.
Are there any questions, Dr. Ramanna, we can use this time?
Yeah.
Can I ask you a dumb question? What percentage of patients have actually loss of domain by exact definition? If it's post-operative hernias, roughly what percentage of patients will have loss of domain by definition?
I don't know. I think probably it would be somewhere between 1 and 5%, depending on your particular hospital and the community you practice in.
Yeah, sure.
So the definition of loss of domain is not only clinical, it's also radiological or vice versa. So if you use the Sabbag or the Tanaka index, you would say that, okay, 25% of the volume is in the hernia sac, then that is loss of domain. But that's only one criteria. It has to be clinically, you have to see that it is irreducible, it's a large hernia, and you know that you cannot close the fascia primarily without risking abdominal compartment syndrome, and that you need AWR.
Please.
Yeah, so I think I'll start with my talk. It's a Botox technique and progressive pneumoperitoneum and its application. So I bring greetings from Mumbai. So ventral hernia with LOD, just now you was asking, but if you see there is one paper which is quoted as 21% of large hernias are LODs. So I think it depends upon how complex hernias you see, but quite a lot of patients have an LOD. And this is 21% of about cases. This is in that particular journal, and it causes systemic consequences, and we saw that. But there are certain physiological problems like inspiratory and expiratory restrictions, difficulty in defecating, difficulty in bladder, detrusor muscle dysfunction, and low back pain. So these are all added besides what we saw, the horrendous things of abdominal compartment syndrome. And locally also what happens is there is a shortening of the abdominal wall muscles. Now that is why actually you need to do something on the abdominal muscles before you plan an AWR. A loss of visceral protection, and therefore there can be a fistulization, which we saw it eventually happens in these people, or a decreased venous and lymphatic return leading to an ulceration like this on the abdominal wall. So the loss of domain is something like this, which today morning when I was trying to shirt, and that's why I've just put a jacket to cover it. But when you have too much of an abdomen or too much of content inside, this is what can happen. And if it is in a gunny bag, it can tear. But what happens in the abdomen is a disaster, because you have closed the abdomen tightly, and now the contents are going to press on the inferior vena cava, on the gut circulation, on the renal circulation, and that's what we call it abdominal compartment syndrome. And I think this is what Ramana was trying to say, that if it is when there is a grade 4, that means more than 25 millimeters of mercury intra-abdominal pressure, then we lead to a disaster of abdominal compartment syndrome. So we need a preoperative optimization. So one of them is a Botox injections, which is a chemical component separation, and the second is a progressive pneumoperitoneum. Now what Botox exactly does it is that it is injected preoperatively into the lateral abdominal oblique muscles, and it provides temporary flaccid paralysis of the musculature. And therefore this paralyzed muscles then can be approximated without creating a tension. So that's the main thing. And in a progressive pneumoperitoneum, it is intermittent insufflation of the peritoneal cavity, and that elongates the contracted oblique muscles and eventually make a space for a contents to go in. So these are the two important things that are done. So on a Botox, basically Kekmek was the first person who actually thought of using Botox. Before that, the Botox was used more for a cosmetic and the other indications. And what he did is that he actually took a rat. It was a experimental animal study, and he injected a saline inside till it could no longer saline could be put in the cavity, the abdominal cavity of rat. And then he injected Botox at this thing. And then he found that he could now put more amount of saline. So he was trying to say that with the Botox, you can actually increase the intra-abdominal volume. So this was the first ever study. And thereafter, there are various studies. So these are about 6 studies done of what more than 1,000 patients. And they have all realized that what is most important is that it leads to primary closure of almost 100% of patients. So if you use a Botox, you can practically close the midline in almost all the patients. And the recurrence is also reduced drastically. So I think that is where the role of Botox comes, is that you are going to reduce the recurrences. So this is exactly how it is done. So basically this is the Botox, which is from one of the companies. It is being, that trade name is a Botox, and we use normally about 300 units. Now it's a neurotoxic protein, which is produced by Clostridium botulinum. And what it does is it blocks the transmission temporarily. And this is exactly at the synaptic level. And it has got an excellent safety profile. So that's what it makes it feasible to be used. And it causes temporary paralyzing effect, which starts within 2 weeks and it starts fading away in 2.5 months. So this is the time period in which you have to catch the patient. So you plan your surgery, inject Botox, and about 3, 4, 5 weeks time, that is the time when actually you operate, you will get a maximum advantage of Botox. How exactly it is done? So basically the patient is put in lateral position with the arm extended. This increases the distance between anterior superior iliac spine and the costal margin. So this is how it is done. So you can see costal margin and the anterior superior iliac spine, and then you make a 3 points in the center. So that is where you're going to inject, and it's in lateral position on each side. So you're going to inject 3 points on the right side and 3 points on the left side. And this is exactly how it is done. So this is done under a sono guided. So this is where I'm injecting the diluted Botox 300 units, and the sonologist is trying to show me where the external oblique, where the internal oblique, where the transverse abdominis, and that is how we actually inject it. So 3 layers of the lateral abdominal wall, all 3 muscles are injected. They are identified and diluted solution is injected. And this is one study where he has talked about the selective administration. So what he says is that you don't inject in transverse abdominis, inject only in external internal oblique. And his point is this, that it will cause the transverse abdominis causes is an integral part of abdominal truncal stability. And therefore he said there is no need of even a TAR. What you do is that in a patient where you inject Botox, many of them you can actually avoid component separation. The PPP, there is one very good paper which has just appeared. It's a systemic review. See, the progressive pneumoperitoneum is an excellent technique, and I've done plenty of times. But somehow there is a lot of fear in patients' mind, people's mind, doctors' mind, that it is a very dangerous procedure. So somebody actually went through the entire literature, and this is summary of it, where this was first time used in pulmonary tuberculosis. So people who had a cavity which was not healing, what they did is they did a pneumoperitoneum, and that collapsed the cavity. And because it remained collapsed, then it would start healing. So this was the first time that was done. But first time it was done in the by the Ivan Moreno. This was done somewhere in the 1947. Okay, so how does it work? It's gone from here. No, it's not. It's an adapter which is. क्या हो गया? इधर प्रॉब्लम. ये फुल स्क्रीन होना चाहिए ना. Yeah, just look there. Okay, fine. So how does it work? It actually causes a soft tissue elongation, allowing tension-free abdominal wall closure, and it acclimatizes the diaphragm. I think that is the most important role of it, that it increases the diaphragm get acclimatized to the increased intra-abdominal pressure, and that leads to an efficiency of the respiratory muscle. So it works at a multimodal level, and eventually that is something which I think it works even better than Botox. The procedure, it goes like this. Usually it's done in a people who have got an LOD. A relative indication would be a large hernia. So again, we don't know, but even large hernias, the people have used it even for 7 and 8 centimeter hernia and avoided component separation. The procedure is placement of a catheter, which is usually either anatomical, that is going layer by layer, or an image guided, or by the laparoscopy. That's what I normally do it. And a patient is put on low molecular weight heparin because they have a very high chance of thromboembolism. So this is something which is absolutely important. And a progressive insufflation continued daily or second daily for almost 7 to 10 days, either inpatient or outpatient. So I typically don't admit the patient for a reason that I want them to move. So they come every day for injection to the theater, and then they go back, and again they come next day. So this is how I do it, is that after about 3 to 4 weeks of Botox, I first put in a 5 mm telescope at a very safe point looking at the CT, and just I don't try to do anything, just stretch the abdomen under anesthesia. And once that is done, then you insert the catheter through the same 5 mm port. You can use any of those peritoneal catheters or even a Rice tube and fix it well so that there is no surgical emphysema. And then you start injecting it every day. So I call them every day to the theater, and I just put an abdominal belt and start injecting by a 50 cc syringe. So in the multiples of 50 cc of atmospheric air, you start with about a liter, and then you keep on extending about 200-300 cc every day. And these patients are then, the air is not evacuated. They are made to sit down, and then they are made to walk. And after about half an hour, 1 hour, they can go back to the home. So this is not a very pleasant experience for patient, but it does help them. This is an everyday on OPD basis. Atmospheric air is injected, abdominal belt is tight, and you stop it when there is a severe shoulder pain the patient cannot tolerate anymore, and then they are sent back. Now, what are the complications of PPP? I think that's very important, where the fear lies. So the Gonde Marino, when he did his first 300 cases, he said there were not reported any complication. And he says whatever discomfort, that is a part of the procedure, and that usually takes does not become very severe. There is one study of 53 publication over 1,000 patients. And what they found is that 12% experience some adverse effects like a minor shoulder or abdominal pain, subcutaneous emphysema and dyspnea, but none of them had a very major problem. That there are 3 real procedure related mortality out of 1,200 patients, out of which 1 was pulmonary mycetoma and 2 were respiratory insufficiency. So one thing is very true, that people who are respiratory crippled, you should not do this kind of procedures. So I think if you take that care, it is almost certain that it works. And this is the how when the PPPs do. This is one good algorithm which has been given. So there are a complication, but all of them are actually can be avoided by taking an adequate measure. So thank you so much.
Thank you, Dr. Panjani, for that talk. Now I'm going to attempt the audacity to introduce someone who needs no introduction, a great mentor, boss, and chairman of the Department of GI Surgery, GI Oncology, Minimal Access and Bariatric Surgery here at Medanta. Dr. Adarsh Chaudhary is also credited to have established the first GI surgery department at GB Pant Hospital. If I'm going to enlist all his awards and honors, the time for the conference will get consumed. So handing over the mic for his talk on preventing incisional hernias in GI surgery practice. Thank you.
We all know that incisional hernias occur after laparotomy. The reported incidence of incisional hernia is about 6 to 40%. And such wide range exists because it depends on the duration of follow-up and what do you label as incisional hernia. A symptomatic patient or a patient even who presents as a hernia on a CT scan. For everything to succeed, we need to have an aim. And like the Zen archery shows, that aiming is everything. If your aims are correct, you reach your targets. And for all surgeons who are doing laparotomy, the aim of having an incisional hernia is an incisional hernia rate of less than 10%. When we analyzed our data of patients who underwent GI surgical procedures of magnitude like pancreatic duodenectomy or gastrectomy, you see we have failed in all of that, but because it's a representation of the true hernias, because these patients come for follow-up, we do routine scans, and even a small hernia on a CT scan we've labeled. So you can see, so incisional hernias after laparotomy are a problem. They'll continue to exist. So our aim is how can we reduce and prevent these incisional hernias? What is typical about advanced GI surgery, I'm talking of GI surgery of magnitude of doing pancreatic resections and hepatic resections, is that there are incisions which are like an extended subcostal incision. We use an L-shaped incision, a Mercedes-Benz incision, or a long midline incision. And majority of these procedures are extirpative procedures. The patients are different. They have many times malignancy. They have coexisting sarcopenia. Many of them have preoperative chemotherapy and radiotherapy. And as you all know, that GI surgical procedures are potentially contaminated, and there's a high chance of developing a surgical site infection. And we know that an infected wound is one of the causes of forming an incisional hernia. A tumor like this will need an incision like this, and you can well know when you have an incision of this size and magnitude, the chances of developing an incisional hernia are very high. Over years, there have been efforts to develop a scoring system. Can we predict the development of an incisional hernia? There have been various efforts, but the first paper, which was published in JCS 2015, 640 patients followed up for a mean period of 41 months. And they could have a scoring system for predicting hernias. And they found that open surgery, a high BMI, and presence of pulmonary obstructive disease are predictors of developing a hernia. There have been many more studies, but none of them have been reliable and predictable of predicting the development of a hernia. The question of relevance is, why do hernias form? We all know there are known factors: patients who are obese, who have diabetes, who have respiratory problems. There are some unknown factors. And what is interesting is there are some neglected factors which over years we have ignored. There's a term called as proportionality bias, which means that we think that big events are caused by big causes. The example is that Princess Diana died in a motor car accident. We all think that it was not an accident. There was some sort of a conspiracy planned with it. Same is true of hernias. We think that there's a big mistake which happens, which causes big hernias. The fact of the matter is, it's a very simple cognitive understanding that, I'm giving an example. When you have a patient who undergoes an extended right hepatectomy for a hydrocholangiocarcinoma, a surgery which lasts 12 hours, the priority of me as a surgeon is to have a safe R0 resection. I go home. The first assistant also goes, the second assistant who's been there, his priority is to finish the pending work and go home. Wound has no problem, no importance for that person. So if that's the state of affairs, an assistant who's done a night duty closes the abdominal wound, that's what happens. We form incisional hernias. And if you study the most traumatic incidents in the world, like the Chernobyl incident, the Bhopal gas tragedy, they all occurred in people who were tired and who were sleepy. So that's what happens when residents who have done night duties assist you to close abdominal wounds. You're bound to have incisional hernias. We very well know that the technique of closure of abdomen is standardized. Single layer aponeurotic 5 millimeter bites using delayed non-absorbable sutures is standardized, but we must understand that this has been done for midline closures. The data for subcostal incision using same technique is still not validated. What else we could have done or we can do? This fact that monofilament and multifilament is answered because delayed non-absorbable is always monofilament. There is no benefit of using antibiotic impregnated sutures, retention sutures, abdominal binders. There is some interest in the use of prophylactic mesh augmentation in a subgroup of patients, that if you think that this patient is going to develop incisional hernia, is there a role in putting a prophylactic mesh? Though theoretically sound, but there are a lot of issues, especially in our set of patients who undergo major surgery. Which patient should get a mesh? Somebody who has a bowel resection, who has a multivisceral resection, there's a risk of infection. What is the best way to put this mesh? And in centers which have been tried, there's a risk of surgical site infection, seromas, nagging pain, and even GI fistulae. So mesh augmentation in a small subgroup of patients might have a role. What can we do to prevent an incisional hernia after GI surgery? Selection of a patient who continues to smoke is not a good candidate. Preferably, if patient can wait, we should give chest physiotherapy, properly prepare patients. As far as possible, use minimal invasive techniques. Plan your incisions well. Efforts to minimize surgical site infections. A standardized technique to close abdominal wound. Ensure the absence of time pressure, because you have to get the next patient in. You always tell, hurry up and close. And most important thing is audit your data, because we believe that we don't get incisional hernias. If you follow up your patients, you will find an embarrassingly large number of patients develop incisional hernia. To my mind, the single most important thing is an attitude change. We all have been a party to workshops where surgery is done. The moment the surgery, the specimen is out, the television gets, the screening gets closed. How many of you ever seen an abdominal wound being closed? Not a single workshop has shown abdominal wound closure. Why is it that we are so complacent about it? Why do big surgeons think that it's too small to close a wound? Wound closure time is coffee time. That's disgusting, because we leave a junior resident there, everybody goes, that person has no interest, he has no motivation, he just closes the wound. That's why we form incisional hernias. That's a fact. We need to understand it. And there are papers which are showing the same thing. It's our absolutely lack of interest, our involvement, and our addiction to stereotyped goals of removing organs. A surgeon is considered big by the quantum of organs which go into the bucket, and nobody talks about what happens to the patient's incisional hernia forms. We all know patients have died after incisional hernia repair, and I believe a vast majority of incisional hernias are avoidable if proper technique and care is given to them. I believe that we should have closure teams which are separate from operating teams. In our department, we tend to do that. If you have more people, you can do that. If you have less people, at least you can give some people a break, have a coffee break, come back and close the abdominal wound. Just imagine 10 hours surgery is going on and one person closes the wound. It has to be, it's not a marathon. It's like running a relay race. And in some countries, they are trying to impose financial penalties to people who develop incisional hernias. So it's all avoidable. And so if you ask me a question, is preventing incisional hernias in GI surgery a special technique or a basic skill? I say it's a basic skill. And I'll end my talk with a simple belief that we should be realizing that not all of us can do great things, but we can do small things in a great way. An abdominal closure is a small thing, but can be done in a graceful and great way. It's a great disservice to the patient not to regard this part of the surgery as an essential part of surgical training. Thank you so much.
We'll go. Super.
As sir has finished ahead of time, we have time for one or two questions, quick ones before the tea break. So if anybody wants to ask for any, Dr. Chaudhary, any of the panelists, please come up.
Yeah. Do you change your instrument for suturing back?
No, we don't.
No. So that is what, again, one thing that is recommended is after you've done a Whipple surgery and you have gone through bowel and, you know, stomach and everything, you just take another set of instrument to close the abdomen.
I will not agree on that. I may be wrong on that, but I sincerely believe in a simple thing that we generally believe in a lot of wound irrigation or something. So I think that helps, but I don't think it, I mean, you may be right, but I've never tried.
This is something which has been suggested.
Maybe you're right. Maybe you have a point.
I have a question for Ramesh. The question is, with pneumoperitoneum, the idea is to expand the capacity of the peritoneal cavity, the abdominal compartment, but you end up actually pushing more air in the hernia sac and the hernia tends to get bigger. What is your answer to this argument?
Yes. So the one other thing that they have suggested is that you put an abdominal belt while inflating the abdomen. But yes, some air will definitely leak. But despite that, the overall volumes will definitely increase. So, I mean, what I have seen and what has also been described is that when you start insufflating the abdomen inside under a pressure, the abdominal cavity volume increases. That's important. The hernia sac volume also may increase, but the abdominal cavity volume definitely.
What percentage of your patients in practice these days get Botox?
Now I try to do it more often. It's expensive. Only the cost is coming in a way. Otherwise, I think we should do it more often. I would now do it even for a 7 centimeter, 8 centimeter hernia, because definitely it will cause less pain to the patient and it is harmless. That is.
So may I make a comment here? So for the progressive pneumoperitoneum, of course, one of the essential aim and target is to expand the abdominal wall There is also the basic premise from the originators that it allows the patient to withstand higher intra-abdominal pressure. So if my abdominal pressure is 5, but if I was getting air inside my abdomen for 3 weeks, I will be able to withstand 15 millimeters of pressure without feeling respiratory distress. So one of the essential targets of doing a progressive pneumoperitoneum, according to originators, also to allow the patient to withstand higher abdominal pressure and not have abdominal compartment syndrome in the post-operative.
Yeah, that's
Your
what I
comment.
see it by acclimatization. So it gets acclimatized to that higher atmosphere.
Thank you for your question. We'll take a short tea break for the next 10 minutes now and join back at 10:45 sharp for the talk on posterior component separation by Dr. Sean. Thank you.
Hi there.
उधर वाली ऑडियो इधर आएगी ना।
मुझे लेबल भी दिखा रहा है। सॉर्ट आउट करना पड़ेगा तब रुक जाओ ये म्यूजिक चलाया हेलो
Hello there.
हेलो हेलो
Hi, can you hear me?
yes I know can you speak something sir just to test
Yes, hi, can you hear me okay?
okay you're audible now
Okay, good. I can't tell if my screen is being shown
Yes.
live to you now
Yes.
or,
it's
Okay.
visible to us sir
is everything looking okay on your end?
pardon sir hello
Hi, can you hear me?
yes I can hear you now
I'm having a hard time hearing you and I'm my maximum volume. So please let me know if you need me to do anything on my end.
It's perfect, no issues in this.
Okay,
No, it's
great,
perfect,
thanks.
fine. Yeah.
Can I request everybody to come back inside as Dr. Orenstein is ready to deliver his lecture from the US. So next couple of minutes, I wish to request everybody to come back in. You don't want to miss his great talk on posterior component separation.
So I'll be introducing our next speaker. Our next speaker is Dr. Sean Orenstein. He's an associate professor of surgery working in Oregon Health and Science University in Portland, USA. His passion for management of complex hernias is evident in his multiple fellowships, which focus on research in mesh materials and his specialized training in AWR. His work also focuses on minimal invasive techniques and a fusion between endoscopic and surgical techniques for improving patient outcomes. He's a member of the American Society of Hernia Surgeons and SAGES. I'll welcome him for his talk on posterior component separation and its correct application. Dr. Sean Orenstein.
Well, hello and good evening from Portland, Oregon, and good morning to you all in India. I really appreciate the invitation to speak to you all and hope you're having a wonderful start to your conference. I'm looking forward to speaking to you one of my big passions, and that's not only on abdominal wall reconstruction in general, but on transversus abdominis release. Here's my disclosure slide. None of this is relevant for this talk. And when it comes to hernias, they certainly come in a lot of shapes and sizes. Some are fairly simple, some are a little more complex and need a little more TLC to help the job along. And there's no better start to talking about posterior component separation and abdominal wall reconstruction than talking about classic retrorectus repair from Dr. Jean Reeves and René Stopa from France. And I love Dr. Stopa's philosophy on giant prosthetic reinforcement of the visceral sac. And I think it's so interesting, the history of it, where this tissue plane that we use so often started out as a groin repair, and their thought process to develop that plane more superiorly to use it for ventral hernias instead of just groin repairs. And that certainly led the way for a lot of what we do in hernia repair today. And a lot of people think of the retrorectus repair as the gold standard for large ventral hernias. And it really is good for medium to large ventral hernias. However, a retrorectus is insufficient for a lot of the hernias that we see today. Very large defects, perhaps larger peristomal hernias, if they have a flank as well as a midline, as well as other areas that are difficult to access with retrorectus only. So how do we get beyond the semilunar line? That is, how do we get beyond the retrorectus plane? Well, various techniques have been described. There's preperitoneal technique, which really isn't a myofascial advancement, but it's creation of a visceral sac to allow a larger mesh prosthetic for reinforcement. Intramuscular technique was described by Alfie Carbonell a number of years ago, and this is going in between the internal oblique and transversus abdominis. The drawback about this procedure is it ends up sacrificing all those nice neurovascular bundles to the rectus, hence the development of transversus abdominis release. And when we wrote about this and described this back in the day with Yuri Nowitzki leading the charge, this really was, interestingly, at the time was kind of scoffed at, and certainly looking at today is quite one of the major techniques that we use today. It is a true extension of the retrorectus dissection. It can tackle a lot of large and complex hernias. And I think today, if Dr. Stopa were alive, he'd really enjoy using this procedure, because I really think it epitomizes his philosophy on giant prosthetic reinforcement of the visceral sac. And that's what you really create with transversus abdominis release. When do I use TAR? Well, there's a lot of situations for it. Very large hernias that have too much tension with closure with a retrorectus only, multi-recurrent hernias, subxiphoid and subcostal hernias. Because transversus abdominis inserts deep or posterior to the ribs, it's one of the best ways to get superior overlap for these type of hernias. Large peristomals, flank hernias. And I say flank hernias that have associated midline hernias. I think if you have an isolated flank hernia that doesn't necessarily require a full TAR, that could be usually a flank incision or perhaps a unilateral TAR. But if you have a flank lateral hernia along with the midline, a TAR is a great way to take care of that. Also large suprapubic hernias to get widely into space of Retzius as well as Bogros bilaterally, as well as other complicated hernias. So let's talk about some of the technique for it. Step one is a thorough adhesiolysis. Now, there have been extraperitoneal techniques described. Scott Roth writes a nice paper about extraperitoneal, where minimizing intra-abdominal dissection, and he's very gifted in that. I will say that for me, I think a thorough adhesiolysis is critically important to reduce the visceral injuries, especially as you dissect laterally and you're getting into your pre-transversalis or perhaps pre-peritoneal plane to reduce visceral injury. Start off with a classic retrorectus dissection, about a ½ centimeter to a centimeter just off the edge of the linea alba. Taking care to note, before you dissect too far superiorly and inferiorly, you want to make sure you've accessed the retrorectus plane. Far too often, our patients have a big diastasis, and if you're too far medially, you're going to end up cutting right into and getting to subcutaneous fat. Now, you haven't burned any bridges yet, but you got to recognize that until you see some of that good rectus muscle, don't dissect any further in that plane until you've gone back a bit more laterally to get into the true retrorectus plane. And once you've done that, you dissect superiorly and inferiorly, you clean off all that fibrofatty tissue from the posterior rectus sheath, retract the belly of the rectus muscle anteriorly, and really nicely exposing these neurovascular bundles out near the semilunar line, as you see here in this image. And it's crucially important to identify these neurovascular bundles and the semilunar line as a key aspect to a safe and successful transversus abdominis release. So let's take a quick minute to talk about some of the anatomy in this area, because I think it's one of the very crucial aspects for a safe and successful TAR. If we focus on that area near the semilunar line, what we're looking at is one of the key aspects is when you initiate TAR, one of the first things you enter and divide is the posterior lamella of the internal oblique. And remember, internal oblique splits into an anterior and a posterior component. You're going to end up cutting into that posterior component. And also seen in this is looking at that yellow line there, the neurovascular bundle. By staying medial to those neurovascular bundles, that's going to keep you safe, that's going to keep you on track. Conversely, if you end up cutting lateral to those neurovascular bundles, you may end up inadvertently cutting the anterior lamella and perhaps the external oblique. And if you're cutting portions of the internal and the external, and then you go and do your TAR, that can destabilize the abdominal wall and create a semilunar line injury, which could be catastrophic for these type of repairs. When we look at the location of transversus abdominis, if you look at that classic Frank Netter drawing, it shows the two obliques and transversus abdominis lined up perfectly there. The reality, though, is that this is only one part of the abdominal wall, say the mid-abdomen. When you look at transversus abdominis, it actually is very medially, the higher up you go, closer to the subcostal region. And so much when you do a transversus abdominis release, doing it in a classic top-down approach, you're cutting muscular fibers superiorly, and as you take your division line down low inferiorly, you end up only cutting muscle for about the top third or so, and then the bottom half to 2/3, you're not cutting any transversus abdominis muscle, you're only cutting the aponeurotic portions of that as you proceed inferiorly. So you've done your retrorectus dissection, you've identified those neurovascular bundles, you're going to start your division of that posterior lamella, as I just talked about. You're going to be about 1/2 centimeter to 1 centimeter medial to that semilunar line. And I can't emphasize how important it is to be medial to that. Anything lateral is bad and could be catastrophic. So very important to identify that anatomy. And a lot of people have good anatomy in here, but many of our patients have had multiple surgeries. Perhaps they've had old or current ostomies or scarring up there in this region, and that can make these tissue planes, the anatomy, challenging to identify. And this is one of those dreaded complications that I was talking about, where you have these semilunar line blowouts, which can be very difficult, sometimes impossible to re-repair. And this is a complication of not only posterior, but also anterior component separation, that is external oblique release. So here's showing another image. You've done your retrorectus dissection, you're medial to the semilunar line, you're going to initiate transversus abdominis, cutting that posterior lamella that exposes transversus abdominis muscle fibers. And the other trick to this is when you start your dissection, you're going to aiming straight down toward the back of the patient. That is aiming your dissection posteriorly, not laterally. You will eventually do your lateralization, but initially, to stay safe, straight down, cut the posterior lamella, cut those transversus abdominis fibers all the way down to that nice white transversalis fascia. And then you can extend that incision superiorly and inferiorly. Here's showing a quick video clip. Now we're dividing that posterior lamella of the internal oblique that's exposing the muscle fibers. And now we're coming back with our large right angle, cauterizing all those muscle fibers of transversus abdominis. And there just is just that upper portion of it. And as we proceed about 1/3 or so down, now there's no more muscle fibers. We're only cutting the aponeurosis of transversus abdominis. After you've done that, now it's time to lateralize that plane, where the bulk of the transversus abdominis muscle is reflected out and laterally, keeping that nice floor of your visceral sac down, meaning transversalis fascia and peritoneum. And I do what's called a TAR massage, where I just usually bluntly dissecting with my fingers, getting all the way out to retroperitoneal fat as far as I can go, and extending that lateral dissection superiorly and inferiorly. And interestingly, transversalis fascia, it loves to stay sticking to the transversus abdominis muscle. So sometimes you have to fight it to keep it down on your peritoneum. Can you get into the preperineal plane? Yes, you can. The only challenge with that is that gives you more likely to make holes out there, which can be harder to repair afterwards. So really take the time, try and keep that transversalis fascia down, especially as you get in the subcostal area where it's tented up a little bit underneath the ribs. Then the lateralization there. Once you've done your left and right side, then you're going to come down and do your inferior dissection into space of Retzius and into space of Bogros, trying to sweep, get that fibrofatty tissue down below the arcuate line. If you have inguinal hernias here, you can take care of this at this time, divide the round ligament if needed to get your mesh way down there inferiorly. And then superiorly can be challenging. And one of the important things for the superior dissection is instead of taking your dissection line straight up, this is where you want to start to curve your incisions more toward the xiphoid process. That is, curve that incision medially. And the whole idea of this is that if you end up staying too far laterally, as you go superiorly, you may end up getting into the diaphragm muscle fibers. And if you take out too many diaphragm fibers, you can actually create a Morgagni hernia, which is something that would need to be attended to and reinforced if you end up doing that. So staying safe is trying to go medially toward the xiphoid process, go underneath the xiphoid, cauterize some of that tissue that releases it. It'll drop down. There's a normal subxiphoid fat pad that almost every patient has as a way to double check your location. Once you've completed all your dissection, you're going to reapproximate your posterior fascia. Typically, I use a running 2.0 Maxon or a slowly resorbable suture, and then it's time for mesh placement. For good central hernias, a 30 by 30 mesh, if you rotate as a diamond, that's going to give you about 42 to 43 centimeters from long point to long point. That's sufficient for a lot of abdominal walls. But for large abdominal walls or large hernias, I'll take 2 pieces of macroporous polypropylene and overlap them, or I call this home plate configuration. It looks like a baseball home plate. And because you're dissecting so far up underneath the ribs and underneath the xiphoid process, you can actually take a squared off straight edge mesh and bring it all the way up, getting at least 5 to 8 centimeters above the costal margin. And then your diamond mesh is going to go down very low, and you will have some overlapping of that mesh in the middle. As far as fixation, I used to do quite a bit of fixation with slowly resorbable sutures. And this is sort of an older diagram that I used to do for all my fixation. I really gotten away from this. And at this point, it's minimal fixation. Occasionally I'll use Tecile or some type of adhesive fixation. For those that have a significant amount of tension, then I do place a few tension offloading sutures. I do like to drain this quite widely, so I'll place a couple drains in there, and most of my patients do go home with at least 1 drain. And then you're going to reapproximate the anterior fascia in a typical short bite fashion, taking sure to ensure we get good fascial bites and not getting any muscle or fat with our closure. And then you want to close your skin and soft tissue in your standard fashion, perhaps doing some type of skin and soft tissue resection. So a couple challenges during TAR, a lot of questions that we get, what happens if you make holes in the posterior layer? This is common. Certainly we want to try to avoid that. Little holes are easy to take care of, little figure of 8s with a resorbable suture. If you have a little momentum, you can take a little bites of momentum to pledge at that. And then also, what happens if you can't close your posterior fascia? Maybe perhaps you had to remove old mesh, maybe there's a tumor resection. You do need to reapproximate and close that posterior layer. This is a barrier layer, not a strength layer. So you need to reconstruct it, whether that be using hernia sac, some type of resorbable mesh or biologic mesh to sew it as a bridged inlay to create that barrier. And then the next layer would be your main structural mesh. Also, what about anterior fascia? What if you're having difficulty closing that anterior fascia despite bilateral TAR? Well, number one, before you even choose your mesh, you want to get your Coker clamps, pull on that fascia to see how much tension is. With a good TAR, you're going to get enough myofascial advancement that the vast majority of those will be able to get closed. But for very large hernias that you're having a tough time closing, if you think you might have to bridge, you want to make sure you choose a heavier weight mesh. And these are one of the few times where I will use a heavyweight polypropylene if I highly suspect I'm going to have to bridge. And if, despite having that heavyweight mesh, If I'm still struggling to get that closed, instead of running my fascia, I'll just place a series of figure of 8 sutures, and I'll sequentially tighten those from superiorly down toward the middle, and sequentially tighten those to get my fascia closed. And if for some reason I do all that and there's still some gaps in it, the most important thing at that point is skin and soft tissue coverage. I'll raise skin flaps. I'll do whatever it takes to get my mesh closed. You don't want to be staring at bare exposed mesh. A couple other things is questions we get are, what about, can you do anterior and posterior component separation at the same time? That is, can you do an external oblique and a transversus abdominis at the same time? And I would emphatically say, no, please don't do that. Some great surgeons, Jorge Diaz and Eric Pauli, wrote a great paper looking at this. And while they said, while it is technically feasible, it would not be recommended given the complexities of it and the potential for destabilizing the abdominal wall. Well, what about, can you do a TAR after somebody's already had an anterior component separation, say years ago? And Eric Pauli wrote another nice paper about this. And the reality is that, well, technically it can happen. You can do it. There are inherent challenges with this, and this probably should be done in high volume centers that have a lot of experience in this, just to make sure that the anatomy is well understood and there's wide reinforcement well beyond the semilunar line. What's the data looking like on TAR? Well, this is the largest TAR database in the world, looking at a large series from Case Western University with some great hernia surgeons like Yuri Nowitzki and Mike Rosen. And certainly there's a lot of complex hernias. Looking at the overall data, 19% surgical site occurrence rate, 9% SSI rate, with less than a 4% hernia recurrence rate, with only a small number of bridge repairs with that. So really is an essential procedure for those embarking on complex abdominal wall reconstruction. Adjuncts, things that you can do to TAR. I'm not going to go into detail on this. I'm going to save a lot of this for Eric Pauli's talk. Things like a storm, which is a stapled transabdominal ostomy reinforcement with mesh, or a polyperistomal hernia repair. These are nice adjuncts to do for peristomal hernias. Again, he will address those, I'm sure, in his talk later. So to conclude, TAR is a very advantageous procedure. There's a lot of variety of large and complex hernias that you can tackle with it. It really is true giant prosthetic reinforcement of the visceral sac. It's got great outcomes with low surgical site occurrence and recurrence rate. And really, if you're embarking on abdominal wall reconstruction, it really is an essential option for these procedures. That said, while we have some good data out there, you know, this has only been around for about a decade now, so we don't have 20+ year data on this, and we are accruing the data. The last bullet point I think is an important one, though. I do think there's an overuse of TAR. That is, people are doing TAR for perhaps small or medium-sized hernias that don't need it, or, you know, in their robotic age, people are doing ETEPs. And they're doing, you know, ETEP retrorectus, ETEP TARs for 3 centimeter hernias that probably don't need that level of dissection, and perhaps burning bridges that we don't need to do. So I would be cautious with some of the overuse of this procedure, even though I think it's a wonderful procedure to use. Some of the anatomy can be challenging. And so for those that do want to really go down the pathway and doing TAR, I would really recommend going to as many talks as you can, doing cadaver and animal labs, get some mentoring and shadowing. And that way you really learn this right and you have a good, safe operation for your patients. With that, I'd like to conclude. I want to thank you for your time and looking forward to our discussion. Thank you very much.
Thank you, Sean, for an awesome talk. You've really beautifully covered the indications, the anatomy, the precise technique. I think all we need to know about TAR in just under 20 minutes. So I'm sure, and I want to thank you. I've told a few people here, Sean was my co-fellow during my training at Case Medical, and he let me in his OR days on Thursday. He allowed me in. So I got to see some TAR and learn a lot from him. I was the bariatric fellow and he was the hernia fellow. So thanks again, Sean. And I'll please, if anybody has a question for him, as he may have to leave later. Anybody has a question for Sean, we can take it now. So, Mike. Can I request the
Yeah.
panelists to come up for the next session on the stage while we are having the questions also?
Sean, hello.
Hi there.
Yeah, Dr. Punjani here, Ramesh Punjani. You still do an anterior component separation at times?
Very rarely. I would say that I do that when, for whatever reason, I cannot access the posterior plane. So let's say I get into the abdomen and there's severe adhesive disease. Perhaps there was prior mesh with numerous fixation points, and those posterior layers are just destroyed or severely fibrotic. Those are times when I will consider doing an anterior component separation, or basically a hostile abdomen of some form where I really just want to stay the heck out of the abdominal cavity. Then I can do an anterior component separation. Now, as much as I'm biased in favor of doing posterior component separation, both anterior and posterior separately can provide a lot of myofascial advancement. So I think both are good procedures. My biggest beef with anterior component separation is the potential wound morbidity. You don't get as severe of wound morbidity with posterior just because you don't have those skin flaps that you do with an anterior. But again, you get a lot of myofascial advancement with either procedure.
Vikas, can I ask? Sure. Yeah. Okay. Sean, hi, Ram here. Question, I have two questions. One is, since the early years where you were part of Yuri's team and developing the procedure, in these years, has your technique of TAR changed in any significant way? Number one. Number two is, when you're doing the subdiaphragmatic dissection, do you find any specific tool of developing the preperitoneal plane? Because sometimes the peritoneum sticks to the diaphragmatic fibers. So how do you avoid holes in that region?
Yeah, I mean, Ram, you raise a good point. I'm going to address your second question first. And I think one of the tips is of all the layers, when you're trying to bring that transversalis down with your peritoneum, up in that subcostal area near the diaphragmatic area is one of the hardest. And I can tell you from personal example how many times I've made holes up there, that little holes turn into very big rents, which can be quite challenging to tackle. What I've learned with that is that if it feels like it's really stuck, I will go more laterally. So instead of going straight up superiorly underneath the ribs, I will instead lateralize my TAR plane and sweep my hand around underneath the ribs and come back up. And by sweeping my hands from lateral up around, going up behind and then superiorly, that can help get me into that plane. And I literally, this is all blunt dissection. It's very hard to do with clamps and with right angles. It really is a blunt dissection technique. And by sweeping, and then with one hand, if I get my hand above the costal margin, then I'll work my way down inferiorly from above the ribs to below the ribs. And by doing that sweeping motion, it can help me sweep and bring down that transversalis fascia and have it opposed to the peritoneum. Another technique is that if for some reason I can't do that, I will take my cautery and I'll try and score at the transversus abdominis muscle. And I actually do that when I'm looking at the muscle, as I'm bringing that muscle outward laterally or superiorly near the ribs. You can see, if you see raw exposed muscle fibers, you know you're in the correct plane. But if you see a glistening of whiteness or a glistening of tissue, that tells you that transversalis is up and opposed to your muscle. And again, you have to fight it to bring it down sometimes. So another trick to do is you can cauterize, just score it with your cautery at the muscle. And then you can use some clamps or some other traction devices to try and kind of rip it and pull it down away from the muscle. You want to do that before you get too far. And also, as you're doing your dissection, instead of doing big sweeping motions, try and do little baby sweeps. Those little baby sweeping motions will help prevent some of the tearing off of the transversalis from the peritoneum. And some of it's hard to describe in words. You just kind of have to do it in person. And I'm not suggesting it's easy. Sometimes there's very challenging and it's very stuck. If for some reason you just can't separate transversalis from peritoneum, you just gotta be slow and cautious. and really try to be careful as you take that peritoneum down from underneath the ribs. Now, to address your first question, what have I evolved in? Well, I certainly do still a lot of top-down approach. One of the things that robotics has taught us is doing a lot of bottoms-up approach. And I say this as somebody that's done a lot of TARs. I don't think that bottoms up is good for learners, that is initial learners learning TAR. I think the top-down approach is still a safer way to start learning your TAR, because by staying on that transversus abdominis muscle in the upper part, that's going to keep you on track and keep your anatomy straight. But if you're more familiar with the anatomy, by going down low and doing a bottoms up approach, you start off in the space of Bogros. You are actually pre-peritoneal, and that's actually a fairly easy plane to bluntly sweep with your hand. And then you can bring that hand up superiorly, but at some point you have to transition from pre-peritoneal into pre-transversalis, again, trying to get that transversalis fascia off of the transversus abdominis muscle and down to pose with it. So I think that's probably my biggest modification that I do from time to time. The other thing that I've learned over the years is the amount of traction, whereas my assistant is reflecting that the rectus and transverse abdominis up laterally, I'm pulling medially. Usually I use Coker clamps to pull my posterior sheath out medially. There's a certain amount of traction and counter traction that you need to get your division of those layers, as well as the blunt sweeping. It's typically when I'm in a rush, or I start to curve my fingers, I'll pop my fingers inadvertently through those thin layers. And I've learned to kind of keep a nice flat, almost like a dog paw, and pad that down to separate those layers out bluntly laterally. And that's just from years of experience doing it. But surprisingly, the technique has really not changed too much since its inception.
Awesome. Thanks a lot, Sean. In the interest of time, sir, can we, would you mind, we have a few more questions, but if you're okay to stay on for the next half an hour, I know it's late, but.
No, that's fine. I'm looking forward to the next round of talks. I'll stick around to the panel and to the crowd. Thank you very much. I will stick around. Vikas is great. Thank you very much. This is a great program, and you were a wonderful fellow to have back in the day. So it's great to see you again.
Thanks again. Then we'll get, I think, please come up and we'll get started with Dr. Shinde's talk.
So after the posterior component separation, we have Dr. Pramod Shinde coming up to speak on anterior component. He is an eminent surgeon from Nasik, Maharashtra, practicing in Kaushalya Hospital. He's credited with opening the first laparoscopic center of surgery in northern Maharashtra as early as 1993, and also has performed the first lap hernia surgery in that region. He has done various fellowships in minimal access surgery and specializes in laparoscopic and hernia repair. Presently, he's an integral part of Hernia Task Force and CME Committee of SAGES. He's one of the founding trustees of AWR Society, Surgeons Community of India also. I welcome Dr. Pramod Shinde.
Thank you, Dr. Vikas and Dr. Adarsh and the entire Medanta team for an excellent program. Well, the topic given to me is tough on two counts. I am standing amongst giants and Tarzans and almost feeling like a David against Goliath. But here the Goliaths win, not the Davids. So, and the time is pretty short. So we all know that Ramirez popularized this method way back in 1990. And he understood that the external oblique muscle is a very large muscle covering the abdomen as well as the chest, and that there was no nerves between the external and the internal oblique. And this technique is all well known now that if we take an incision beyond the linea semilunaris, he also added a retrorectus cut and then separate the cut edges of the external oblique, then the entire component of this neurovascular and neuromuscular part can be free to close the midline. What this did was to close the midline very nicely, and then a mesh could be put in any plane, either an onlay or a sublay, or even an intraperitoneal mesh can be put after an anterior component separation. We all know this technique needs meticulous dissection, and it's not as difficult as TAR, but a generous incision is taken right from xiphisternum to the symphysis pubis, And after a complete adhesiolysis, then we start raising the skin flaps, which Sean was saying that this is the nemesis of an open anterior component separation. Once we raise these flaps, then we can literally hold the rectus muscle in our hands and go beyond the linea semilunaris, and then take a nice divide the external oblique right from the costal margin towards the inguinal region. Due to shortage of time, I have not emphasized all the steps here, but separation of the external oblique from the internal oblique is also important, where we go all the way down to the anterior and the mid-axillary line. And once we have reached an adequate separation, then we move on to the other side and do a similar anterior component separation on the other side. Once that is done, you will see that the midline comes very easily, and even the anterior closure comes very easily. We are able to put a very large mesh, and the advantage in this procedure could be that we can suture the mesh to the cut edges and then close the abdomen very nicely. But if we don't like and we don't want rightfully don't want the skin complications, it can be done endoscopically also, and it can be now done as a subcutaneous and a subexternal oblique technique in open ventral hernia repairs, or even in laparoscopic repairs. And sometimes if we need to close the abdominal wall in adverse situation, it can definitely be done. This is how, if we want to do it endoscopically, it can be done, where the defects may not be very large, but sometimes you will find these recurrent hernias are difficult to close and the defect will not close. You could use the same intra-abdominal port in the upper abdomen and the mid-clavicular area. We can pull out the port, and the same right mid-clavicular port can then be put beneath the external oblique with a simple telescopic dissection. Here we are already below the external oblique and lateral to the linea semilunaris. This is on the right side, and we are going towards the pelvis. Then we put in an additional working port and enlarge that space. And once we have done that, then according to Ramirez's technique, that's the linea semilunaris medially, and we need to divide this external oblique on our roof, and it can be done very elegantly and almost like a bloodless field there, and the edges can be separated. The pneumoperitoneum, the CO2 does help us. And once we have done that, in fact, in between, if we want to really assess if we've done an adequate job, we could go back to the peritoneal cavity through the central port. If not, we can go back to the subexternal oblique cavity. And once we have done an additional dissection between the external oblique and the internal oblique laterally, even divided the deep fascia fibers, then we could repeat the same procedure on the other side. And on the left side, in this particular patient, I was able to see a very nice finding, which we will see in a moment now. While doing this dissection, we could see the iliohypogastric nerve traversing this plane. And then we can go back to the peritoneal cavity, take up the bladder flap, and do a kind of a TAPE, where part of the mesh is fixed to the Coopers and it's below the peritoneal and the bladder flap, and the defect can be closed very nicely. There are many papers, and due to shortage of time, I may not be able to read all of them, but this was a meta-analysis comparing open component separation with posterior component separation. Surprisingly, this meta-analysis did not find any significant difference in the wound complications, and there are comparable outcomes of posterior to the anterior TAR. Not only that, an open anterior approach, a TAR, a laparoscopic anterior approach, and a perforator preserving approach was also studied in a systematic review. And again, the incidence recurrence was similar in all except for the open anterior approach. The prevalence of SSO was comparable. Again, a surprising finding, but all three were comparable as far as the recurrence rates were also concerned. Again, the differences between all these three were studied. And in this paper, again, it was seen that surgical site occurrences were again similar, not very different. The corresponding rates are there right in front of you, and no relevant differences were found between these techniques. But we all know that TAR is a very versatile procedure. But then the question is, where does the anterior component separation have its place? So when the defect is not large enough to warrant an extensive dissection of a mesh, if we are not really trained for a TAR, or if the retrorectus plane is already used, or when the sac is so huge that it's already extending beyond the linea seminonaris. Sometimes extensive adhesions, a post-open abdomen treatment for abdominal disasters where we don't want to go back into the abdomen, as Sean was saying. Abdominoplasty for a huge pannus where already the linea seminonaris is right in front of you. Very large hernias with loss of domain and post-star recurrences will find a place where an anterior component separation can be done. Sometimes the defect is not very large enough, but being a sub-xiphoid defect, the recti may not come very close with a posterior component separation. The anterior component separation, you can divide the external oblique way above the costal margin, and these defects can be closed nicely with an endoscopic component separation, or maybe even a total combined approach. Sometimes the sac extends right beyond the linea seminonaris, and sometimes when you want to do an abdominoplasty and the patient wants it, and it's good for the patient also with this kind of an hernias, the defect may not be very large, but during the abdominoplasty you already can do a anterior component separation with just a small tunnel. You don't have to raise the skin flaps right up till the costal margin, and from here you can divide the external oblique, close the defect. You already have the retroperitoneal plane, and you have the cave of Retzius. The mesh can go right below down. Sometimes after abdominal disasters, and this was one of the papers where even in 2022, Ramirez's approach was tried without mesh, as Ramana was saying. But after abdominal wall disasters, extensive adhesions posing bowel risk, where you've already whacked this patient, you don't want to go and the abdomen is going to be hostile. Sometimes in an open abdomen treatment for abdominal disasters like this, in a young patient, the recti are very strong. The midline closure is not going to require a very large mesh, and this can be done very nicely with a combined open and endoscopic approach. In a very large hernia, now there are papers now from this famous group where Sean was saying that we should not do it, and still it's in an experimental stage, but sometimes we might need to combine very large hernias, anterior and component separation. We don't advise it, but the literature has come in. Jorge Diaz and Monclis have papers on it where they have tried it in very specialized centers, but that's for the future to tell us whether we should be really doing these kind of procedures. Post-star recurrences is another area where you may not want to go back into the same plane. It may not be safe for you. It could be easier to do an open or a repair with an endoscopic component separation. And this was a sub-xiphoid or an upper abdominal post-star recurrence. And our leader of this program, Dr. Vikas, was with me in Kolkata in our first international conference, where he did an open repair of this procedure, and I helped him and chipped him with an endoscopic anterior component separation, and we could close this defect without going into extensive dissection, being a post-star recurrence. So my friends, this is my short presentation, where I think I have highlighted that anterior component separation does have its place in cases where it can do a better justice without doing too much of harm or damage, or especially in elderly, risk averse and frail patients with very hostile abdomens and some specific situations. Thank you. So if you can take it.
A couple of questions for Dr. Shinde.
Hello. Yeah. Pramodji, I think very nice presentation.
Thank you.
If we compare with open and laparoscopic anterior component separation, so what would you prefer exactly? And in cases of recurrence of TAR, what would be the treatment of choice?
Well, the endoscopic component separation has a limitation. It will not offer an extensive release, and it is indicated for medium-sized hernia, say for from 6 to 8 centimeters. It can be very well combined with open hernias. So if there are large hernias where you're going to have extensive mobilization needed and extensive medialization needed with a large defect, then endoscopic component separation will not be sufficient. You might have to do open. As far as post-star recurrences, it's a very specialized topic, specialized surgeons, because it is going to need experience. Re-TAR has been done, and Dr. Ramana and Dr. Punjani, both great Tarzans, are sitting here, but it's not a very easy procedure. So we look for the safety of the patient, your own expertise, how big is the recurrence and what will be better for that patient with what will be less morbid and what will offer comparable outcomes without causing any harm to the patient. So that is the specific situation where we would not want to go back into that plane, and we could use an anterior component separation, maybe the onlay plane, where it can be done much more safely.
Dr. Shinde, fantastic
Yes.
talk as usual. I think one of the indications that I found for anterior component separation is subxiphoid hernias.
Absolutely.
So, post CABG hernias, I think subxiphoid hernias, most of these patients will do much better with trying to do an anterior component separation rather than
Yes.
trying to close their defects with posterior component separation.
Yes.
I think ACST scores there. Do you agree?
I agree, because the external oblique goes right up to 6th intercostal space and we can divide it over the chest wall. Not only that, in compromised patients, I have done it in the last patient under regional anesthesia because the patient was not fit for a general anesthesia with a huge subxiphoid defect. So I would say that anterior component separation has a place in those subxiphoid defects.
Anything which is along the bony margin, sometimes the mobilization is better with the
Absolutely,
So subcostal hernias,
Absolutely.
you would get some advantages.
Otherwise, in TAR, we still might end up doing a little bit of bridging, although we'll get a good mesh coverage, but some amount of bridging might be needed. Thank you.
Thank you. So could you join us on the dais for the next panel discussion? Sir, so to round up this, this was an excellent talk, Dr. Shinde, sir. To round up this round up this session, we have a panel discussion on the right application of component separation techniques, for which I welcome to the dais our panelists, Dr. Pramod Shinde, sir, Dr. Brij Banga from Nisar, Dr. Meenakshi Sarma from Paras, Gurgaon, Dr. Vivek Bindal from Max Vaishali, and Dr. Sumit Shah from PSRI Delhi. To moderate this session, I welcome Dr. Ramesh Pujani. He is the Managing Director at Puja Nursing Home and is associated Fortis and Beach Candy Hospitals. Dr. Ramesh.
I think we'll start off. So it's a panel discussion on right application of component separation. So we heard seen Austin talking about the posterior component separation, a very lucid talk. And equally lucid was Dr. Pramod Shinde claiming that anterior component separation has still a place in the armamentarium of a surgeon. So where will you choose which? So I come from Mumbai, everybody knows me, and these are the panelists who are all very, very stalwarts. He keeps on doing robotic surgery, Vivek, and Sumit is a very senior friend, a surgeon and a friend. Brij is a good open surgeon, I know him. Meenakshi is a good, and Pramod Shinde, everybody knows. Now, abdominal wall reconstruction, basically what is the aim when we try to do it? And I suppose we all do it for a big hernias, right? So what is the first criteria that we follow? What is the aim of abdominal wall reconstruction? So it is basically to protect abdominal organs getting outside the abdominal cavity. So you want a closer. You do not want to bridge it. You want to close the abdomen. So that I think is the first criteria. So primary facial closure. And it provides a dynamic support to the abdominal wall. So you want everything to remain live till you finish. That means you don't want any rectus atrophy. You don't want any, even the soft tissue problem. So you want a dynamic support to the abdominal wall by taking care of nerves and blood vessels. And keep an adequate margin of soft tissue coverage. So you want a wide prosthesis. So that's, I think, the third aim of any abdominal wall reconstruction. And avoid tension in the supply area. And therefore, you want an adequate myofascial release. So these are the four aims that we have whenever we do an abdominal wall reconstruction. So with that in mind, this is a very good study done. So do you think that the bridging, what problem, Sumit, the bridging would bring about? Suppose there is a big hernia and I bridge it with a big mesh. And that's what we did it for quite some time with the putting a big IPOM meshes in a patient who has got 7-8 centimeter defects.
I think basically it leads, is this working? I'm not sure if this is working.
Okay.
Okay, so what it leads to is a pseudo hernia. So there is a bulging of, the mesh into the defect, and that leads to kind of a pseudo hernia formation, and the patient is going to continue feeling the bulge.
So what he's talking about is that the mesh will start bulging inside the abdomen, but it will be a pseudo hernia. Meenakshi, anything else? Suppose you bridge it. What is your fear?
So the patient actually comes with a complaint of a bulge. And we have sent her or him back with the same complaint he or
So
she
it is
came
that
with.
the patient is not satisfied. That's third. Pramod, you can say something?
I think it can lead to a higher recurrence also.
I think that's important. All of us who have done a big IPOM for a big hernias have burnt fingers quite a number of times where these people do come back just not with a pseudo recurrence, but an actual recurrence. So this is what the aim of this study, what they showed is that the SSOs are more common with bridging. All of you agree? That
Yes.
all surgical site occurrences will be more. The recurrences are more with bridging, and a functional restoration is more with facial closure. So these are the reasons for which you avoid bridging in all the patients. So, and in some cases, therefore, you will have to do a component separation technique, which since morning we have been listening to. Now coming to the anterior component separation technique, do you agree, Pramod, that there will be more surgical site occurrences?
Yes, yes.
So most of the data, or all the studies that are done, that the surgical site occurrences in every form, that means whether it is seroma or whether it is infected mesh or it is wound disruption, all of them are more with the anterior component separation, obviously because you are compromising the blood supply. Hello? Yeah, okay. Okay, fine. Yeah. Is it quicker, easier, anterior component separation? Pramod, he has done plenty.
Yeah. Well, some of the papers don't support it, but definitely there are equal number of papers and personal experience also that anterior component separation, the bane of anterior component separation is surgical site occurrences. There is a slight difference though. The surgical site occurrences can be ghastly, but they are manageable. Whereas surgical site occurrences of a posterior component separation are less frequent, but they can be more disastrous also. But I would agree that anterior component separation, SSOs are more, and definitely that is a point against it.
Sumit? I mean, the time taken would be less?
I think it all depends on your training in the procedure. So if you are well trained to do either, I don't think there is a big difference. But yeah, because one is more familiar on to do the, the anterior component separation, because many surgeons have been doing onlay repairs as a routine. So I think they would take less time generally. But after you are well trained in posterior, I don't think there's that much difference.
So most of the data has shown that it is definitely quicker, the time wise. So also the blood loss wise, the blood loss of the transabdominal release is more than the anterior component separation. Yeah, Pramod?
More importantly, it is also easier.
It is?
It is also easier than the posterior tire component separation.
Correct. So it is easier to learn. And now this is something which is very, in fact, I asked Seen also, but he didn't come out with that. So suppose you are operating in a patient of say a large hernia, which has now come with an obstruction. And you need to go in. You have tried to conserve, it's not coming around. And now we have opened and you have done a separation of intestinal obstruction. At this point of time, patient got a defect of say around 12 centimeters. And in no way you will be able to close it. You don't have a vicryl mesh available with you. Now, how are you going to close it? At that point of time, already you have spent 3 hours of doing the release of all the intestinal adhesions. And now would you start a TAR procedure or would you do an anterior component separation?
Definitely anterior component separation is doable at this time.
Raman, what will you do? We have a stalwart sitting here.
So again, it depends on the exact clinical situation. The patient is high risk patient. I wouldn't even bother about doing anything other than just peritoneal closure and skin closure. We are talking about a situation where you have a sizable abdominal wall defect.
Correct. And suppose there was also an enterotomy and you have done a resection. Now what will you do?
Yeah, so that's what I'm saying. I would not do anything fancy at this point of time. AWR will wait.
Would you just close the skin and you think it will hold?
No, I would just close the peritoneum if I can.
It's not possible.
And if there is no peritoneum, you could
Others,
just do an anterior component separation and close it. But
yeah, Vikas.
Sir, if it's an emergency situation, it's really tight. I
You are
would
not
not, I would not do a component separation as far as possible.
So I think the one message which comes from all these people who are experienced is that component separation is not an emergency surgery. So it has to be avoided at every cost. But at times you do burn, and I have burned my fingers where there was nothing that I could close. And to leave that lady with the anastomosis, with the resection inside, open abdomen was again out of question, putting a vac was out of a question, getting any sort of closure was also a problem. And I think the rescue can be an anterior component separation, though it is not an ideal.
How about using a peritoneal flap herniaplasty in that case?
So here in this patient already.
If she has a big sac, that's what you're saying.
Yeah, so if it is, so these are as Ramana said, it all depends upon every individual case, but often it is not available, or it's too flimsy to rely on. You want to say something?
Can you put a negative pressure dressing and wait, optimize him and do whatever procedure at a
So in a patient where not closing anything, would you apply negative pressure straight on the bowel?
There are special abdominal negative pressure dressings which don't stick to the intestine, and you can apply them. They will also drain the peritoneal cavity very well, and you will be able to.
So something like Apthera or something. Correct. So I think that's another option that you have, but this is one which you can think of doing it this. And now this is a very, very controversial thing. So Bridge, do you think that our anterior component and posterior component, which will give more myofascial release?
Anterior component separation definitely give more myofascial release. At the waistline, it gives around 20 centimeters, around 8 to 10 centimeters.
And the posterior, Sumit, posterior would give how much release? You think it will give equal or it will be less?
I really don't do that much anterior, but I think about 8 centimeter either side for the posterior component separation.
Pramod, which one will give you a more myofascial release?
Anterior component separation gives her more myofascial release, is my experience.
So I think most of them are saying, Ramana, you believe it gives more
But the
myofascial release?
literature
anterior
doesn't say
component?
that. Yeah.
I don't know. I'm not sure. There are pretensions, but I'm not sure.
So I think in whatever little experience that I have seen it definitely gives a more myofascial release. But what the studies are showing something different. So this is one study which is done by Dr. Nowitzki's group. And they showed on a cadaveric model, the myofascial release after the transverse abdominal release was better than the anterior component separation. So this is one paper which was in 2018. And in the same year, somebody did another cadaveric study and said the anterior component separation gives more myofascial release than the posterior component separation. So I don't know, the thing is still very, very confusing. And there is still a third paper which talk about mineralization of combined anterior and posterior component separation in a cadaveric study again. So what they did is that they did the cadaveric study. They found that after doing a posterior component separation, if you add anterior component separation, it leads to a little more myofascial release, but at the cost of destabilization of the abdomen. And they have warned that probably it is not recommended. So that is where we are. So we don't know what works. But a lot of people believe that anterior component separation will give a better.
But it gives release only over the waistline. At the upper end and lower end, it is not much release.
No, Pramod says that for a subxified hernia, he would prefer anterior component over the posterior component separation.
Yes, but as far as the dimensions are concerned, the defect, the size of the defect closed is smaller in the epigastric and umbilical. That's right.
So it is more in the midline than
it is more in the periphery. Yes.
Right. Now, therefore, Pramod, you said you will do it probably in old patient, but what the literature says is a little different. What it says that in a young non-smoking patient with a normal vascular supply, anterior component separation is a better thing to do it. Do you agree? Because see, non-smoker, they say because the vascularity, there is no further vascular problem. So the chances of them having a skin necrosis is less. Smokers, that's why. And young people, because they don't have much atherosclerosis and therefore probably wound supply will be better. So that is the content, and those are the patients where probably ACST. But I think with today's, with the TAR, which is coming up in a big way, I think a lot of us have turned over to the posterior component separation.
Agreed.
Hernia defect with larger defect, longer defect. So this is one study where they showed that if the defect is more in length than in the breadth, then the anterior component separation scores over. Then the people who have more width than the length. So again, this is something, but I think if you have a very long defect, you can. I have done plenty with transverse abdominal release and it works very well. But this is what the literature, some of the literature says. Now, comparison between ECST, perforator sparing anterior component separation and a posterior component separation. So this is one study where they have concluded this, that ECST is best treatment to avoid SSO. That I think you agree, Pramod.
Yes, absolutely. Yeah.
Whereas perforator sparing gives the best treatment, avoid the recurrence. So this is what they say, that the recurrence is a minimum with perforator sparing as compared to endoscopic component separation. And that is probably because
We are able to.
you will have a less mesh
less
coverage in
mesh.
ECST.
True.
The
Absolutely.
ECST will have a less mesh coverage.
Correct.
As compared to the other this thing. Many surgeons have abandoned ECST. Now we have here a pioneer and the master of ECST, Dr. Pramod Shinde. But this is what they say, that because reportedly it gives limited release and a high lateral seroma rates. That's what happens. Have you ever encountered lateral seromas?
Yes, yes. Because though that lateral space sometimes needs drainage, sometimes it is a prolonged drainage, and that can be a problem.
So these are all the problems with
There
the
is a problem with that.
I think this may particularly be in the subcutaneous space. When they do a subcutaneous endoscopic ACST, that then it may be a bigger problem. But I think if you do a subexternal oblique endoscopic ACST, it may not that much be a problem, the seromas.
I agree with that.
Now, this is one more advantage which has been quoted, and I think most of the panelists would agree that as compared to ACST, in PCST, you don't raise any flaps whatsoever. So you're not undermining the skin at all. So therefore, obviously, the surgical site occurrences should be less. And that is what is there in most of the comparative studies, where they have found that SSOs are less in PCST as compared to ACST. Sarfaraz, if he's here, he may differ. Because you have said it well. Right. So now, where will you do a TAR now? And this, where will you say that the transverse abdominis release will score over the anterior component separation? Bridge.
When there is atypical hernias. Like
Right. So I think that that's a very, very valid thing, that for a hernia which is non-midline, for a non-midline hernias, the PCST or TAR would definitely score over the midline hernia. So therefore, definitely you will do a transverse abdominis release. So hernia with LOD, which is better, anterior or posterior?
Well, although the release is equal or maybe more also, literature says it is equal. The mesh coverage and the mesh plane being a sublay plane and less SSOs, TAR will score over that
Ramana, what
in
do you
LOD.
think? Just have a mic here. He is almost a panelist. He is more than a panelist.
So there's one important thing here. If you look at loss of domain, and there's a huge peritoneal sac, and you want to save the peritoneal sac. So by the time you dissect out the sac, a lot of the external oblique is exposed. A skin flap is already raised. So it does appear to be a good thing to just release the external oblique and then lay the mesh either in the Reeve-Stopa plane or in the onlay plane. All right. Now, an important thing here is if you lay it in the Reeve-Stopa plane, it may not be enough for overlap of the defect. So you may then think that this is not good enough. So if you place the mesh on the onlay plane, it may not be good enough on principle because you're exposing a large prosthesis to the skin and subcutaneous. So best bet is what the Henniford group does. They do an extensive preperitoneal dissection and lay the mesh in the extraperitoneal space, but do the release in the external oblique. But again, this means you're dissecting in two different planes extensively.
But for a loss of domain, you think which works better? Now I'm very, very specific question. Anterior component separation or posterior component separation? There is a loss of domain. That means there is a smaller abdominal cavity than what you want.
I'm not aware of.
No, there are studies done.
Specific thing other than people like the Henniford group have shown excellent results with the anterior component separation.
No, there is a study done wherein they say that if you do a posterior component separation, that means when your transverse abdominis release, the transverse abdominis release per se would increase the abdominal cavity. Because you are dividing a transverse abdomen which is gripping the abdomen. It is like doing a sphincterotomy for a fissure in ano. When you do a sphincterotomy, it opens out. So therefore, there is definitely in a patient of LOD, I would at least do 100% PCST and not ACST. But it may differ. It's still a very gray area.
Again, approaches are very variable.
Okay, fine.
I think we also do a lot of posterior component separation for these large hernias and with very good results. But peritoneal sac is one of the things which we always keep in armamentarium. even after doing a bilateral TAR, you may not get the closure or the overlap enough. So we save the sac, and sometimes, on one side we'll save the sac with the anterior sheath, on the other side we'll save the sac with the posterior sheath. And that helps in a good overlap and bridging, and then we place the mesh in the sublay position.
So that's the peritoneal flap herniaplasty. That's what you're saying. Multiply recurrent hernias, what would you choose? Anterior or posterior component separation? Sumit?
Well, I would err towards choosing posterior component separation.
Because most of the time, people who come with multiply recurrent hernia in India, at least so far, is onlay meshes. I think that is the reason that you would rather go to a posterior component separation. So that's what again will be my choice. If you have to
what do you choose for a post IPOM recurrence? Like we do see a lot of post IPOM.
That's what is coming. The mesh removal. Now, in case you have to remove the mesh, say it's an IPOM mesh, which is now coming with a big recurrence, right? And now you have to do it. And this mesh, you don't want to put those tacks and meshes inside the abdomen after doing a TAR procedure. And you have to remove the mesh. It will be a posterior component separation, isn't it?
We have left the mesh, IPOM mesh in many patients without any problem.
So if it is incorporated mesh, you can, but I think I would probably, because you are shutting the abdomen forever, going after a TAR for anything is going to be difficult. If that is one of the unfortunate patients who would go into an obstruction because of some adhesion over there, you are not doing a justice. That's what my belief. So I would probably do.
The problem in removing an intraperitoneal mesh is sometimes you will leave your posterior rectus sheath so tattered that, in the process excising the PRS along with that mesh, that the posterior closure will become difficult.
So
then you are going to add another vicryl mesh, again intraperitoneal, with again adhesion formation to it.
So we have come to this conclusion that these are two complex things. And therefore, I think, as he said, nobody without experience would venture. But yes, these are the process. On the table, you will have to keep on taking a decision that if you have to remove the mesh, if there are very bad adhesions, I think both will work. Anterior as well as posterior component separation. Extensive hernias, large hernias, non-midline hernias, parastomal hernias, big parastomal hernia, which is good, and anterior or posterior component. Pramod.
Definitely the posterior component separation scores because you are able to go into a sub-transversus plane. And anterior component separation, first of all, it will be limited by the stoma on the same side also. So posterior component separation.
Is there any role of ECST at that time? Because your stoma is within the linea semilunarius.
If it is within the
semilunarius, and do an external oblique release.
Yeah, but in India, at least we don't find stomas done so classically and anatomically. But if the stoma has been classically done within the rectus space, then definitely ECST can be done.
Okay. Defects near bony structures, I think that Sumit was trying to say that where there is near bony structures, probably anterior component would score over the posterior component. After ineffective release of external oblique, so that's a combined thing where you can do it. So these are all the where you will choose the TAR. Now, this is one study done long back. See, now 2016, Yuri did his first paper on 2008, and by 2011, this man had already done 646 TARs, and he found that the complication associated with wound healing occurred in TAR technique is similar. So he didn't find any difference, but the recurrences were definitely less. So all of you agree that the recurrences would be less with TAR or with ECST?
I think recurrences would be less with the TAR.
It will be TAR for one single reason, that you are putting a very wide prosthesis. You're putting a very wide prosthesis in a sublay position, which is sort of an ideal position, and therefore all the studies so far have shown a less recurrences in TAR. I think that is one thing which is very, very important. A TAR allows creation of an externally wide space. So, it's a huge space. They say it's almost 4,500 square centimeters. So you can put in what size of the mesh up. Recently, I put 160 by 50 mesh, 60 centimeter, 50 centimeter CCAT mesh, and it went very easily without even, I didn't even trim anything. So if you do an adequate release, you can put in a very, very huge prosthesis, that is giant prosthetic reinforcement. The drawbacks of TAR now. What are the drawbacks, Meenakshi?
So that is the last weapon in our armamentarium. So the thing is that the skill level required has to be very high. The experience.
Technically a very demanding procedure. So as compared to anterior, we said anterior component is easier. It is equally difficult to understand complex anatomy, learning curve, and tissue planes. Now bundle injury is very common after posterior component separation. So if an unwary, if you just chop off few of the neurovascular bundles, you have already done irreversible damage to the abdominal wall. and
I-
atrophy
I
of the
think rather
rectus.
it is advantage of the TAR that we don't injure the nerves. If we
Yeah,
do
so
that.
provided you protect the nerve. See, there in external oblique release, you can't injure any nerve. You're going into an absolutely avascular, but here you are close to the nerve, so you have to be careful. The risk of damaging posterior rectus sheath, I think this is something which is buttonholing, tears in open surgery and PRS breakdown, which is an Achilles heel in ETAP procedures which are done for the transverse. So these are some of the drawbacks of transverse abdominis release. Now
I think the potential for creating disasters is not there with the anterior component, but the potential for creating an abdominal wall disaster is there with the posterior component.
I think that's very, very correct, because
You can easily disrupt the linear semicularis with an anterior component separation, and there are plenty of cases which we see in practice where anterior component separations have gone through the linea semicularis and resulted in lateral hernias. These lateral hernias are not going to be easy to repair, and the rectus is atrophied as well. So the chance of a disaster exists with every surgery.
yeah, but I think given the choice, I think the posterior, the semilunar line injuries are more common. With
Absolutely, semilunar
This is
injuries
what
are
I
more
think.
common.
No, but
with-
we also have seen a lot more surgical site infections after anterior component separation, lot of mesh exposures, which is a huge trauma to the patient and the surgeon. While how many times have you seen a mesh infection after a posterior component separation? Hardly. I think abdominal wall disaster, looking at the overall picture, is much more common with anterior component separation as compared. That is why PCST has picked up. Otherwise, what was the role of PCST?
Sorry. So this is one of the disasters which happened after posterior component separation. So somebody attempted an ETAP TAR and see the bilateral semilunar line injury, huge hernias. It's like a huge Spigelian hernias, 16 centimeter wide on one side, 14 centimeter wide on the other side. And this is a completely screwed up abdominal wall. So this becomes a challenge for even the most experienced guys. Now, there are certain studies done to compare these two, anterior versus posterior component separation. There are several researchers attempted. The problem here is what, say they have taken, say, a retrospective data of ACST done by Dr. Pramod Shinde and PCST done by Dr. Punjani. If you can't compare them. So the people are different, the patients are different, the all demography is different. So, and then the meta-analysis. So everything is absolutely something which is not very reliable. So they are greatly hampered with the several technical variation, heterogeneity of data and differing approaches. So we have done one study because we have one group, me and Dr. M. Arora, we have been doing ACST and PCST both. And then we went ahead and we actually did a demographic, we just exactly similar patients of the similar defects, similar comorbidities and the hernia characteristics. And then we have compared. And with that, our results are that the retrospective study of almost 127 cases, it showed that with the similar groups, the PCST is more demanding, more operative time, high blood loss, but shorter hospital stay, lower wound morbidity and less recurrences. And I think most of the panelists should agree that this is what the PCST is this. So I think lastly, I would say that both these things are going to remain, and we saw even Sim talking about ACST. But as you develop in your this thing, I think you become from ACST. When I switched over to PCST, I said I will never do ACST, and soon I realized that that's not true. You have to come back to, so every procedure has a place, and I think that is the message that I would give it. The panelists, all of you agree that you cannot just do one procedure and say that I will do it for everybody, but there is a place for every procedure.
Absolutely, absolutely.
Thank you.
Thank you.
Thank you, sir, for the panel. Any questions from the audience? Also, Dr. Sean is still with us online, so if there are any questions, we have.
Yeah, he also.
Hello, I am Dr. Dave from Faridabad. Sometimes we come across lower midline incisional hernias, and it is difficult to close in IPOM plus. Can we add an anterior component separation endoscopically to close the midline defect and put IPOM plus mesh in the lower abdomen?
Yes. In fact, the case that I showed was a similar lower abdominal hernia. It can be very easily done, and endoscopic anterior component separation combined makes it not as extensive and difficult, especially if we do not have enough experience with TAR, and the hernia does not warrant a very big dissection. Then an endoscopic anterior component separation can be done, and IPOM plus can be combined. In any way, in a lower abdominal hernia, part of the mesh is going to be below the bladder flap and peritoneum. Correct. That is okay. Absolutely okay.
Sir, Dr. Chopra from Indore. I would like to say the posterior component separation is technically looks more difficult as compared to anterior. So what should be the minimum period for learning period or a technique to learn for a junior surgeon to go for it before he...
Can I answer that question?
Please.
So I think it is difficult. What you have to do is you have to go to a person or the place where there is a high volume. So like, you go to a place, if you want to go abroad, you can go to Scene or you can go to Yuri, Anu, practically do TAR every alternate day. So there you will be exposed to a large volume of work and then learn it systematically. But we have, as an AWR initiative, we have started cadaveric workshops. So one which is happening tomorrow, Dr. Jignesh Gandhi is doing it at KEM Hospital. So we run such several workshops. And I think that is where your understanding of the anatomy, it clears, and then you should attempt. And then also you attempt with somebody around, see a couple of cases before that, ask that person to wash up with you, see it with him, and then slowly, gradually you take over. I think it has its own learning curve. You can't just do it. People have done it. We are seeing in a YouTube and then creating a disaster.
I think maybe we can ask Sean also, because learning curves have not been so well studied in component separation as they have been in inguinal regions.
Yeah,
so
Sean,
maybe
can you just give your advice?
Yeah, I mean, it's interesting. I don't think there's a specific number of cases that, can you guys hear me okay?
Hello?
Yeah, we can hear you.
Okay.
Yeah, we can hear you.
Okay, great. I don't think there's a specific number of cases that you have to do, but as I said in my talk, it is so important to get your hands in there. And this is where things like cadaver lab training, animal labs, you need to start making some holes and figure out what's going wrong in order to overcome that, to see what works, really understand that anatomy. I think we all have a general understanding of the anatomy, but until it's almost like you need to start making some mistakes to learn what not to do. And certainly we don't want to practice for the first couple of times in a live patient, where then we have to overcome all those potential complications. So, I mean, for me, I would think it would be at least 20 plus before you even start to get an inkling of feeling comfortable developing that plane. And some patients are easy and some patients are quite hard, even in virginal planes that have never been operated on.
Yeah, Dr. Punjani, can I have a question?
Hello? Yeah.
Yeah. So, Sean, if you're hearing this question, this is Dr. Sarfaraz Beg. I would like you to also comment on it, as well as the entire house. So largely this session was talking about a comparison between an anterior component and posterior component separation. And I think if you look at the US data, where they compared 3,000 PCST with 800 ACST, they found that there wasn't much of a difference. Much of these cases actually come from Dr. Butler's unit, and they did not find too much of difference. Probably they used perforative sparing ACSTs. But I would definitely like to also know whether this data can be just early data, maybe the long-term data would be different, or are we looking at different things? Why is it that the data does not show that PCST is better than ACST? We did a review recently on SSI after ACST versus PCST, and we found that the SSI rates are equivalent, both superficial, deep, and organ-specific SSI. So I just want to know why the literature doesn't support the superiority of one component separation over another.
I would argue that literature supports both techniques for various reasons. And as with anything in the literature, you're going to find a lot of papers that support one thing and a lot of papers that support others. One of the slides I kind of skipped over because of timing was written by David Krapata, and it did compare posterior versus anterior component separation. I think it looked a little over 100 patients, and there were significant differences. Wound complications rate were 48% with anterior versus 26% in TAR. Recurrence rate was also big. It was 14 versus 4%, talking about anterior versus posterior. So there is data that shows some superiority, especially with wound morbidity, of posterior over anterior. But as with anything in hernia and ab wall, there's pros and cons to everything we do. And so that's why, as much as I'm a proponent of TAR, I think we need to know it all. TAR can't be for everything. And so it's important and behooves on all of us to know all the techniques. So if I can't do a TAR for whatever reason, and all these wonderful descriptions that you guys just described, we gotta have other tools in our toolbox, and anterior component separation is one of those great tools. Conversely, if you don't know how to do a TAR well, but you excel at doing an anterior component separation, that's still a really good procedure, and you can get good outcomes with it in the right hands. And one thing we have not talked about is preoperative optimization. With any procedure, with these, if you optimize your patients sufficiently, you're going to reduce your morbidity, and all these numbers that we see in the papers are going to go down, and you're going to benefit your patients by optimizing prior to any type of myofascial release.
Thank you, Dr. Sean. We'll just take the last question from this panel.
I have a question for Dr. Shinde. Good morning, sir. We're discussing complex hernias here, but we know when we do an ACST, we are putting the mesh in the onlay plane. So for smaller hernias, do you think onlay repair is, if we see that the sheath is coming together without tension, and we want to put an onlay mesh, do you think it's okay, or we should prefer the retrorectus space for putting a mesh?
See, in India, onlay repair has been done right, left, and center, but we do not have data to show how much of SSOs and infection and complication rates of that. A lot of recurrences are also seen. So although onlay seems to be an easy procedure, it seems to be universally available, everybody is doing it. Data has definitely shown that the best plane of the mesh is a sublay plane. So even for small hernias, if we are able to learn and put the mesh in either a preperitoneal or a retrorectus plane, that is a better option. So I would say that the data is supportive of the sublay plane. Therefore, let's move more and more towards the sublay plane.
Thank you. Thank you to all the panelists for such a comprehensive discussion. We'll now move on to the fourth session on lateral hernias.
For the first talk, I would like to invite Dr. Rahul Mahadar for his talk on ETEP and IPOM for lateral hernias. Dr. Rahul Mahadar is the Medical Director of Jeevanshri Hospital, Mumbai, and he is a practicing GI surgeon for the last 20 years and a founder member of the Abdominal Wall Reconstruction Surgeon Trust India. Dr. Rahul Mahadar.
Give us 1 minute. Yeah. At the outset, I thank Dr. Vikas Singhal and Dr. Adarsh sir for giving me this opportunity for this presentation on the lateral hernia section. Yes, sir. So, lateral abdominal wall hernias. Lateral abdominal wall hernia defects are defined as the hernias and bulges or surgical wounds that occur within the anatomical region bounded by linea seminonaris, paraspinous muscle, costal margin, and iliac crest. Now, what are the causes for the lateral wall hernias? We know that the congenital causes are there, but moreover, what we see in our day-to-day practice are the traumatic injury and the surgical interventions. Now, the incidence is stated in the literature is ranging from 8% to 57%, with 14% following nephrectomies and 20% following retroperitoneal abdominal aortic aneurysm repairs. And there is one classification which has been suggested for lateral wall abdominal hernias, which is came into existence in 2007. It's a EHS, European Hernia Society classification. They have divided into 4 anatomical regions: subcostal, flank, iliac, and lumbar. Now, according to this, there is some surgical management which has been decided. There are several surgical techniques that are proposed, and that will depend mainly on the incision placement, then the type of mesh used, location of the mesh placement, then extent of the mesh reinforcement, and surgical approach. So, and there is also special consideration is given to the defects that crosses the adjacent regions or require additional soft tissue reconstruction along with the hernia repair. Now, the procedures which are proposed for lateral hernias are open repair, laparoscopic or robotic techniques, intraperitoneal onlay mesh repair, transabdominal preperitoneal repairs, E-tape repairs, and moreover, now is coming into existence is a hybrid modalities, open plus laparoscopic or sandwich technique. I'm Dr. Rahul Mahadar today in front of you. I'm talking about only a technical aspects of E-tape for lateral hernias. Now, post-open cholecystectomy hernia, if you want to go for the E-tape approach, you are going to the opposite side of the retrorectal space first, then doing a midline crossover in the lower abdomen, and then from below up, from the suprapubic region, you start dissecting and do a bottoms up TAR, and then that particular part is reinforced with the help of a mesh. Post nephrectomy or appendicectomy wounds, which are large hernias, in those cases also you can utilize this E-tape technique, wherein without doing a midline crossover, you can do the procedure, wherein you can put the dissection on the right side retrorectal space, and then from below up, you are doing the TAR procedure, transverse abdominal release, and then that area is reinforced with the help of a mesh. Post-open appendicectomy, in these patients, there also you can, there are two methods. One is doing starting from the opposite side first, going into the hypogastric region, doing a midline crossover, then going up, and then doing a partial or complete TAR on that particular side, and that area is reinforced with the help of a mesh. Or otherwise, you can do without doing a midline crossover also, starting on the same side on the right side retrorectal space, and then putting a trocars into that particular plane and into a preperitoneal space into in the hypogastric region, and then go laterally and doing a bottoms up TAR, partial or complete, and then reinforced with the help of a mesh. Post open urethrolethotomy, wherein you can do the E-tape procedure, wherein you are going on the same side in the retrorectal space, going into the preperitoneal space in the hypogastrium, and then putting a port there, and then approaching this particular hernia and doing a bottoms up limited TAR, and then that area is reinforced with the help of a mesh. Here is first case. 59-year-old female patient operated for open left urethrolethotomy after failed ureteroscopic lithotripsy 4 years back. Stormy post-operative period, now presented with left lateral wall hernia. Now you can see here the hernia. Now this was actually switch, like a Swiss cheese defect. Now I started, I decided to do a E-tape procedure for this particular patient. And here you can see I've started on the same side of the hernia. Retrorectal space dissection is done. Then through the umbilicus, just below the umbilicus, I put other trocar, and then in the midline, in the hypogastric region, the two trocars, the optics is shifted to this, and then I have done the reverse or bottoms up TAR on that side, and then that area is reinforced with the help of a mesh. Now here I have started with the balloon, because this is around 4 years back I have done this procedure. After doing the retrorectal dissection, I have gone into the space of Regis. That dissection is carried out. You can see very well here the pubic symphysis and the pubic bone. Laterally, there was some adhesions because of the previous placement of the drain site. So I have to dissect in that area, and then I have put a trocar in that area, and then started dissecting towards the hernia. Now here the hernia is started here actually, and there is a posterior rectus sheath as well as the peritoneum. I have tried to go in between that plane. And started dissecting up. This is arcuate
arcuate fibers. These are arcuate ligament fibers, and those that is dissected. Try to preserve as much as peritoneum as possible that can be utilized for the closure later on. And then dissected laterally. Then I have to open the make an incision over the peritoneum and look inside. You can see here there is a omentum as well as some bowel loops that are going into the hernia sac. So adhesiolysis is carried out with the help of a harmonic scalpel here. And then while doing so, I am doing only adhesiolysis. Then the second part, I have taken the peritoneum down. Now you can see here large defect with switches component in between. And then I started doing the bottoms of tar with the help of a hook. So bottoms of tar is carried out on that side, taking only a posterior rectus sheath, because as you go down, there is only posterior rectus sheath. There is no muscles as such. As you go up towards the epigastrium, then you will get the muscles. So here, while doing so, a care has been taken not to injure or make a rent to the peritoneum. And then I'm dissecting. First, I have dissected the tar plane, gone completely laterally down, and then again shifted my focus towards the sac. And now here I'm taking down the sac and peritoneum down so that I can utilize it for the closure, and taking down the peritoneum and the sac part. So after complete taken down from all the sides, and here the care is taken not to injure the iliac vessels because those are near in that area. So you have to be very careful while dissecting. So this sac is completely dissected down, and then you can see now the defect. So to approximate the defect, what I have done is I put a echelon stay sutures, transfacial, to approximate the defect, and at the same time the CO2 pressure is taken down to 6 millimeters. And then I started closing the defect with the help of a V-lock sutures. Just traction is given from outside, and then I have started suturing, and then this approximation is possible. So after doing this complete approximation, the hernia defect is completely closed. And then the peritoneal rents are closed completely with the help of, again, wherever possible, it's a V-lock sutures or a Mixon 20 sutures. And after completing the dissection, this entire area has been reinforced with the help of a mesh. So these are the final picture before putting the mesh. And then I have put a polypropylene mesh. But here I felt after putting this particular mesh, I still felt that the lateral part of the abdominal wall is not sufficiently covered. So I put another mesh over there, and that has been fixed on the lateral wall. And that mesh is fixed with the help of absorbable tackers, and the drain is put into this particular area. So this is the picture after a 9th post-operative day, and this is the picture after 1 month of the operation. I'm still following this patient. It is now almost 4 years. She's doing well. Now, case number 2 is a 61-year-old male patient operated for bilateral inguinal hernia open repair 18 years back, operated for umbilical hernia repair 4 years back, operated for open appendicectomy 2 years back, and now presented with bilateral inguinal hernia recurrence with a right lateral wall incisional hernia. Now, you can very well see here the hernia into the intramuscular plane on the lateral side at the appendicectomy scar. And you can very well see the herniation of the bladder into the left inguinal canal, left inguinal hernia site. And these are the hernia sites. I have made a surface marking. This is my usual tendency. And then I started with the E-tap approach for bilateral inguinal hernia. These are my port positions. Started on the left side retrorectal space, then done the midline crossover in the hypogastrium, then again put a trocar into the suprapubic port, and from bottoms up, below up, I've done limited tar and taken down all the adhesions, and then this part is reinforced with the help of a mesh along with both the inguinal hernias. Those have been reinforced with the help of a mesh. Now here is, I'm going inside on the left side retrorectal space. So after putting a second operating trocar, I'm dissecting towards the space of radius. And after dissecting into the space of radius, I've started reducing the hernias. This is at the left side direct inguinal hernia. I've taken down this large sac. So that is dissected. Give me 2 minutes. Now this is paralyzation of the cord structures. Then this is a left side direct inguinal hernia, large hernia. Then the right side inguinal hernia. Then I put a trocar into suprapubic region. And from bottoms up, I started dissecting laterally. And first I have dissected on the right side retrorectal space. And then here you can see the rent and the hernia inside and the adhesions on that side. And this hernia contents are taken down. As far as possible, I preserve the peritoneum and sac so that I can utilize it for the rent closure in the peritoneum, and then reverse bottoms of tar is started. Here you can see all the adhesions along the incision site. And now everything is after adhesiolysis. I have closed this lateral wall hernias, honeycomb or Swiss cheese defect with the help of a non-absorbable V-lock sutures. And after closing the peritoneal rents, I have put a large mesh into this particular area. Yes, just 1 minute. And then put a mesh on both the sides, and all the mesh are fixed with the help of a non-absorbable, absorbable tackers. 1 month follow-up after the procedure, and patient is doing very well. Thank you very much.
Thank you, sir. Next up, we have a talk by Dr. Sharat Sharma on lumbar hernias, TARM versus TAPP versus E-tip versus open. Dr. Sharat Sharma is a pioneer of advanced laparoscopic surgery from Navi Mumbai. He is a diploma in advanced laparoscopic surgery from GEM Hospital, Coimbatore, and is one of the founder surgeons of Department of Minimal Access Surgery at Hiranandani Hospital, Vashi. Dr. Sharat Sharma.
Thank you for the kind introduction. Thank you, Vikas. Thank you, Dr. Adarsh. I have this difficult topic, It's lumbar hernias. So it's not lateral hernias, it's lumbar hernias. And again, I would say TAM versus TAP versus ETAP versus open is pretty unjust, because I think these are rare hernias. And frankly speaking, EHS, AHS, all of them have recommended that as lumbar hernias, they are rare. And there is no data on any preferred technique or a method that exists. So I have to skim before that. I'll just give you a brief introduction of lumbar hernias. So it's about 1.5% of all the ventral hernias that we see. That's pretty rare. Barbet is the one who first coined the name lumbar hernia, and then they were also called costo-iliac hernias, coined by Torek. Then there was the Petit, who described the inferior triangle, then the Grinfeld-Lesaft, who described the superior triangle. Of course, then came the post-traumatic lumbar hernias, which was first published by Selby, and then incisional hernia was reported by Kelton. Finally, it's the EHS which gave a classification that the spontaneous ones were called lumbar, and the acquired or the traumatic incisionals were called the L4 hernias. The most difficult part for me was to get data on this, because being rare hernias, you know, as literature goes, there must be less than 500 reported hernias since ever, you know, in last so many years. All I found was case series and case reports. There were some interesting expert Facebook videos, expert YouTube videos, expert SAGES videos. Nothing beyond that. I didn't have anything of my own as far as videos are concerned. But I had a lot of friends around, so I asked, and this is what I have as of now. Coming to the case report, so the first one is a case series. This series is by Shen et al., and they did open under local anesthesia. They had 28 patients over a period of 10 years. They used an array of meshes like the Ultra Pro plug, hernia system, Proceed, and even in one case, they did a sutured repair. They had an overall recurrence rate of 1%, I mean 3%. That is one case in 28 cases. It's pretty acceptable, I feel. So this is one technique which they have done. So, I mean, there are various methods surgeons all over the world have tried, and I think all of them have got acceptable results. The second is another 14 patient series where done by Lin et al., and they had 14 patients over a period of 2 years, retroperitoneal mesh placement according to their literature, and they had no recurrence at all. So I think, again, it's pretty good, an open repair, simple repair with no recurrence. We have Bigolini giving us a case report on a 6.5 centimeter mesh, 6.5 centimeter defect with a tension-free repair. So what they did was he put a sandwich. So there was a pre-peritoneal mesh and an onlay mesh, and there was no suturing of the defect. And he was very happy with it. So he said that because there was a bony interface, he wanted to reinforce that bony interface and did not want to suture the muscle over it. And he had no recurrence after that. I have one small publication of a case report of my own where we had used mesh sutures. So we have in 2 layers, we have sutured with 4 mesh strips, and over 2 years, we have seen, you can see the CT before and after 2 years, it is a pretty acceptable outcome. So even mesh sutures work. Then we have single incision laparoscopy. So we have Nakahara, who did a 5 centimeter incision for a Grinfeld hernia, 3 independent trocars, and a flexible 5 mm scope with meshes. And he has a pretty acceptable, you can see he is using a self-gripping mesh, and it is a pretty acceptable incision and a pretty acceptable outcome. Tape has not been spared here. So there is a series of 14 patients done by Shen et al., and they have over 5 years, they have done 14 patients with most of them have been EPTFE meshes. And you can see maybe there were large hernias where they preferred to keep part of the mesh outside. But again, they have reported good outcomes. Of course, TAP was also reported by Michel Garnier, but I would shift to the more interesting TAP, that is a robotic TAP. So there was a series of papers presented in SAGES in 2018, and out of which I would be interested in presenting to you this by Jenny Lam, and I would actually even keep her audio on. This is by Jenny Lam doing a wonderful robotic TAPP for lumbar hernia. It's not playing. Can you help me play it? thing there. I'm sorry. The most interesting media is not playing. It was a very cleanly done surgery. Online, you have, is it on the net? Yeah, it is on YouTube. It is on YouTube. Is YouTube on here? Only thing is it's too long. So I had actually concised it into a small video. No, there's no internet here. No, I cannot bring it out. This is an incorporated video. It's okay. I still have another interesting video by Professor Keyur. He himself is very much present here, and it cannot play the video, so I'm sure it will not play the video. Jenny Lam. It's a Sage's video. हो जाए? I think that's the one. No, I edited it, so I remember. It's a wonderful video, so nicely described. It's a wonderful video. Lumbar hernia, only. दूसरा दिखा देता, but I have no display. Yep. So you can play her sound also because it's pretty. Yeah, that's right. It's playing. You can play the sound, please. No, it's a 4-minute video. So this is a right-sided. Yeah, we can end this. Yeah, we can end this. Unfortunately, I think I have been told none of the videos are going to play. So I'm going to have a tough time. So anyway, from TAPP, we proceed to our evidence on TEP. So the more preferred method now is being the TEP, and we have good case reports, again, only case reports, as I say. So we have Lim et al. And of course, even Cristiano Claus, who have given their case reports on TEP with about 3 ports, and a pretty easily done according to them with no recurrence. But then the concept of lateral ETEP came in. So what Jorge described in his Spanish paper is that most of the maneuvers which are initiated for ETEP are medial, are retrorectus, but it is possible to actually go lateral to the semilunar line and then do ETEP, which he coined it as a lateral ETEP. And again, there is a video. I don't know if I'll be able to play it. Let's see. I think it's not playing. So this was a nice video by Jorge Diaz, which was actually on Facebook and which he has referenced in his paper. So I really didn't know that you can reference a Facebook paper, Facebook video on paper. So, but it was very well demonstrated, and there is a much larger space that can be seen on a lateral ETEP as compared to an TEP for lateral lumbar hernias. Another great video is by Professor Keyur Yagnik. So this he has presented in our ANZ AWR conferences. Unfortunately, even this is not going to play. The interesting part of Dr. Keyur's video was that he had a scope inside the peritoneum, and through that, he actually visualized his optical trocar coming into the preperitoneal space and then creating a preperitoneal pneumoperitoneum. So I think Keyur's that aspect was pretty interesting. And then it was more like a lateral ETEP that he had done. And then finally, through that optical trocar, he entered, and then he created blunt spaces, blunt dissection, and created a space, and subsequently did his closure of the lumbar hernia. In case your lumbar hernia is large and repairs require, oh, is it so? Oh, thank you. Thank you. Thank you. So it is actually not playing from my computer, it is playing from their computer. So you can see. So we, oh. ये वो लेकिन डॉक्टर केयूर का बज रहा है कोई बात नहीं वो नेक्स्ट आ जाएगा वही चल रहा है. So I think you may be able to see this video. So this is Jorge Diaz's video that I wanted to show you, and he is using a balloon to create a lateral ETEP space, and subsequently he is now introduced his 2 working trocars, and you see that as compared to TEP, there is a much larger space. The hand instruments are much deeper inside. You can see that his visualization is much wider, and the comfort of working is much more. There is a large defect that you will see, and he will suture this large defect and then place a mesh. This is the large defect, about 6 centimeter size defect that he has shown. And he will ultimately end up suturing this defect and placing a large mesh. This is Dr. Keyur's video that you can see. And I would just fast forward it a bit. I already described this. Maybe it's interesting to see. This is a peritoneal visualization of a preperitoneal CO2 insufflation. It helps. And here he has entered with the scope into the preperitoneal area. This is the defect or the herniation. He will be introducing the subsequent 2 trocars. He has beautifully shown the iliohypogastric and the ilioinguinal nerves, the psoas and the diaphragm. This is reduction of the hernial sac. Always remember the 12th intercostal nerve will always be there in relation to the Greenfield hernia. And the roof of the Greenfield hernia will be the latissimus dorsi. So these are some landmarks which you must know so as to give a better repair and not to encompass or entrap the nerves. So as I was talking, in case there is a large lumbar hernia and you need to do a component separation, what are the options? Well, the most commonly known TAR is with a bilateral reeve stopa with a crossover. But you can modify the TAR procedure, and I think Dr. Rahul has already enumerated it. So we do an ipsilateral TAR, which does not require a crossover, with ipsilateral reeve stopa with a TAR. We can also do a bottoms-up TAR with an ipsilateral reeve stopa. And finally, what you can do is, in case you are not sure if you need a TAR or not, what you can do is you can go ahead with a lateral ETEP, do your dissection, and once you realize that your defect is too large for a simple closure, you can go with a bottoms-up TAR or a reverse TAR. I would leave you with this one last slide or a question. So if you have a lumbar hernia with complexities, what do I mean by that? So there is a 60-year-old man with a BMI of 40. He is type 2 diabetic. He has had multiple laparotomies. He has had a radical cystectomy. And now he has an ileal conduit. He also has undergone a renal transplant. Now he has come to us with an obstructed parastomal hernia and an 8-centimeter lumbar incisional hernia. Now, this is a complex patient. I would like to know, would you have a different approach to this lumbar hernia, or would you approach the lumbar hernia at all in this patient? I mean, this is a question I would leave to everybody. Thank you very much.
Next up, we have the panel discussion on lateral hernias. For the same, I would like to call Dr. Sarfaraz Beg as the moderator. Dr. Sarfaraz Beg is the head of GI Minimal Access Surgery and Bariatric Surgery at Bellevue Clinic, Kolkata. He is the Vice President of Hernia Society of India and a Global Coordinator for TUGS Hernia. As for the panelists, I would like to call Dr. Mukund Khetan, Dr. Sharad Sharma, Dr. Rahul Mahadar, Dr. Pankaj Hans, and Dr. Sumit Shah.
It's a pre-lunch session, so we stand between the lunch and these gentlemen here and ladies here. So we have a great panelists for a discussion on lateral hernias. First of all, it's an honor to have all of you. It's an absolute honor because all of you have been producing great results. I've seen your work, so it's a great honor to have you all. Sumit, Tarun has not come yet, so Sumit is here. Sumit Shah, Mukund, Rahul, Mahadar, Sharad, Sharma, and Pankaj. So we have all of you, and I welcome you to this. First of all, I'd like to wake you guys up with an audience question. It's a little dark, but I think you will get it. So for the audience, you get a Cadbury's 5-star if you name it correctly. What is the name of the hernia? No 5-star takers, no sweet tooth. M5 hernia. Ramesh bhai, never trust me.
Yeah.
Okay. Nobody wants to take a chance. What hernia is this? Nobody wants to take a chance. So I was told by Vikas to make it interactive. That's the hernia. Now we'll show you why the hernia is there. Okay. You are too hernia minded. That is my first submission to you all. You're too hernia minded. Let's make it easy, boss. Let's make it easy and palatable. Hernia is not that difficult. It can be solved by easy methods. So recently, Josna was kind enough to call me in Maharashtra, and there we presented a panel discussion on incisional hernia. At the end of the session, after 1 hour, a gentleman, a very dear friend, and he spoke wisely, and he said, all you said out here in this dais doesn't make sense to most surgeons in the country. It makes sense to you, only you. So I decided that we are going to do a different kind of a panel discussion where we will discuss it at the level of what should happen in the country and not at the level that you can perform. All of you are brilliant surgeons, but let's keep brilliance aside and let's come back to common sense. So let's start with that humble prayer that we'll talk only what is applicable to everyone. Lateral hernias, largely subcostal lumbar and iliac fossa hernias. Mukund, what are the problems with lateral hernias compared to a midline hernia repair?
Like they are near the bony boundaries.
Yep.
So then you have a limited space of working. So you need a larger overlap. Another thing is, besides anatomical defect, there is a denervation defect associated with most of the lateral hernias. So you need to address the denervation defect also associated with an anatomical defect and a larger overlap because of a bony areas over there. And then you need to counsel the patient.
I want the problem first. Solution comes later. What are the
bulge?
problems? One
So
is
bulge is
course-
there. So the problem is of a bulge. One is anatomical bulge, other is a denervation bulge.
Okay. Any other problem anyone can think of? How do you fix the mesh in these areas when it's so close to the bones? Difficult, right?
So you need a wider overlap.
Yeah. So the problems are that these hernias, lateral hernias, are close to bones and important structures like diaphragm, iliac vessels, nerves. So all of us as surgeons, we face difficulty. We don't know how to now put it, because if you put it onlay, how do you fix it to the rib cage? If you put it sublay, it's not always easy. So how do you do that? So, Sharad, what are the possible solutions as a common general principle in these hernias? How can we manage these patients where it is so close to bony structures? What are your tools?
Well, I mean, as a question, it's a very broad question.
Yeah, broad question, general perspective.
So first of all, the patient should be coming to you for the surgery. I'm assuming that the patient has come to you.
I'm also
for repair
assuming.
of the hernia. I mean, staying on the ground, as you said, we need to really discuss things as they come.
Yeah.
So first of all, you would like to evaluate the causes of hernia and the extent of hernia.
Yeah, the technical solution. It's close to bones and iliac structures and diaphragm and the heart. So is there any technique which can obviate these problems?
So then it's the preperitoneal approach,
Okay,
which will
yeah.
be the most obvious.
Yeah. So extraperitoneal repairs can obviate these problems. Yeah. And Sumit, if we were an intraperitoneal surgeon, not everybody is so adept at doing extraperitoneal repairs, Sumit. So what can we do? You think these other repairs like TAP, TARM, IPOMs, can they work too?
Yes, and don't miss the hybrid repairs.
Yeah.
Yeah, so they work very well because you can do close the defect without requiring component separation. Many of these endoscopic procedures would end up requiring component separations, which a hybrid procedure would not. And still you could get a wide overlap of the mesh.
I think that's a huge benefit. So let's go to the specific case now. Pankaj, this is the case, 55-year-old female, 35 BMI, has a history of open cholecystectomy gone haywire. How would you like to evaluate next? That's the clinical picture.
That would be the difficult question. See, first of all, we'll do CT scan.
Okay.
See, what are the components of this hernia and is there a domain loss or not?
Right.
And if it is, then we need to counsel the patient that yes, we may require the TAR or because this is a little hernia and we may need to mobilize all the muscles in the area.
Yeah, we'll come to that. I'll just ask you to read the CT for us. This is the CT of the patient. Yeah.
As we can see, there is a thinning of muscles.
Yeah.
Transversus abdominis is very thin in the lateral plane.
Hmm. Yeah, so it's a fairly big hernia, wide defect, looks like a 7-8 centimeters. The rectus is probably not there, right?
Denervation injury.
Right.
And basically,
Denervation.
this is because of the innervation loss.
Okay. Okay.
So, whatever procedures.
Yeah, so you think it's LOD, right? So maybe the Tanaka index is also 20-25% in this patient. So Rahul, I will go to you. You master of doing minimal access. Can you do this minimal access? Or if you don't do this minimal access, how do you choose your subcostal hernias where you can do minimal access and where you cannot do minimal access?
See, my take on such type of hernias where I have to go for either open or MIS. In those cases, I see the defect size, the part whether it's a LOD or not, and the how much is the content, the sac size. Because the sac, if it is more and bigger, then I prefer the hybrid approach more than the only laparoscopic approach or MIS approach. And open approach is when the defect size is more and it is more over going from one region to other region. So two regions together, like subcostal region along with the lumbar region, if it is there, then I'll more prefer to go for the open method than the MIS way.
Okay, all right. So Sumit, it will go to you, Tarun. So incision for this patient. If we go for an open approach, because this is clearly a very big sized hernia, and most of us would go for an open approach. Sumit, what would be your incision in this case?
Well, I would tend to incise over the previous incision. I would give a subcostal incision again or a lateral incision again, because there have been occasions where I burnt my fingers trying to give midline incisions in these patients, and then the lateral defect does not close. And then you end up, if the anterior sheet doesn't close, and then if you end up giving a lateral incision also, then you pull it laterally, then the midline becomes deficient. Yeah. So you cannot pull it both ways. So definitely, you should avoid a midline incision, in my opinion.
Yeah, been there, done that, repented. Mukund, the plane of mesh in this patient, let's say you're doing this open surgery, as Sumit said, with the subcostal incision. What are the planes that you're going to open up, and where would you put in the mesh? Of course,
So the preferable plane will definitely be a pre-peritoneal plane, a retromuscular plane. That would be a preferable plane. But if the surgeon is not very well versed with that and he is not able to dissect, especially in the supracostal area or posteriorly, then one can dissect in between the internal oblique and the external oblique. So that is another plane. That is an intramuscular intraparietal plane where one can dissect it, close the defect, that is the peritoneum, and then you can fix the mesh, because the external oblique is going way above the costal margin anteriorly. So you can very well dissect in between these two muscles and can place a mesh over here in this.
So the mesh is going to go superficial to the costal margin?
Superficial to the costal margin behind the external oblique muscle.
Yeah. So Mukund, great answer. If the PRS peritoneum, let's say you said about going for the pre-peritoneal plane with the TAR plane. But in the TAR plane, very frequently with these surgeries, they're so scarred, the PRS peritoneum complex keeps on tattering. What are your bailout options?
So bailout options like you have a larger sac over here, so you can preserve the sac, as we do in peritoneal flap hernioplasty for midline hernia. So the lateral hernias usually they tend to have a larger sacs, and there's a bony margin, so the sac becomes more larger, comparatively easier, because there is less of muscle denervation injury associated. So you can utilize that peritoneal flap to cover up the posterior part. The anterior part is a bit difficult because of denervation injury, because near to the costal margin. So many a times you might have to use a peritoneal flap itself, or maybe suturing the muscles directly to the mesh itself.
Yeah. Just to emphasize what Mukund said, the plane of dissection does not necessarily need to be TAR plane. In fact, it's in this paper by the Scottish group, they used external oblique, internal oblique layer, where you would argue, okay, this is going to denervate. But then there is also already a subcostal incision. Everything is already denervated. So there is no thought process that if you cut the linear seminaris, you would injure more nerves. You might injure one or two proximally. So for the benefit of everyone, it's important to realize medially the retrorectus plane and laterally the external oblique and internal oblique plane is good enough. And you're not damaging any nerves anymore because you've already damaged from the previous incision. So very, very important point when it comes to subcostal hernia. And most of us do open surgery. So it's important to remember this. Now, Sharad, let's say, what many of these subcostal hernias, they have the superior margin, which is the costal margin itself. There is no superior hernial defect edge. It is the costal margin. And it is difficult to close. The defect will not close. Then what?
So the peritoneal flap or the edge of the hernia is definitely important to be preserved. So we must always remember that that is required till the end of the time, till you close the defect. So that will be one important aspect. So peritoneal flap will be a good option.
Okay. So peritoneal flap is one good option. And the other one is the bridging repair, right? I think sometimes we just cannot close. So how many in this crowd have been able, have resorted to bridging repair in subcostal hernia repair? At least sometimes? Never? You guys have never done a bridging repair for subcostal hernia repair? That leaves me alone in the house. Okay, so that's me. Vikas has done it. Pramod Bhai has done it. Yeah, it's nothing to be ashamed of. And onlay mesh, how many of you have done onlay mesh for subcostal? Yeah. So, it's difficult to close subcostal hernias. If you've done like 50, you probably not closed 10. I probably not closed 10 to 15, I would say. So these are our bailout options for the interest of the audience and surgeons here. The defect is not closing. You have the peritoneal flap technique. You have the bridging repair, but you have to fix well then. And lastly, the onlay mesh repair will still hold good. How would we fix the mesh to the bone, the costal margin? Anyone? What would be your preference of?
There are bony anchors. Bony anchors
do
are
bony
there, so we
anchors?
can use the bony anchors.
Okay.
You
to
can
fix.
use the proline, take the periosteum and
Around the rib.
Yeah.
Yeah. So there are some techniques. Yes, bro. You use bony anchors? Yeah, I'm costal margin. Iliac bone, yes, we have used, but bony in rib cages, have you used it?
No, I haven't used.
So yeah. So sutures going around the rib is also not a bad idea. It holds good, leads to a little bit of pain. So peritoneal flap we've been talking about, and it's important to talk about it all this while because it is really a helpful tool in the hands of majority of surgeons. So this is just to give you an example. These are the left paramedial incision gone haywire after colectomy. Look at, you cannot close that defect by anything you do. It's a narrow abdomen, abdominal girth is too narrow. What can you get? So the peritoneal flap comes to rescue. Imagine the amount of peritoneal flap you get for these lateral hernias. Pankaj, macroporous mesh or a microporous mesh in these cases? In the subcostal hernia, we're talking about the same case now.
Everywhere I use always macroporous mesh, so I don't have any doubt using this mesh because of the less chances of less chances of seroma formation in this. So I would rather use macroporous mesh.
Macro. Anybody else would differ?
Heavyweight mesh, yeah.
Rather than the porosity in lateral hernias, I will prefer the weight of the mesh.
Yeah.
That is most important.
Heavyweight mesh.
So unfortunately, do we have macroporous heavyweight mesh in the
No,
system?
we don't. So they are medium weights. Yeah.
That's why I use that term.
Yeah.
So all of you would use heavyweight.
Correct.
Okay. So I would also
It
tend to use
happens to be
heavyweight.
microporous, that is another matter.
Sorry? Which one? SICAT. Wow. Can you share that on the group?
PVDF is too costly.
That would be nice. Is it available? Okay. So now for the audience, do you offer surgery to all your subcostal hernia patients? When the patients with subcostal hernia come to you, do you offer surgery to all your patients? Anyone would like to say yes or no? Always offer, always offer, always offer. Okay, so this is a 50-year-old male patient, post Whipple's for a CA pancreas, and that is how he came. 1 year down the line. Any thoughts? Yeah. So I gave you the CT. There wasn't any recurrence, but that was thinned out entire abdomen, half of the abdomen. Nothing below, nothing on the top. So anyone has thoughts? If Dr. Adarsh Chaudhary was here, I would have taken his thoughts.
So what are the patient expectations? You should ask the patient, what does the patient want rather than what the surgeon wants?
Great question. Absolutely great point. Yes, because you want to say something? Yeah. Absolutely. Yeah.
Thing because it's got a significant bulge.
Yeah.
And, of course, it's debatable what we would do, but we could at least flight it, do something, maybe just a call.
Yeah.
It's not a
I think it's that's a great comment. So 1 year down the line, CA pancreas, broad-based hernia, subcostal. My personal opinion, I wouldn't touch it. But Dr. Adarsh Chaudhary probably agrees with the same. But I think we can all have a different opinion on this. This is something that can happen.
I think we just want to make sure that he doesn't come back with a loss of domain hernia.
Yeah.
Right?
The patient should be on surveillance.
Yeah, so we need to do a strict surveillance.
Yeah, I agree.
So it has happened to me. It has
Yeah.
happened to me.
Yes, sir.
There was a subcostal hernia post colorectal surgery. Patient after 2 years was sent to me for a huge hernia. So I repaired the hernia. And then patient came up with a small tiny rent again. Okay, it was a bucket handle. This time we did a CT and patient had a recurrence.
Oh my God.
Colorectal rent.
Okay. So I think we just got 5 minutes, so I'm going to wrap this up quickly. So this is for everyone, all of you panelists. I have given you this case, 60-year-old female hysterectomy. On the left side of the panel, still there is a hernia, which is 5 centimeters, L3W2 hernia. And I've given you the approaches. I will go to the audience after this, but let's take it from Pankaj. Pankaj, which one would you do? Just name your procedure.
I would rather do an hybrid repair.
Hybrid. Sharad?
ETAP.
ETAP. Yes, Rahul? TARM. Yes, Mukund?
The easiest would be TAP, but my preference will be ETAP.
Okay, Sumit?
Maybe tape.
Tape. Now I'll go to the audience. Open only, how many? No. Open sublay, how many? I can do it. Okay. IPOM, how many? No. TAPP? Yeah. TAPP, many.
TAPP or tape is like.
Tape and TAPP are similar because one you will use a coated mesh and the other way you will use a polypropylene. Yes. ETAP? 1, 2. No, we have already exhausted you. And TARM? Okay. So what does it show? It just shows that all of us have different approaches, but we are probably thinking the same thing. We're doing extraperitoneal repair. So I wanted to bring this up to all of us that no matter what language we speak, we're probably talking the common language, which is the scientific rationality is the same. We're not saying IPOM. We did not say only. We know that the problem is in fixation. We all talked about extraperitoneal repair. So there is no fight. It's all the same, right? Now, I'll go to Rahul. Rahul, this is a 3 centimeter hernia. And I know you like doing ETAPs. This is a right iliac fossa hernia after an appendicectomy, a 3 centimeter hernia. I am proposing to you that ETAP is an overkill in this patient.
I do agree because for the lateral hernias, ETAP is technically very demanding procedure. You have to really decide how you are going to approach to that particular patient because it depends on size of the patient, the distance of the hernia from the umbilicus and the midline and rest of the things. So being said that, with depending on all these factors, ETAP definitely becomes a technically very demanding procedure. So rather than going for ETAP, there is a two procedures. Those can be more easier with the same plane is a TARM procedure or TAPP procedure. So these are the two procedures where we can really think about.
Perfect. Now here's a lumbar hernia, right? So Sharad, these are the 2 CT scans, right? 2 different patients. What would you advise to each one of these patients? And I would like the audience to pay attention to this CT scan. Both, I've just given you one picture so that you can pay attention. I like to take your comment as well. What would you think?
So in the first CT, I think a TAPP would do well.
Okay.
The upper one.
The second one?
second one I might open.
Okay. And Pankaj, yes, you wanted to say?
Again, I would say that I'll do hybrid approach. I'll open from the same scar. I'll repair the muscle from outside. I'll clear all the adhesions from there. And then I'll go inside. I put a mesh. I do APP or whatever
Okay.
procedure. Then I place a mesh.
Okay, Rahul?
For the first case, there are 2, 3 options. One is I can even, after going inside, I can decide about the TAM or IPOM, or even I can, even to start with, I can start for the E-tape also for the first case. But for the second case, I will go for hybrid.
Okay.
First go inside, laparoscopically do this thing, and then division of the sac and everything with the open small incision.
Okay, Mukund?
So the first looks like an interparietal hernia where the external oblique is intact. So it looks like an interparietal hernia with an denervation injury. So and much not bulge is there. So you can choose your procedure, but the mesh should be in a pre-peritoneal, preferably a pre-peritoneal plane, whatever may be the approach is. And in second case, definitely it's a big, large hernia with an avulsion. You can see the lateral muscles have been avulsed from there, as we can see on the left side, the things are fine enough. So maybe you can go laparoscopically, reduce the contents, and then take a call whether you want to go again endoscopically, do a TAPP or a TAM or a E-tap repair or maybe hybrid repair, depends upon the surgical skills.
Okay, Sumit?
I think it has been said. I think one of the challenges that we see in the second CT is how are you going to fix your mesh?
Yeah.
So that is going to be the challenge, whether you do a hybrid, whether you do a TAPP. So fixation of the mesh is going to be a challenge around the iliac bone. So I think that is what we have to, my thought process would be how to address that and whether I can really close this defect or not.
Yeah.
If I cannot close this defect, then how do I take my mesh, in the pelvic area? So that is going to be my thought process.
So anybody from the audience would like to say something about the first CT scan? Okay. So I propose to you that the first one is just an abdominal wall laxity, it's just a denervation, and the patient will not do well irrespective of what surgery we perform. What would you say?
Then, as Mukund has already pointed out, we have to see what patient wants. That is most important here than what surgeon wants or what is the surgeon's skills are. That is not important. So according to patient's need, then you can tell the procedure and customize the procedure and tell all the facts in front.
Yeah. So I would want the audience to pay attention that here you can only see a bulge, whereas in the other one you can see a fascial defect. This one, although if you see the entire CT scan, it's just a diffuse bulge. Now don't forget the clinical picture I showed you. That was just another patient. But between these two CTs, this is just a diffuse bulge all throughout. If the patient comes to you and you want to operate, make sure the patient knows that the results may not be great. If you can say only that, I think we would have done service from this particular slide. But the other one, yes, this patient is symptomatic. There is bowel going in, is a definite fascial defect. This one, you could recommend surgery and you would probably give good results. Take home message. Lateral hernias are, gentlemen and ladies, technically challenging. They have higher recurrence. The physics is different. Biophysical forces are different. When indicated, which means that sometimes you may not like to operate in all of them, but extraperitoneal repairs have advantages. You may do it open technique. You can do it MAS. If you do MAS, you can go laparoscopic. You can go in the extraperitoneal space directly. Doesn't matter as long as we have the general norms same. The bailout options, especially for the subcostal hernias and the large iliac hernias, where the defect margin itself is the bone, bridging repair, you may have to be content with it. And onlay repair, sometimes you may be have to contend with it. But peritoneal flap is a great technique, and that should be remembered. And I'll leave it to you from one of my favorite poets, Hafiz, a Sufi mystic poet. Knowledge is good if it's beneficial to everyone. And the key word is everyone, which means not only for panelists there, the moderator here, but each one of you in this room, as well as all the patients that we serve. So if it serves everyone, benefits everyone, that knowledge is good. Ladies and gentlemen, thank you very much for this great audience. Thank you, panelists. It was great having you all.
Thank you, Dr. Beg. A lot of take-home messages there for everyone. A great discussion. So I'm sure everybody's now looking for lunch. We have about 50 minutes for lunch. I request everyone to be here, just about 5 minutes before 2, so we can get started on time. We have lunch at the front side and at the back side. But please be back on time so we can get started and stay on time. Thank you.
There is a chance of pressure variant, which holds the suture inside the needle, leading to needle pullouts. This can lead to tissue trauma and also prove to be fatal. At Ethicon, we realized there is an unmet need. We have now taken a leap into the future where science and technology will elevate the standards of care by delivering meaningful innovation. For the first time in India, Ethicon brings to you flexible automatic swaging, a standardized automated method of swaging. FAS can process various needles and suture types with improved needle suture attachment capability. Stake swaging. It works by trapping suture in needle versus compressing needle onto suture. Consistency and reliability that each strand of FAS-produced suture enables surgeons to focus on procedures. To truly surpass standards of quality that Ethicon has set, FAS tests each suture for needle pull attachment strength. This ensures that every suture is made with best-in-class technology, so that when it reaches the hands of surgeons, they can perform their procedural activities with confidence. With FAS, surgeons can have a sense of security and trust that product in their hands is not just good, but best among the rest. Every suture attached through the FAS machine is a combination of Ethicon's technical skill, experience, and commitment to quality and consistency that sets its product apart in OR, enabling best patient outcomes for our surgeons. For us, a suture is not a strand of fiber. It is a thread which can save lives and create happier future. Because at Ethicon, patients are at the heart of everything we do. For over 130 years, Ethicon has built its legacy by providing groundbreaking sutures that have
रुक जाओ। रुक जा ना, रुक जा, रुक जाओ रोहित। रुक जाना, छोड़। Delete कर, delete कर। ये नहीं है। रुक जा, रुक जा। वीडियो नहीं चल रही। अब ये चलेगी। हाँ? ये चल रहा है। ये चल रहा है। Yes, ma'am.
Discover enhanced three-dimensional design adapted to your patient's anatomy. Introducing the Textile Anatomical Mesh. Designed and developed in close partnership with surgical experts like you for optimal coverage, integration, visualization, and handling in your minimally invasive inguinal hernia repairs. With the Textile Anatomical Mesh, you'll experience enhanced coverage thanks to its 3D patented anatomical shape. Excellent tissue integration with high porosity material. Improved visualization thanks to the mesh transparency helps you see and orient the surrounding anatomy. Easy handling with just the right balance of softness and rigidity to maintain shape after trocar passage. An efficient mesh deployment to fit through small trocars while maintaining good handling and mechanical properties. The textile anatomical mesh fits in easily with your surgical workflow. First, orient yourself to the mesh by ensuring the ML marking is readable and placed towards the medial plane of the patient's body. Dissect to obtain a critical view of the myopectoneal orifice. Ensure you can visualize critical landmarks prior to mesh insertion. Rest the medial edge of the mesh and gently introduce it through the trocar using a 10mm trocar for medium and large mesh sizes and an 11mm trocar for the extra large mesh size. Allow the mesh to unfold. The unique structural design enables the mesh to maintain its shape after trocar passage. Confirm positioning by ensuring the medial edge overlaps the patient's midline. Gently direct the inferior flap laterally to align with the anatomy and guide the unsealed inferior edge down to the retropubic space. Finish the procedure per the tap or tip technique used. Make sure that during space deflation, the lateral and inferior edges stay flat against the abdominal wall and do not roll up as the inguinal space desiflates. Surgeons everywhere are discovering the difference. Enhanced design, full inguinal anatomy coverage, textile anatomical mesh.
For over 130 years, Ethicon has built its legacy by providing groundbreaking sutures that have surpassed the standards of quality and innovation. Currently in India, the needle suture attachment is hand-swaged. There is a chance of pressure varying, which holds the suture inside the needle, leading to needle pullouts. This can lead to tissue trauma and also prove to be fatal. At Ethicon, we realized there is an unmet need. We have now taken a leap into the future where science and technology will elevate the standards of care by delivering meaningful innovation. For the first time in India, Ethicon brings to you flexible automatic swaging, a standardized automated method of swaging. FAS can process various needles and suture types with improved needle suture attachment capability. Stake swaging. It works by trapping suture in needle versus compressing needle onto suture. Consistency and reliability that each strand of FAS-produced suture enables surgeons to focus on procedures. To truly surpass standards of quality that Ethicon has set, FAS tests each suture for needle pull attachment strength. This ensures that every suture is made with best-in-class technology, so that when it reaches the hands of surgeons, they can perform their procedural activities with confidence. With FAS, surgeons can have a sense of security and trust that product in their hands is not just good, but best among the rest. Every suture attached through the FAS machine is a combination of Ethicon's technical skill, experience, and commitment to quality and consistency that sets its product apart in OR, enabling best patient outcomes for our surgeons. For us, a suture is not a strand of fiber. It is a thread which can save lives and create happier future. Because at Ethicon, patients are at the heart of everything we do.
जो वीडियो है उसके बाद ही है। ये वाला, उसके बाद ही है। ये वाला। बाकी वाला। दोनों एक साथ ही लगाना है? ठीक है। ऊपर एक और लगा दो, इसी के ऊपर वो वाली है। इसमें कुछ लिखना है आपको?
For over 130 years, Ethicon has built its legacy by providing groundbreaking sutures that have surpassed the standards of quality and innovation. Currently in India, the needle suture attachment is hand-swaged. There is a chance of pressure varying, which holds the suture inside the needle, leading to needle pullouts. This can lead to tissue trauma and also prove to be fatal. At Ethicon, we realized there is an unmet need. We have now taken a leap into the future where science and technology will elevate the standards of care by delivering meaningful innovation. For the first time in India, Ethicon brings to you flexible automatic swaging, a standardized automated method of swaging. FAS can process various needles and suture types with improved needle suture attachment capability. Stake swaging. It works by trapping suture in needle versus compressing needle onto suture. Consistency and reliability that each strand of FAS-produced suture enables surgeons to focus on procedures. To truly surpass standards of quality that Ethicon has set, FAS tests each suture for needle pull attachment strength. This ensures that every suture is made with best-in-class technology so that when it reaches the hands of surgeons, they can perform their procedural activities with confidence. With FAS, surgeons can have a sense of security and trust that the product in their hands is not just good, but best among the rest. Every suture attached through the FAS machine is a combination of Ethicon's technical skill, experience, and commitment to quality and consistency that sets its product apart in OR, enabling best patient outcomes for our surgeons. For us, a suture is not a strand of fiber. It is a thread which can save lives and create happier future. Because at Ethicon, patients are at the heart of everything we do.
Discover enhanced three-dimensional design adapted to your patient's anatomy. Introducing the Textile Anatomical Mesh. Designed and developed in close partnership with surgical experts like you for optimal coverage, integration, visualization, and handling in your minimally invasive inguinal hernia repairs. With the Textile Anatomical Mesh, you'll experience enhanced coverage thanks to its 3D patented anatomical shape. Excellent tissue integration with high porosity material. Improved visualization thanks to the mesh transparency helps you see and orient the surrounding anatomy. Easy handling with just the right balance of softness and rigidity to maintain shape after trocar passage. An efficient mesh deployment to fit through small trocars while maintaining good handling and mechanical properties. The Textile Anatomical Mesh fits in easily with your surgical workflow. First, orient yourself to the mesh by ensuring the ML marking is readable and placed towards the medial plane of the patient's body. Dissect to obtain a critical view of the myopectoneal orifice. Ensure you can visualize critical landmarks prior to mesh insertion. Press the medial edge of the mesh and gently introduce it through the trocar using a 10mm trocar for medium and large mesh sizes and an 11mm trocar for the extra large mesh size. Allow the mesh to unfold. The unique structural design enables the mesh to maintain its shape after trocar passage. Confirm positioning by ensuring the medial edge overlaps the patient's midline. Gently direct the inferior flap laterally to align with the anatomy and guide the unsealed inferior edge down to the retropubic space. Finish the procedure per the tap or tip technique used. Make sure that during space deflation, the lateral and inferior edges stay flat against the abdominal wall and do not roll up as the inguinal space desiflates. Surgeons everywhere are discovering the difference. Enhanced design, full inguinal anatomy coverage, textile anatomical mesh.
Good afternoon again. So we'll be starting in another 5 minutes. And we have the Hugo Medtronics robotic system outside. If anyone wants to try it, they can give it a shot. Good afternoon, everyone. Can we please take our seats? We will start with our post-lunch session. I understand it's a very difficult time. Everyone has had a good meal. It's a very dull afternoon. We'll try to spice it up with some advanced wound management from our plastic surgery team. We have the first speaker on this is Dr. Rakesh Khajati. He is the chairman of Plastic and Reconstructive Surgery in Medanta here with us and he has surgical expertise of over 40 years with special interest in reconstructive microsurgery. I welcome Dr. Khajati to speak on wound flap necrosis and our methods to minimize it. Welcome, sir.
Thank you, Utpala, Vikas and others for giving me this opportunity. I think the subject written there was wound flap necrosis. So I just a little correction here. It is skin flap necrosis and how we can minimize it. For a post-lunch session, it is a rather dull subject, and as she suggested, and try and spice it. Right. So I think this talk that I'm going to give today will be in these parts. What is flap necrosis? Why does it happen? How do we prevent it or minimize it? The last part, which is how do we manage it, is basically management of wounds. So I'll leave that to my colleague who will follow me, Dr. Sukhdeep Singh. So here is a patient that you see. He has a flap necrosis following an excision of a dermatofibrosarcoma, which was involving the abdominal wall. It included removal of some skin over the swelling. So skin flaps were used and the closure was done, but you can see the end result is not very good. His flaps have necrosed. So this is what we call a skin flap necrosis. Why does skin flap necrosis occur? Primarily, it is loss of blood supply. What you do when you are doing an anterior component separation technique, you are raising large flaps. And when you raise those large flaps, you have potential to devascularize that skin. It may be just an ischemic and have some wound breakdowns. In a worst case scenario, the skin will necrose like you've seen in this case. So flap necrosis is something which is likely to occur when significant areas of skin are undermined and large flaps are developed. The second cause that we see sometimes is necrotizing skin infections, and that would happen, necrosis would happen without even you are having to raise any flaps. So a lot of organisms can cause necrotizing skin infections. A lot of them come from the gut. So if you have infection coming from the gut into the skin and subcutaneous tissues, which is necrotizing infection, you could have skin flap necrosis. So earlier I showed you an example of devascularized skin. This is a patient who had a liposuction related perforation of the gut, and he came to us with this kind of abdominal wall, which was completely necrosed. The rest of his story you will hear later from Sukhdeep. I will not go into that because as such, this etiology is out of our domain other than wound management. So as I said earlier that when you do anterior component separation technique, you have to undermine large areas of skin. And when you do that, you end up devascularizing the skin. So here is a patient similar. You see the kind of extent of undermining that is being done to achieve closure. And what you need to learn is where your undermining becomes critical to for the purpose of flap necrosis. So what is critical? That is what you have to understand. To understand this, it is paramount that you understand how the blood supply comes to the skin and what is the physiology, how does it work. So I'll briefly go through that part. The abdominal wall is supplied mainly by the superior epigastric, the deep inferior epigastric artery, but there are also supplementary supplies from the superficial branches of the femoral artery, the external pudendal, circumflex iliac, and the inferior epigastric, and also the intercostal and lumbar arteries. So these are the arteries which run reasonably deep, except the superficial branches from femoral artery, and they run longitudinally. How does the blood supply come to the skin? From these vessels, as you see here, that here is a vessel which runs deep. Let's assume it is deep inferior epigastric artery. The perforators arise, perforating vessels perforate through the muscle and then supply the skin. And once they are into the skin, they will form a plexus which is longitudinal, that is horizontal in nature, which can be either over the aponeurosis or over the Scarpa's fascia. So these are the plexuses which nourish the skin. And you can, of course, see these in angiography that we sometimes use to find out where the blood supply is. Here you see the longitudinal running deep inferior epigastric vessel. And then you see a perforator which is coming through the rectus abdominis muscle, perforates the muscle here and then into the skin. So this is the vessel which will supply the skin. And this is the Scarpa's fascia layer. And at this layer, there would be another horizontal plexus along the length of Scarpa's fascia. And technically, you see these perforators. I mean, I'm sure you all have seen them, but you see here is a very decent sized perforator supplying. This is the umbilicus here. So just below the umbilicus, you see the perforator entering the skin. And if we trace this further, once again, this is the perforator, main perforator, and this is the deep inferior epigastric vessel, which is lying in the just extraperitoneal in the extraperitoneal fat. So in terms of blood supply to the skin, just like you have dermatomes, we call them angiosomes. So all the skin, the body skin is divided into territories supplied by different arteries which enter in different ways. And these are called angiosomes. These are the segments which are relatively autonomous blood supply units. And once we see if you have to understand the angiosome concept, so here is the main vessel, the main source vessel, and then there are perforators which supply different territories of skin, and each territory we call an angiosome. How are they arranged in the abdomen? Sorry, before we go to that, now these angiosomes, what you see here is this is the physiology of angiosomes. What you see here is there are 3 angiosomes supplied by the 3 different vessels. And these angiosomes territories are in contact with each other through vessels which we call choke vessels. They are called choke vessels because normally blood flow through them is very minimal. It's only if you cut off the supply to one of the angiosomes by ligating or cutting or whatever, devascularizing, then these choke vessels open up and each angiosome can supply the next territory fairly comfortably. So just it's a colorful picture of the angiosomes of the abdominal wall. And these are the dots show the perforating vessels where the big perforators are. And if you, for your practical purposes, what is important is to learn that there are 3 major zones in the abdomen. The one is around the midline and the paramedian area, and also the upper third below the umbilicus. This is supplied by deep inferior epigastric artery and the superior epigastric artery. That is one zone. The second zone is below the abdomen towards the inguinal ligament, lower part of abdomen. And this zone is supplied by superficial branches of the femoral artery, the external pudendal, superficial inferior epigastric, and circumflex iliac. And then you have the third zone. This is supplied by the intercostal vessels and also the lumbar perforators. And so these are the major zones that you have to remember. And I'll just to show an example. Now, these are not the blood supply zones, but these are the segments in a lower abdominal skin flap, where we have raised this. We have the perforator entering. So this we call the segment 1. Adjoining segments are segment 2 and 3, and far away segment is segment 4. So what I'm trying to tell you here is that if we have these segments and the vessel is entering only segment 1, this vessel will be sufficient to supply segment 2 and segment 3, which are immediately adjoining. But segment 4 will be dicey. The blood supply may not reach there. So just this is a ICG fluorescence study of the same flap. And you see the bright part, this is the flap. You see the bright part is all well lit up, but this is the segment 4 that I was showing you, which is dark, and the blood supply there is very poor. So you can, in cases where flaps are doubtful, you can do an ICG fluorescence, although this is fairly expensive equipment that you need for that. So that way the applications get limited, but this is something that we have in our armamentarium to find out what is avascular in a skin flap and what is not. So in this flap, what we will do is this segment 4 we will discard completely, and segment 3 will also be partially discarded, but we know that this is healthy. So this is just to give you a concept that in your dissection, when you are working through the midline, you make sure that you don't devascularize segment 1 and 3, both of them. You must maintain the perforators which are there in the segment 3. If you do extensive undermining completing the segment 3 as well, there's a very good chance your skin in the middle will necrose, because now you have 2 consecutive segments which have been devascularized. So that is the angiosome concept that you need to remember. So how do we prevent flap necrosis? The one main thing that I've told you is understand the vascular anatomy and do not transgress 2 consecutive zones. It's very simple in the abdomen that I have shown. But there is a second concept. This is the zones. The second is when you dissect, you have to know where the vessels are. You have to know the right planes of dissection. By staying in those planes, you can save the vessels and make sure that blood supply is adequate. So there are 3 main planes of dissection. The first plane is what we call subscarpa plane. In subscarpa plane, this represents the subscarpa plane. There is a plexus superficial to scarpa's fascia. So for your purpose, this plane you will only need for tumors which are infiltrating the abdominal wall, because in all other cases, most of the time your plane of dissection will be deep. So if you have a tumor which is through the sheath into the subcutaneous tissue, then the safe plane of dissection of the skin will be subscarpa. It's a very well-defined fascia, particularly in the lower part of abdomen. The second one is your plane of the aponeurosis. If you staying just on the aponeurosis, the rectus sheath or the external oblique aponeurosis, by staying close to that, what you do is that again, all these plexuses are safe. There is the next plexus is deep to scarpa's fascia, and that is the plane you use for your anterior component separation. And the third plane is, sorry, I just have to go back. The third plane is the so-called extraperitoneal plane, which is the plane that you use for your posterior component separation technique. Sorry, I think they've jumped. So these are the 3 planes that I have described. Depending upon what sort of surgery you are doing, you choose your plane. So this is a patient anterior component separation technique. So you see we are on the aponeurosis. You can start seeing the perforators here on the side here. You see one perforator. As far as possible, we try and save the maximum number of perforators that can be saved. If they are under traction, when we are pulling the sheath inwards, we will have to divide them. But you make sure that these are something, this is just for demonstration that we are separating this. So here it is, you see the extensive dissection all around, and you see these are once we reach the perforators which are in the lumbar region, these are all these perforators have been saved, and you are lateral to linea semilunaris where your incision for anterior component separation technique is going to be. So that's what will make sure that your flaps remain healthy. And this is a patient who had a severe divarication of recti. And once again, this surgery was done through an abdominoplasty incision. So you see, once again, the dissection is right on the sheath, and you see the lateral sides. It is limited to zone 1, which I had shown you earlier. And this is in preparation for the repair of the divarication. And you see the extent of undermining here, which is limited only to the central abdomen, not going laterally. And then you have to work through this tunnel to get this repair done, but you are sure then that your skin is very safe. So the next thing that we need to do for preventing flap necrosis is to anticipate it. There are some patients who are high-risk patients who are diabetics, smokers, atherosclerotic disease, advanced age, obesity. These are the patients, when you look at them, you think that this is in an obese patient, that skin necrosis the supply is very poor. So they are even the transgressing of zones is a lot more important there. So make sure that once again, I emphasize, don't transgress zones, stay in the right planes. And also if you're doing surgery in contaminated fields where the chances of infection are there, you have to be very careful. So just to show you an example, this patient had a dermatofibrosarcoma, again, upper abdomen, and post-excision, we could see that the skin closure was tight and there was a defect in the abdominal wall which needed mesh reconstruction. So we decided to use a flap which is based on the paramedian or the zone 1 perforators, which are close to the midline. And you see this long flap that we had to use, and this is what it looked like. We've raised the flap here. This is the defect, mesh reconstruction done, and flap in place. What we had 2 perforators at the base, one medial and one lateral. So saving the lateral perforator, we transgressed into zone 3. You can see that little bit of the skin was beyond. At that time, one thought that one would get away with it, but no, it didn't happen. You see that the skin necrosis in the zone which was going beyond our 2 territories. So what we then did was to excise all this again. Then we tied the lateral perforator, advanced the skin again. After suturing, we know the skin is still at risk. We use negative pressure dressing over the sutured wound. So this is supposed to improve the blood supply. I don't have exact, I mean, there is no really confirmed data on this, but that is what we've seen in many patients. And there are some early reports that this helps. And you see that this we were able to get this wound to heal without any problem after that. So come to the conclusions, I would say first is respect blood supply. If you know about blood supply, what we say, what the mind doesn't know, the eyes don't see. So you have to have knowledge of blood supply. When you have that knowledge, you will automatically start respecting it. Understand the vascular anatomy. Once again, do not transgress 2 consecutive zones in your dissection, specifically when you're doing dissection for anterior component separation. Stay in the right planes. Make sure you do all the measures that are required for preventing infection, all your infection control measures. And wherever you anticipate that skin flaps are dicey, they may not survive, use NPWT as a preventive measure. It may help. As I said, there is no definite evidence, but early evidence does suggest that it will help. So thank you very much for your attention. And so we'll have questions in the end.
We'll take all the questions jointly after the panel discussion. I'd like to introduce Dr. Subdeep Singh. He's a senior consultant in plastic surgery here in Medanta with 15 years of experience. His prime interest is in reconstructive microsurgery and facial aesthetic surgery.
Yeah, good afternoon, everyone. I think Dr. Khazanchi has very clearly laid out the principles that we need to follow to prevent wound-related complications in the abdomen. My job is to talk about situations when we do land up with an abdominal wound. What do we do and how do we manage that? So there are no disclosures to be made. And if you look at the causes, I think the major causes would be trauma, tumor resection, infections, and flap necrosis due to ischemia. So if we have a patient with a tumor like this, so we can excise it and we'll have a defect which will include the musculoaponeuritic system. We can bridge it with a bridging mesh, a dual plane mesh. And most of the cases, there'll be enough skin to be able to close the wound like this. We can have patients where this lady came with post-laparoscopic hysterectomy, abdominal wound infection. There was necrotizing fasciitis, and this patient Dr. Khazanchi already talked about. And this patient, there is flap necrosis mainly because of ischemia. So the first step in any such patient is debridement. Debridement has to be radical, it has to be extensive. Whatever is dead or non-viable needs to be taken out. Don't worry what the final defect is. As a plastic surgeon, I would say, main hu na, whatever it is, we'll manage. So once you've done the debridement, what you land up would be either a superficial defect where the aponeurotic and the muscles are intact, or it'll be a deep full thickness defect. For most of these wounds, our workhorse has become the negative pressure wound therapy. So it could be a simple negative pressure wound therapy or one with irrigation, or specific to the abdominal wounds, which comes under the trade name of Apthera by the KCI group. And they could be incisional negative pressure wound therapy that Dr. Khazanchi alluded to in his talk. For superficial wounds, one can use a NPWT with or without irrigation. And once the wound is ready, we can either close it by secondary suturing or by skin grafting. So in this patient, we were able to excise. There were multiple discharging sinuses. Sorry, there were multiple discharging sinuses here. And we were able to excise those, clear the wound, and then close it secondarily. This lady, she had a superficial wound again, managed with debridement, negative pressure wound therapy, and we were able to get away with a skin graft. So this gentleman, he came with post-liposuction necrotizing infection. He also had some intestinal obstruction and a seal of perforation in the jejunum. So again, radical debridement. Laparotomy was done by our GI colleagues who managed the intestinal part. The wound was closed in the midline, the eponeurotic system. We put in the vac. And to prepare the wound, because the patient was not fit for an autograft, we didn't want to lose his own skin. So we used what is an allograft, which is basically cadaveric skin, which is preserved in a skin bank. So this helps in preparing the wound. It helps to cut down the losses from the wound bed. And this generally starts to shed off in around 2 to 3 weeks time. And by that time, the wound is ready, and then you can cover it with an autograft. And this is an early post-op picture of this patient with the settling wound graft. Sometimes you come across patients who had a hernia surgery before and they land up with a wound where the mesh is exposed. So in such patients, again, first step is debridement. And if possible, the mesh can be removed. Sometimes it may not be possible. It's too early to remove it, or it might be deeply integrated and that might risk bowel injury. So in such situations, you manage with NVWT, preferably with irrigation. Now, literature says that even if you use saline for irrigation, it gives equally good results as compared to any other solution. But our personal choice is using a betaine and a polyhexamethyl bigonite solution. It comes with a trace name of Prontoson, because this helps to break down the biofilm formation and helps prevent a formation of the biofilm in such situations. And once the cultures are sterile and the wound clinically looks good, there is no inflammation on the edges, then you can plan a wound closure. Now, this lady, she was a post-liver transplant patient, had subacute intestinal obstruction, underwent a surgery, developed incisional hernia, underwent incisional hernia repair, and then landed up with a wound which is there towards your left. So again, debridement was done. I don't know whether you'll be able to appreciate the mesh in this, but she had an exposed mesh, which was, we used the NPWT with irrigation in her. And once the wound was ready, we were able to close it. And this is around 4 months after surgery. Till now, she's infection-free and hopefully will continue to do so. So once you have a full thickness defect where the muscular eponeurotic system has also been breached, you use what is an abdominal wound therapy. And this comes with the name of Apthera. So this is a schematic of that. So there is a visceral protective layer. And this is basically polyurethane foam, which is sandwiched between 2 perforated sheets of polyethylene. And on top, you put another polyurethane foam, and then that is connected to the negative pressure device. So the visceral protective layer, it also helps in draining out the peritoneal secretions and protects the viscera from direct contact with the mesh and helps prevent enterocutaneous fistula formations. So this was a patient post-liver transplant, and he had a wound infection. The gram staining and the QAH showed mucor. So he was taken up for debridement, and this was the kind of wound that we landed up with after debridement. And in this, we used the Apthera system. There's a small video showing that. This incidentally was the first use of Apthera in India, the first case that was done. So the visceral protective layer has been put in, and this is the polyurethane foam which is being put on top of it. So the visceral protective layer goes right up to the paracolic gutters and draws out all the secretions. And once this is there, this is sealed off with the adhesive tapes and then connected to the negative pressure device. And this was how the dressing looked at the end of the procedure. So this patient needed serial dressings with abdominal therapy. And after a while, once the wound was ready, we were able to close a part of it and some part just granulated, and we were able to just graft it and get away with it. This patient was from Burma. He's not followed up, but I think hopefully he's doing fine. So the biggest drawback of Apthera or the abdominal system is the prohibitive cost. So in such a situation where the patient is not very affording, we take help from the Jugaad technology. So this is a way in which you can prepare your own, Apthera dressing, although it will not be as effective as the original one. So you take an adhesive tape, make some perforations in that, and you take a polyurethane paint, which is the normal negative pressure dressing, which is there, and cover it with another adhesive layer. Now this layer can be perforated or non-perforated depending on how big the wound is. And these films will help prevent adhesion with the viscera. If the wound is bigger and you need bigger drapes, then you can use even the Ioban, which is an adhesive drape, and you can use that and make your own thing. So you will see that on one side, there will be perforations which will help in draining the exudate. So if it's a bi-perforated thing, you need to put another layer of polyurethane foam and then connect it to the machine, or you can directly connect it to the suction machine here in the center. Another thing that has come into use is the acellular dermal matrix. Now, this has been in use in the Western countries for a very long time, but has recently become available in India. We don't have a personal experience with this for abdominal wounds. We've used it for other indications. Like in this case, this was for breast reconstruction. This was the stratus dermal matrix. And this could be of human origin, porcine, bovine, or from sheep origin. And most of these will differ not just from the source, but also in how they are processed after harvesting. They are used as a replacement for a prosthetic mesh, and in non-contaminated wounds, you can use those. And in contaminated wounds, it's recommended that this is preferred over the normal prosthetic mesh, which is there. And the reason for that is that this has been shown to have lesser reinfection rates because it gets rapidly revascularized from the wound bed. And in contaminated wounds, you can put in this acellular dermal matrix, and this could be the single stage repair for the patient. It can be placed as inlay, onlay, or a bridging mesh, although the risk of recurrence of a hernia has been higher with a bridging mesh because of the elastin content in the dermal matrix. Again, a device by the name of top closure is available. We have not used it personally, but this is another tool which can be used to close abdominal wounds where there's a problematic. So a plastic surgery presentation won't be complete without flaps. So this patient, I've shown the picture earlier, also had a ischemic wound necrosis of the edges. So once the debridement was done, there was a full thickness defect. We covered it with a dual plane mesh, and then we did a pedicle anterior lateral thigh flap to cover the skin defect. There's some other examples. This is again a pedicle anterior lateral thigh flap for a groin wound, and the paraumbilical flap that Dr. Khazanchi referred to in his presentation. I would also like to mention about the atypical mycobacterial infections. We've seen them quite often now, and especially in patients who've had laparoscopic surgery, where the scopes and the other instruments are sterilized using glutaraldehyde solution. So these patients would generally come with a persistent discharge and a sinus formation. The aerobic cultures would be sterile, and you need to have a high index of suspicion, take a proper history so that you can come at a diagnosis of atypical infection. So you need a biopsy. You need ZN staining, gene expert, AFB cultures. Now a modified ZN stain for atypical mycobacterials are also available. And they need a long-term antibiotic under the care of an infectious disease specialist. Now this lady had a post-LSCS scar, discharging sinus. You can see multiple sinuses there. And again, the aerobic cultures were sterile. Her ZN stain was negative, KOH was negative. And the AFB cultures also turned out to be negative. Only the biopsy had chronic granulomatous inflammation, which led us to the diagnosis of atypical mycobacterial infection. She was on therapy for around 6 months, and then she recovered after that. Also, we can have patients with mucormycosis or black fungus. I think this was highly in news during the COVID era. So this lady, again, post-LSCS mucormycosis, again, extensive debridement. We used VAC for her. We also used allografts for her. She needed a pedicle anterior lateral thigh flap for a suprapubic coverage where the bladder was exposed. And this is about 1 year follow-up with this patient. So to sum up, I like to say that whenever there's a complex wound, there is a plastic surgeon to manage it. Don't worry. Thank you.
So very well said. Next we have a panel discussion. The moderator, I would like to call upon Dr. Abhishek Tiwari from Indraprasth Apollo Hospital, New Delhi. He's a senior robotic, bariatric, and GI surgeon and is passionate about diabetic foot and complex non-healing wounds. For the panelists, may I call upon Dr. Rajesh Khazanchi, Dr. Vimlandu Brijesh from Medanta Plastic Surgery Department, and Dr. R.M. Khattar with over 25 years of experience in hernia surgeries.
So, good afternoon, everyone. And so I'm given topic here, which I'm very passionate about, complex non-healing wounds. And I mean, here the topic is post-hernia surgery mesh infection. So I would like to start with a very small video. And this video is of a patient and who has given due consent for the same. Volume.
मेरा ऐसा है कि बाईपास हुआ था तो बाईपास होने के बाद मेरे को इन्फेक्शन हो गया। वो इन्फेक्शन वैसे तो देखने में प्योर था, एक छोटा सा स्कार था, उसके ट्रीटमेंट में 1.5 साल लग गया और इंटरनली इट वाज डायग्नोस्ड इन बाईपास हुआ था तो बाईपास होने के बाद मेरे को इन्फेक्शन हो गया। वो इन्फेक्शन वैसे तो देखने में प्योर था, एक छोटा सा स्कार था, उसके ट्रीटमेंट में मेरे को 1.5 साल लग गया और इंटरनली इट वाज डायग्नोस्ड इन मणिपाल बाय डॉक्टर अभिषेक तिवारी। तो साइनोग्राम वगैरह होने के बाद पता लगा कि वो स्टर्नम के अंदर इन्फेक्शन चला गया है। तो वो स्टर्नम का सारा ट्रीटमेंट करते 1.5-2 साल लग गया और 18 लाख रुपया खर्च हो गया, जो देखने में वो 18 mm का भी कट नहीं।
So this is what patient feel when they have wound. And I still believe that most of us just think about that as wound only. So this patient paid 18 lakhs after bypass surgery. So cost of bypass is not included in this. So that is the amount of money patient spent, and think about the time. 2 years, family members and the patient, they all are suffering. So we should need to take the wound seriously. And here for the mesh infection, my first question, warm-up kind of question is to Dr. Khattar. Sir, this is a post-component separation hernia repair with underlying mesh. And now this is the kind of infection. It is subcutaneous in the subcutaneous plane. So anything you would like to do?
Actually, it depends on the many parameters, what type of mesh has been used, and what are the systemic parameters, fever, counts, the cellulitis surrounding this wound. Preferably, this wound should be laid open and the mesh should be exposed. If it is a macroporous proline mesh, it is salvageable. Most of the times it is salvageable.
Sir, this is only in the subcutaneous plane.
The infection?
Yeah.
And the mesh is underlying.
Rectus is safe, sheath is safe, and the mesh is below the sheath, so we are safe.
So I think you have opened in between, and irrigation and dressings is all that is required. There doesn't appear to be any cellulitis around the sutures. So I think dressing should be, and antibiotic should be, and cultures, of course.
Okay. So I do agree with you, but in this case, there's underlying mesh. And if that mesh gets infected, then that leads to major problem. So ideally, there is no harm putting a vac or two after a small debridement and then closing it. So the wound heals in a week. Otherwise, dressings may take more time, and there are chances that wound may get infected later on, and it can lead to damage to the mesh as well. So this is my opinion. Anybody from audience would like to differ from me? Can you? Most welcome to say. So I believe this mesh is there. So we should do debridement, place a vac, and close it immediately. Otherwise, if there's no mesh underlying, I agree with sir, we should go with this. Yes, sir.
I think I am more tempted to agree with you. I think in these situations, the infection may look very superficial, but it's only time before it becomes deep. So your job is to make sure it doesn't become deep. And by just removing sutures, antibiotics, and little irrigation, it will not work. The problem is patient is lying supine all the time. Your drainage will not happen from that wound. The drainage will not happen. That's where the negative pressure comes into use, because it can suck out all the toxic fluid that is there. And you can also irrigate with various antiseptics by
Yes, sir.
using Veraflow. To my mind, I think the most problems occur in standard wound. We've seen lots of them. The maximum number of operations. I did the 21st and 22nd and 23rd before we got him healed. He had 20 before coming here. So the most problems arise because you see, do wound pus aa gayi hai, we just remove 2 sutures, give antibiotics, and you load them with antibiotics for next 3 weeks. I think that's the worst you can do to that patient. Early aggressive treatment will prevent late long-term complications. So you have to go, the moment you see infection, get aggressive. Don't, the only thing that gets hit is surgeon's ego. There's nothing else gets hit. So put your ego aside, get in there, wash the wound, put negative pressure dressing, and make sure you've controlled that infection before you close that wound or let it heal. That's my opinion about these early infections.
We do agree with you, sir. Thank you very much. So I come to my next slide. Now this is a post-hybrid approach hernia repair, this IPOM mesh inside. And it was hybrid closure. So you can see the proline by which we close the sheath. And now the suture is visible with some kind of slough, and there is underlying mesh, IPOM hybrid. So what will be the line of management? This I'll go with Dr. Khazanchi.
See, my knowledge about the mesh is limited, so I will have to take your help. But the treatment remains the same. Open the stitches, lay everything open, drain everything, provide drainage, provide wash. Question here is whether the mesh is salvageable or not.
Yes.
Okay. And
So,
how critical it is to keep that mesh there. That is where the input will come from you and not from me. And if it needs to be salvage, yes, we will work on it. We can get the wound clean. If required, even cover it with a flap later on once it is ready. But if the mesh needs to be removed, then at some stage it will have to be removed.
yeah. So I will pass this question to Dr. Ashwin Bawa as well. He is both into hernia repair and wound management. So what is your take?
See, if I see this primarily, I will open the sutures. Take a culture on the first.
Suture, what suture you will open?
I open the nylon suture that you see.
There is only one suture. And
Open that suture, cut all those braided sutures that you see.
what about that proline suture which is holding the sheath?
Perhaps don't touch it. So, what do you call it? Stuff that you see is your best time to find the culture, the infection inside. So, swab it first. Wash the wound for a few days with hydrogen peroxide and other things. See how it is going. If it is granulating well, we are good enough. I think so. We can wait for any sort of intervention with regards to the mesh. If it is not discharging much, we can wait. If it starts granulating, then think of NPWT after debriding whatever you see.
Okay. So I do agree with you, but in this case, my opinion is the suture, as long as it is there, this proline, this wound is not going to heal. So you need to take chance sometime. Just cut up to the level you can see it. Don't pull it and try to cut extra. And here the history is important, like how many days post surgery. So this is after 25 days. The condition of this wound is after 25 days. Yes, sir, please.
IPOM meshes behave in a different way from other meshes. Because of the non-adherent coating, any infection in an IPOM mesh creates the stage for a biofilm, and at some point or the other, the mesh will get reinfected. So I would certainly be more aggressive than just take care of the wound and remove the odd suture and put a vac. I would actually counsel the patient and say that if you want to give it a chance, okay, we'll treat it more conservatively. Otherwise, I would be aggressive and explant the mesh and then prepare for a reconstruction later.
So I agree with you. Punjani sir, want to tell something?
Get this repeat done. There is something inside.
Yes, exactly. So there are two thoughts. Now there are two opinions. So this patient, I can tell you how we managed. So this patient, we explained that mesh explantation may be required. He was coming in as OPD basis patient, and if the wound get further infected, you are having fever, then we will remove the mesh. Otherwise, we are going to give it a try. So we applied the vac after removing this stitch and removing the slough, and we used here vac insta. So installation vac we used, so it was constantly irrigating and cleaning the area, and whatever fluid was there that was coming out because of negative pressure. So we managed to save this patient, and mesh explantation was not required. Yeah.
Sorry, just one point.
Yeah, sir, please. We want to hear from more than one, sir. Many points we want to hear from you.
So there was a study in the US on the VA, Veterans Administration patients, over 100,000 patients of mesh repair, and the patients who got infected, their complication rates and explantation rates were over 50%, much over 50%. So I would say that be cautious in prognosticating and say that, oh, be fixed.
Yeah, I do agree.
And you know, polyester meshes are less liable to tolerate infection. They will be explanted much more frequently than polypropylene meshes. So that factor has to be taken into consideration. CT scans are important. And one should be, I think, liberal in explanting a mesh if it is infected, rather than prolonging the misery of the surgeon and the patient.
Yes, I do agree. But in this case, I think we can take chance because there is a sheath in between mesh and the wound. This is subcutaneous infected wound, thin patient, and the prolene is exposed, but the sheath is intact. We did a CT scan. So we manage this. My opinion is that we should try to save mesh as much as possible. Although I do agree, if there is any risk at all, you immediately remove the mesh.
I think I agree with your last sentence as the what is the risk profile of the patient. The same thing might change a little if the patient is diabetic, elderly, and has risk factors.
With comorbidities and all those things,
so
old
much in
age.
favor of preserving the mesh. We would rather look at safety first,
Yeah.
and then mesh preserve.
So here I come to my next slide. Now this is post Lichtenstein repair. One patient from Nigeria. He underwent mesh repair 8 months back, and young patient, no comorbidity. And this is the wound after right inguinal hernia repair. So I would like to ask Dr. Brijesh, how you will manage this case.
So is the mesh exposed? I don't think there is a mesh.
Mesh is
exposed out
removed.
there.
They
It
remove
has
the
been
mesh
removed.
outside
It has been
only,
removed.
but after that, this wound is persisting, non-healing wound.
So first stage will be always be a culture of this wound.
Yes.
And accordingly, the antibiotics. A session of VAC would be good enough, but we need to ascertain whether there is an underlying collection or something like that. For that, I think CT scan would be advisable for this region, whether there is an underlying collection or not. If we need to explore and debride it properly, then debridement. Otherwise, VAC and maybe I think secondary suturing or grafting should be done.
Yes. So this is what we did, and we failed. We did all those things what you said, but there was the infection of the bone, that was osteonecrosis, and avascular necrosis led to this wound. It was not healing with multiple VAC sittings. So we took ortho opinion. They excised the bone thing, whatever was infected with osteonecrosis, and the wound healed. So these things also we need to keep in mind sometime when we go with the conservative typical management. This is odd one out, so I'm presenting it here.
So here I would like to add one more thing.
Yeah.
In this case, CT scan and MRI, there is a little bit of, because if we are suspecting some bony infection, then probably MRI would be a better choice for this patient to
Yes,
rule
I
out.
agree, and we did CT scan.
So
So
mesh
later on,
explantation was not necessary in this patient.
mesh was already explanted, sir.
No, but since it was osteonecrosis, so I think taking care of the dead bone would have been enough to let this wound heal instead of removing the mesh.
I would like to pass this question to Dr. Punjani. So maybe he can answer this. Mike, please.
You said the patient came with mesh already explanted. The
Yes,
infection
yes.
must have started in the mesh. and
Yes,
Then went to the bone.
yes.
It started in the mesh, they removed the mesh by the time. I had to pick exactly similar patient, very big, a big cavity, it was osteomyelitis of the pubis. And even first time mesh was removed, second time, some pieces left over. and eventually we diagnose that osteomyelitis.
I think the lesson here is that there was infection in the bone. You wouldn't really
Yes.
expect
Infection in
to go
bone
to the
and
bone from
yes.
here.
So my next slide is this.
The osteitis pubis is very well known complication of inguinal hernia repairs, and I think that is also a kind of necrosis only, and sometimes requires operation also.
Yes, but we read so many times about this thing.
Don't pass your suture through the bone or periosteum even.
Yeah,
You
that's
are-
true.
At least we were
We should
taught
never-
the
we
first
should never do
first
that.
suture always went through the pubic tubercle. Periosteum.
Should be.
Things may have changed, you know.
Yeah.
I'm talking about.
Not to pass through the bone. Yeah. So, okay. Now the next slide. One lady underwent sleeve gastrectomy outside with ventral hernia mesh repair simultaneously. 44-year-old female, hypertensive, hypothyroid, BMI was 69. And when she came to our hospital, she was also having bed sore and infected abdominal wound. So now my first question is to Dr. Ramana. Shall we do a bariatric or maybe sleeve with mesh repair in the same sitting? Is it justified or not?
By and large, the standard answer is no concomitant elective operations in high-risk patients. But in certain situations, it may be acceptable. For example, if the patient had, say, a BMI of 45, 40, and had a small umbilical hernia which was symptomatic and she wanted it fixed at the same time, you could actually put one port through that defect and then put a mesh patch on the way out. That is acceptable. But certainly 69 patient, I would say,
With comorbidities and
little too
yeah.
much for concomitant.
So now the next question: this patient had sleeve leak, and there was mesh inside. So this was the kind of abdominal wound when she reported to us. So this is pus pouring out with sleeve leak. So I'll tell you one step. We did stenting, and after that, bile leak was not there. Drain not required. We can see everything whatever is there inside. So we can visibly see. So nothing else is required. So my first question to our audience is: can we honestly? You need to answer honestly. Can we save these kind of patients or not? How many believe we can save or we cannot save? How many believe we can save? Okay, great. But I think maybe 60% believe we cannot save these kind of patients, but which is not exactly true. We should give our best. So now after applying VAC, after 2 sitting VAC, this is the condition. You can see the VAC form and how the pus is pouring. So this was the condition. But ultimately we keep on debriding, putting VACs, multiple VACs. So this patient had 24 VACs. Now you can see getting little better, pus is still coming out. Now you can see this stomach and the liver. They are exposed. So now my question is to Dr. Khattar, what will be your line of management in this kind of wound?
Dr. Khajanchi has just taught me to put a vac there.
Okay.
I will put a vac.
Anything else VAC we are already putting? Like this is after maybe some 10 VACs. Yeah. So this is what you told, like some Indian jugaad. This Apthera cost is around 40,000 rupees. This patient had 30 VACs. So that means around 12 lakhs in VAC required if we use Apthera. So in this patient, what we used was there is a dressing, which is Hydrophera blue, which is coated with PHMB and methylene blue. So antibacterial excellent properties. You apply that dressing directly over the wound, and over that you apply any standard normal VAC. So the cost goes down to 14 to 15,000. If we use Apthera, it is around 40,000. So this is innovation, works very well. I used in multiple patients directly on bowel and everywhere, and every time it never failed me.
What is important is that if the pus is still pouring out, the vac is acting only on the wound. The connection would be somewhere else. So that needs to be tackled. If you don't tackle that,
No, we cannot tackle. There is a leak inside and we cannot go there. We don't want to mess up with that plane. We were doing regular CT and we were checking for the collection. Luckily, there was no significant intra-abdominal collection. Whatever was there, this was here only. So that means whatever collection, whatever pus was there, it was coming outside. There was no intra-abdominal collection.
that is important that whatever is there needs to come out.
Yeah.
Because just a wound vac will not serve.
Yes, I agree. And for that purpose, we were doing routine CTs. So, okay, sir. So WAC we are already using. So anything else you would like to do with this?
Very difficult to answer this question, but I think we should continue with WAC treatment for some more sessions till the wound starts granulating and getting approximated. And if the sleeve infection is controlled, then I think then it will start granulating and getting approximated. The sleeve infection has to, the sleeve leak has to completely heal first. That is very important.
Yes. So now in this patient, when the wound was healthy and the pus was absent, we kept on putting WAC. And with that, what we did was we applied one elastin collagen dressing as a first layer. Over that, we applied the WAC dressing. So it worked wonder. And really the result was magical. Wound started healing very well. Now this is the wound which is healing. So this is after maybe 3 months. And the last image is after 4 months. So this was the kind of result, and patient completely healed in 5 months without WAC dressing. So after 30 WAC dressings, we stopped WACs and did normal regular dressings, and we managed to save the patient. So this is the patient with permission, with consent, the pic I am posting here. And anybody would like to add anything else? It's still high. It is very high. And still she is like obese. After that, she was diagnosed with CA uterus and underwent surgery. But after that also, she was obese only.
There is a small gap.
Yeah.
Can be suture closed rather than putting a mesh.
Mesh. No, we didn't place the mesh. Yeah. It, and I believe we should not do hernia surgery together with a bariatric surgery, because defect size also, I believe, keep on changing once patient start losing weight. So we should plan it later on. Anyways, I come to my next slide. So here I am opening can of worms. This is one patient with component separation repair, tar release, and we can see the mesh. Now, after removal of stitches and all those things, patient went home. After 10 days, we got a call that some water is coming out of the wound, skin is open and all those things. We called him back. So this was the condition. Whatever fluid was there already drained out. We can see a mesh over there, over the rectus sheath, and we can see the proline sutures. So now, so I would like to ask this question to the panelists first. Anybody who would like to answer, how will you manage this patient?
I think the principles are already laid out. Debridement, drainage. These are your first 2 steps.
Okay.
So this mesh probably needs to come out. As I said, I don't know how critical it is. It may be that you may end up accepting a recurrence of hernia. That's what you may have to, but the mesh, the way it looks here, it needs to be out. And then after that, drainage is in abdomen is by negative pressure. The other kind of drainage doesn't work. The only other suction drains you can use only if the wound is closed, and you can't do that here. You get the wound ready. So drainage, debridement, drainage, and optimization of wound. Next step, once wound is optimum, you close it, graft it, flap it, anything.
Yeah.
So partial mesh excision can sometimes work here.
Exactly.
So you need not remove the entire mesh, and
Yeah.
even under local anesthesia or no anesthesia, all that
Yes.
exposed mesh can be excised, and you can take a chance.
Sir, I absolutely agree with you. This is what I thought when treating this patient, a partial excision of mesh, but there was a problem. If you can, some videos there. I missed the video, but there is this underlying tunnel. One artery fossa, big artery fossa was completely going inside. So there's a big tunnel. So you cannot think about partially excising mesh and leaving all those things behind. So what we did was, we applied WAC with growth factors. We cleaned, debrided nicely, as you can see this next image. So we cleaned it nicely, and we used with this amnion, chorion growth factors are available these days in market, which stimulate growth of the tissue. Now it is Metridum kind of dressings are available with elastin and collagen, with which you can even apply WAC over the bone. Once you apply the dressing, put a WAC. After that, you can put a graft, and you can get excellent result over the bone as well. So same kind of thing. We use here amnion chorion dressing with PHMB in it. So it has antibacterial excellent properties. We applied this and it is available for vac dressing with multiple holes in it. So we applied that. Over that, we continued with the vac dressing. And as you all can see that there's a granulation tissue over the mesh. Can you see and appreciate at the 10 to 2 o'clock position? So this is the granulation tissue coming over the mesh, and we are hoping that this patient should do fine and well, because almost we are up to there. The subcutaneous tunnel is almost closed, completely healed. And if this area partial excision is required, we will do anytime in OPD. So I mean, we should think about something new. There's no harm thinking. You just need to explain patient properly everything. If the patient is ready to go ahead with you, if you can expend some money, you can try. No, we packed it with vac, sir. We packed it with vac, and the tunnel is already closed now, sir. Non-slippery vac is required. So non-slippery vac, if you use standard normal black foam dressing, that will stick to the wound inside and you will take out, so granulation tissue will come out along with that vac. So you need to take some non-sticky dressings. In this case, I used Hydrofera, which is non-sticky, and we can easily apply over the vac or in any tunnel or cavity. Where patient is having pain, you apply that dressing. It's pain-free when you take it out. Thank you. Yeah. Yeah.
I don't know if the audience agrees with this or not. Macroporous mesh has a beautiful way of getting salvage. You don't have to do anything. You just keep dressing, and the mesh is okay. The granulation invades the mesh and slowly everything gets covered. Just have to be patient. So macroporous, I believe in that because I have dressed a patient for 7 months and did not require mesh removal. And several patients I remember plaque necrosis and seroma formation, and most of them require a little bit of patience and dressings, and they don't need to be excised. That is my personal.
So what is the opinion of the house on use of antibiotic installation for dressing such a wound if cultures are positive?
I think those, I mean, if you talk to the negative pressure people, they will tell you not to use antibiotics topically. At least the principle is that whatever you are using systemically is not to be used topically. So topically you use other antiseptics. But we have used at times, we've used in fungal infections, we've used antifungal agents, we've used colistin in very resistant organisms, and we've got away with it. But these are off-label uses. I think these are one-off things. I can't recommend it routinely. The company won't recommend it either, because your resistance developing chances are very high. But I mean, I would admit that we use it, and it's worked. I think in our hands also it has worked. Regarding removal of the mesh, the problem is that, I mean, we have a patient who's had a infected mesh now in place for 7 or 8 years. But I see her every 6 months with 2 or 3 discharging signals. We take a pair of scissors, snip a little bit more. She gets all right. She's back again 6 months later. We've advised her complete removal, which is itself is a tough call because it's all very badly incorporated. And she's obviously she's not willing for that. She's happy doing that. So every time this is a treatment that has to be individualized. You really can't. And also how critical it is to maintain that mesh. If the price you pay to take out the mesh is an incisional hernia.
Explanting mesh in itself is very difficult.
Yeah.
All kind of complications possible. After explanting the mesh, how to manage that wound is a problem. And after managing the wound, that hernia is a problem. So explanting mesh is all problems. So as long as possible, we should try to save the mesh.
So every patient, this treatment has to be individualized. I mean, we've had patients who are very old and we snip off a bit of the mesh, then they go back home.
Yeah.
They'll come back for some more snipping. So it's very individual treatment. You can't generalize it.
Can I make a point? Yeah.
Coming to that point of antibiotic usage, consensus conference.
I think you need to put your mic closer. Yeah.
So there was a conference on back therapy. So they tried to arrive at some consensus about various issues. So what they analyzed and what they came to conclusion was that normal saline works equally well as compared to any other antibiotic solution. Our personal choice is also PHMB and butane solution. That's we feel comfortable. Literature says that normal saline works well. Second, regarding topical antibiotics, it was that conference only that it was discouraged because it leads to formation of resistance. Ideally, it should be avoided, but yes, off-label, we have used it, everyone uses it. Literature says something else.
Okay, so I would like to add one more question with that. There are many alternative therapies that we discuss about in conferences and many other places, but we hardly believe it's working or not. So I want to know, and this question is to Dr. Khazanchi, what's your opinion about hyperbaric oxygen therapy in wound management?
I think I have not used it. Personally, I don't have a very high opinion of it. But when you have, sometimes when you have nothing left,
Yes.
you try that as well.
Mostly we use at that stage only.
Certainly, it will be the last thing on my list.
And these days we have many options available, local hyperbaric, then warm hyperbaric, and all those things are also available in market these days. But one more excellent.
I am no expert because I haven't used it. I have no, we don't have it in this hospital. So maybe my opinion is biased, but I don't have.
So there is one more newer modalities are coming now.
Not start very early. I think when everything else is exhausted.
So one more newer modality is available these days, fat grafting with wonderful results.
Yes.
So what's your take about, can we think about doing fat grafting over the mesh with excellent results everywhere
Well,
as of now?
it is not fat grafting. It's actually using growth factors from
Yes.
the stem, adipose tissue derived stem cells.
Stem cells.
So it's like, again, stem cell usage has its own regulations. What we use is just some blood factors, and I think Vimlendu is our stem cell.
Yeah. There is one more thing, is PRP soaked gauze can be used. They provide you with growth factors.
Yeah.
That can be,
I agree.
extracted from
PRP
the
is, yes,
blood.
it has good result, but this is recent available procedure, fat grafting, wherein you need to take some fat by liposuction. You put in a machine which costs around few crores, and then it will give you a layer of skin-like fat, and that you can put over the bone or any other place where you feel like skin graft is not working, but it will give result. That's for sure.
Yeah, can I make a point?
Currently, the stem cell usage for this will only be under any the research studies. You are not allowed to use it.
Thank you. Okay, so time over. Okay, so this is the last maybe 1 minute. This is one video by Dr. Rajesh Srivastava. This is
Abhishek. Before that, I just
sir. No, sir. I'll stop it.
just one comment was, I don't want a discussion on this because we don't have time, but do we include all these complications in our consent, and are we as a team prepared? Do we prepare the patient also, and are we also prepared to handle this kind of complications which are time and money intensive when we do it? Consent.
You know, Dr. Shinde, I agree with you. The consent process is totally faulty. Everybody is in a hurry to operate. Anesthetist is in a hurry to give anesthesia. They don't explain post-dural puncture headache, which recently happened in one of my patients. It is a very taxing time for the patient, as well as the surgeon who is primarily responsible for the patient. So I think every operation, not only a general consent should be taken, all the complications, specific complications involved in that procedure should be clearly explained, which is completely lacking in our consent process. Maybe at a very high class hospital or a primary nursing home or whatever, that needs to be, the litigation process will definitely come down if we follow that process very strictly.
Okay, so I would like to interrupt because I think Dr. Andrew is waiting and one session is about to start. So with that, one last point I would like to say, Shinde sir, I would like to, there are few complications which we also don't know will happen. So how can we take all the type of complication? We cannot cover all those complications. Like one next slide, there was inguinal hernia repair mesh shifted into the bladder and obstructing the patient's urine outflow and all kind of urinary complications. So we don't know these will happen. So I mean, yes, but we should try to cover as much as complication possible. And when you are doing some radical procedure in hernia repair, take consent of the patient, explain everything in detail and give more time. Thank you very much.
Thank you, Dr. Abhishek, and thank you to all the panelists for such a spicy and peppy discussion, especially in the post-lunch session. We are moving on to our next session now, which is on peritoneal flaps. We have our first speaker, Dr. Andrew, who's connected to us online and has been has been actually been a part of the conference via YouTube for some time now. He's a consultant of general and upper GI surgery at Royal Infirmary of Edinburgh. He is a past president of British Hernia Society and also the general secretary of the European Hernia Society and a co-treasurer of UEMS abdominal wall section. So I'm handing over the, so we'll be able to listen to him via the net. So please welcome Dr. Andrew for his talk. Thank you.
Thank you very much for that kind introduction. Unfortunately, I'm currently sitting in a very noisy environment, so I have pre-recorded my lecture. So I will play that and then I will stay on for the discussion. So apologies, I'm not giving it in person, but I just did it yesterday. Delighted to be involved. Good day, everyone, and thank you very much for the privilege of being asked to give this lecture. There'll be a little bit on technique, a little bit on philosophy as we go through the lecture and look forward to the discussion. These are my disclosures. Now, the peritoneal flap, or we've renamed it the hernia sac flap repair, is really an extension of the retrorectus or traditional sublay repair. I'm not going to go into the detail of that because I think it's an operation that will be very familiar with you. And while these diagrams are a little bit complicated, and I will run through a case to demonstrate the technique, this was the original description of the technique, borrowing, in a sense, the hernial sac to help with the repair. Now, we called it the peritoneal flap, and that was perhaps a big mistake because people think of peritoneum as very thin. And if we actually look at the thickness of the hernial sac, in this case, a patient who had a healing by secondary intention and skin grafting to a sort of burst abdomen, you can see that the tissues are actually remarkably thick, particularly at the blue arrow. So we're going to run through this poor gentleman who's had multiple laparotomies for trauma. He's actually had a failed retrorectus repair with biological mesh as well, so the tissues are a bit more sticky. And here we go. Now, you've heard quite a bit about pre-optimization, and I'm not going to say very much about that, but that's an important part to try and get some elongation to the muscles, whether that be weight loss, whether that's Botox, whether that's progressive pneumoperitoneum. The operation itself, don't be too aggressive with the skin excision to start with, but excise the skin and raise skin flaps back to healthy rectus tissue. Laparotomy in the standard way through the center of the sac. And you can see the adhesions are rather unfriendly due to multiple previous laparotomies. And when it's hard to work out where the head is, it's always towards the black arrow. And then you make a decision if the sac is an evil thickness. The thicker sac you may want to take to the front and the thinner part of the sac to the back. Here we're taking this part of the sac is going to the back. So we're doing a retrorectus dissection, keeping the sac attached to the posterior rectus sheath. And here's the completion done, and you can see we've got good transposition of the posterior layer over towards the other side. On the contralateral side, you're going to keep the hernial sac attached to the anterior rectus sheath. So a slightly sticky dissection because someone's been here before. And at the end, we can see we have the yellow arrow shows the sac attached to the anterior rectus sheath, and we've got what's left of the posterior rectus sheath. But then it's possible by putting stitches in from the top and the bottom and sewing towards the middle and not using all of the hernial sac to be able to bring the back layer together. So you can see I'm not using all of the sac. My stitches are going in a bit further towards the posterior rectus sheath. And we now have closure. The blue arrows are identifying that we have closure at the top and the bottom, but where the yellow arrows are, we've used some of the hernial sac to get posterior rectus sheath closure. Mesh in, whatever mesh is your standard practice, drains to taste, and then it's the closure of the anterior layer as well. The blue arrow indicates where the suture line is, and the inked arrow on the contralateral picture shows that it's this part, about 5 centimeters worth of hernial sac has been used to get the abdominal wall closed with reasonable tension, a bit more skin excised. And here we are pre-op, and 2 years later, a durable repair. Does it work? Well, again, I'm not going to spend much time on this, as this is our data from a number of years ago with reasonable follow-up, average of 5 years, that we use this technique. And we've used this technique as opposed to other techniques because of either because of very large hernias in our practice, or because of the plan for abdominoplasty. And the bottom line is very respectable recurrence rates. Very unusual to lose a mesh. And this is pre-Botox. So occasionally, particularly in the midline, we have resorted to some component separation, but this has largely disappeared from our practice now. Now, obviously, we've promoted this operation at a similar time. The Swedes, Agneta Montgomery, was promoting a similar operation. And this is their series, again, recently published. They're not comparable. So there's the retrorectus group and there's the modified peritoneal flap, slightly different time scales, slightly different hernia characteristics, and generally favoring the standard retrorectus, so less concomitant surgery and less presence of a stoma, so more clean operations. Obviously, the time periods don't overlap completely, so less follow-up in this group, but similar complications. The patient satisfaction questionnaire is part of their hernia registry. Interestingly, the modified peritoneal group are more likely to have a higher satisfaction rate, but the key thing is recurrence. Similar to us, they're showing this significant reduction in mortality of recurrence with a modified peritoneal flap over a standard retrorectus. So why might the peritoneal flap be better? Well, it's possible that the attempts in the standard retrorectus to get the midline together again may put too much tension on the repair such that it fails. Now, you've heard about you've heard about loss of domain already this morning and calculation of it. And I'm not sure we fully understand loss of domain or its calculations. Here's a very crude representation of incisional hernia, midline incisional hernia. The dotted line is the sac. So what's the loss of domain here? Is it 0%? Is it 10%? Is it 20%? Well, I would say it's maybe in the region of 20%, because when you're closing the midline, particularly in an abdominal wall that's somewhat rigid, doesn't move particularly well, and without component separation, you will be reducing the radius of the abdominal cavity. And this is effectively your loss of domain, the hatched line. And remember, reduction in radius, when you're talking about a volume, is radius to the power of 3. So a small reduction in radius, big reduction in volume. A lot of talk about closing the linea alba, restoring the midline. I'm not so sure how important that is. I believe that we need a myofascial ring. The ring is important for core stability rather than a midline closure at all costs. And indeed, a group, this is an interesting paper, it's worth a read, it's only a couple of pages, but they have suggested this concept of the sick linea alba complex. And we should actually not be using the linea alba in the reconstruction, but actually getting rid of it completely. Because when it fails, either laparotomy or in primary midline hernias, it's because it's sick and it's something that we shouldn't really be using. So a good, interesting thing to read, and you can make up your own opinion about that. Now, we have been told that the linea alba is an important part of reconstruction and it has to be closed. And we've been told that because people believe in it. And people believe in it, and the people who really believe in it, this is how they draw the linea alba, some massive, very thick structure. Whereas in real life, in this patient with a normal abdomen, this is what the linea alba looks like. It's almost something that you can't see. And therefore, it is a very flimsy structure. So maybe getting rid of it or not using it may actually be helpful. I've talked about the thickness of it. And is it stronger? Well, it might be. Typical anti-erector sheath, and particularly linea alba, the fibers are orientated horizontally. We're putting stitches in here and they might cut out. Well, the chaotic fiber orientation in a scar in the hernial sac may prevent stitch cutout, even if it may appear at times to be thinner tissue. I agree that's hypothesis rather than scientifically researched. The proponents of this technique are increasing. The opponents call it a bridging repair. And I don't know whether it's a bridging repair. We're good at building bridges. We've been building bridges across the stretch of water near Edinburgh every century for the last 3 centuries. But let's have a look at this lady, gynecological disaster, burst abdomen effectively, and we've tidied her up. But let's look at one of our slices of our CT before and after. So reasonable size defect. We've got some rectus muscle here on the left, none on the right. We can't perform miracles. So after reconstruction, we see the lopsidedness of the abdominal cavity, abdominal wall is gone. And we now have mesh. You can actually see the mesh coming here across, enveloped in scar tissue here, right across between external and internal oblique on this side. And we have restored that myofascial ring. Does it last? Because it's a so-called bridging repair? It's very hard to follow up patients long-term, but the odd one turns up as a surprise. So this poor gentleman had multiple laparotomies for Crohn's disease. This was him shortly after his repair. And this is him 10 years later when he came with his wife who had gallstones back to my clinic. This is his Ziffy sternum pushing up, and it's not a recurrence. And once you get the idea of the peritoneal flap, then you can start having a lot of fun. I've used it in tram flap hernias. I've even used it in bilateral tram flap hernias, and obviously out laterally, exploiting between external oblique and internal oblique to create the spaces. Primary technique or useful adjuvant. And that's always very difficult when you have developed an operation. I'm not sure I created it, but I've certainly supported it because the idea is actually based on a Brazilian surgeon's idea of 50 years ago. So I can't really give you a summary slide where I tell you what I believe, but I use AWR Surgeons Community set up by RAM a number of years ago as a great source of learning. And listening to that chat has helped me mold my practice for sure. And we're aware of this Dunning-Kruger effect, how new techniques come in, they then are learned as a bit of a disaster, and then they move on. And Danny Rosen always sits there in the background and comes out with a lot of sage comments. And I like this one. Some tools are more dangerous than others, and there are fewer shootings when there's gun control. And there's no doubt that some of the component separation techniques that are being strongly advocated today do have their downsides. The wrong parts of the abdominal wall are cut, creating iatrogenic hernias, which are very difficult to fix. And I know, I hope that Danny won't be upset by me quoting him again, but in this chat, again, you can see some key surgeons in this chat about who can, who should, and who should do abdominal wall. And this is Danny Rosen's confession that he has adopted the peritoneal flap and has largely abandoned a component separation. So instead of credentialing complicated procedure, maybe there's a need to promote the simpler ones. Ladies and gentlemen, I put to you that while the peritoneal flap or the hernial sac flap doesn't need to be done in every case, by setting out to preserve the hernial sac every time you do abdominal wall reconstruction, it's always there to help you out at the end. And in our practice, component separation as an additional part to hernial sac repair is really necessary. This is my final slide. Big welcome to you all to come to Manchester for the EHS 2022 conference. Thank you so much for inviting me, and thank you for listening.
I thank you, Dr. Andrew, for this wonderful talk. We can keep the questions towards the end of the panel. He'll be here with us via the net. The next speaker is Dr. Vikas, who is the mastermind behind this conference. He's a senior consultant at the Department of GI Surgery, GI Oncology, and Minimal Access Surgery here at Medanta. He specializes in surgery for complex abdominal wall hernias and bariatric surgery. He's done his surgical residency in the US and fellowship in bariatric surgery at Case Medical Center, Cleveland. So I'll be handing the dais over to him for the panel. Thank you.
Thank you, Dr. Diksha. So it's really an honor that Dr. Andrew DeBoer, who's described the procedure, is actually with us today, and he's kindly staying on for the panel discussion, which makes my job much harder. I'm sort of anxious with him sitting somewhere watching over the net. So, but I hope, I would like to confess as a disclosure that since we've started doing the peritoneal flap, we've got a strong bias towards the peritoneal flap. So, and we will show you in some of these cases and discuss some of these cases that we've had. So without ado, I'll get started. I request the panelists for the session to please come up. Dr. Sarfraz Beg, please come up on the dais. Can I request Dr. Shinde, sir, to please come up? And we have, I'm sorry, just give me a. Yes, Dr. Ashish Dey and Dr. Mahathir, please come up. I'm sorry, my mind's not been working since the morning, so please forgive me. So I'll just try to get through the session. So when we come to peritoneal flap, these are, before the session, I spoke to all the panelists. I had a bit of a chat. I discussed, and what are the issues that we would like that we should discuss in relation to the peritoneal flap. We've already had a very interesting presentation by the innovator himself, who's given us some concepts, that we've moved, really need to close the fascia, we really need to close the defect, we need to close it with physiologic tension, or we are going back, do we not need to close it at all and put in a mesh which is sort of a sandwich mesh sandwich technique, or how he's described it as a swinging door technique, where there's a good strong layer, and as he himself said, it's not the peritoneum, it's a misnomer. So let's address some of these issues, whether it can be a primary procedure or an adjunct to TAR, or does it obviate the need for Botox or PPP in some of our patients, because our patient population is different from Europe and US. There are cost constraints. Patients don't keep coming back to us. So there are constraints we have, where peritoneal flap may come very handy, whether it's good for non-midline hernias, emergency situations, obese patients, and what is the data on it, the complications, the recurrence rate. So let's just look at some of these patients. So this is a patient we had. He's a 66-year-old male who is 3 years post right hemicolectomy. It was T2N1 disease. He had adjuvant chemotherapy done. He has a history of COPD. He stopped smoking at the time of his colon cancer surgery 3 years back. And he came to us with this increasing size hernia, and his PET scan follow-up was fine. He couldn't get a colonoscopy done because there was too much looping. They said it's not possible. That's when he came to us for this requesting a hernia surgery. So I'll just show the CT scan pic of that as well. So you can see it's about 8 to 9 centimeter defect there. There is some moderate adhesions. It's a thin. Without taking more time, I'd like to start asking our panelists. So Dr. Ashish Dey, could I start with you? He's a senior surgeon from Gangaram Hospital. So looking at this here, so would you do a peritoneal flap as a primary? Do you think it would be a reasonable choice in this patient?
Well, looking at the anatomy, I mean, I could see both the rectus muscles intact in this cross section, and all the 3 lateral muscles intact. The defect, as you said, should be less than 6 centimeter, and considering
defect is about 8 to 9 centimeters.
Around 9 centimeters, and considering the anatomy of the patient, it looks like a broad abdomen. So I believe a primary closure would be possible in this patient. I mean, we won't need a peritoneal flap, posterior dissection, and possibly a unilateral TAR should suffice.
So you would prefer to do a unilateral TAR as opposed to a peritoneal flap?
I would keep the peritoneal flap on one side, but I think it will not be necessary. So we can excise it at the end of the procedure.
Okay. Dr. Mahathir, sir, your take on this?
This patient will require definitely the TAR procedure, mainly if it is if someone is doing it by MIS way, then to close the posterior rectus sheath, this will require definitely TAR, either unilateral or bilateral limited TAR. But in case of an open repair, if one go inside and he preserves the sac, then definitely it is helpful, and the peritoneal flap will be more helpful, useful in these cases.
Okay, so very valid point that if you went MIS, you would likely end up doing a TAR in this sort of a patient. But if you went open, you think peritoneal flap would be a reasonable choice?
If you apply Carbonell equation in this particular patient, if you see on both sides the muscle, you can see here the rectus muscle on both the sides. If you add the dimensions of the width of both the muscles on both the sides and width of the defect is more.
So this required star according to Carbonell's equation.
Okay. Can I ask Dr. Shinde, sir?
Well, I would agree with both my previous co-panelists, but in this case, what I see is that the patient is obese. There's tremendous amount of fat and he has COPD. So maybe he may not be a good candidate for a major procedure for like even a limited TAR. So definitely choosing a simpler option with under regional anesthesia would be better for him. But if we consider regional anesthesia not doing a larger procedure like TAR, leaves us with two options. One is to use Botox as an adjunct because rectus muscles are small in width, so midline will not come close together. Or then with or without a peritoneal flap hernioplasty could be a powerful option in this, since we are looking at the patient profile,
right,
and we would like to choose a simpler option, less complicated, and probably take into account his COPD also.
Very valid point, sir. If you use Botox, possibly this would come together with just a Reeves Stopa repair. Would you agree, Dr. Sarfaraz?
Yeah, I think almost all points are agreeable. There are two choices. One is to do open bilateral TAR or a peritoneal flap with a standard Reeves Stopa plus minus preoperative Botox. These are the two options.
So what would be your procedure of choice in this patient? Would you do a TAR if it came together with just doing a peritoneal flap as a primary procedure?
So, you know, Vikas, our thoughts on this, we've been doing peritoneal flap since Andrew visited us in 2019.
Right.
And we have stuck to peritoneal flap. We have even tested in our small case series that we published for patients with loss of domain to see whether this peritoneal sac can withstand the pressures of those kind of patients. And they do in our series with those follow-ups. So I would be more in favor of doing a peritoneal flap classical method. Here the subcutaneous fat is not too much, so I'm not very bothered about the SSI in this patient.
Okay, but do you think with this COPD, avoiding a TAR
Yeah,
would be
so that was one of the things. See, cancer survivor, A, B, COPD, and the panniculus looks a little too much in the lower part. All of that tells me that, you know, doing a simpler procedure, not doing a CST would reduce the morbidity of the patient.
Absolutely.
Post-operative.
Okay. So Dr. Ashish, can I ask you, so on the other side, he has a lot of cough, he's COPD. Would you worry about doing a peritoneal flap because you're not closing the fascia, you're just putting a bridging mesh?
Yeah, we are doing a peritoneal flap. Let us think of it this way. I mean, it's kind of an adjunct. It's not whether we do a peritoneal flap or we do a primary closure. We have a mesh, we have a large mesh that will act as a corset. So provided the post-op recovery is uneventful and the extubation is smooth, this kind of a patient, I think, would do good with a peritoneal flap. We should not worry too much whether it will give strength or not. We already have a mesh in place, and if the PRS comes together, then just for the ARS closure, the peritoneal flap should be a good choice.
Dr. Mahathir, can I ask you, so would you be okay with the mesh coverage just up to the linea semilunaris with a peritoneal flap procedure with the mesh sandwich?
Yeah, I think that will give definitely good support, but most important in this particular patient, we have to think not in terms of only in terms of a hernia defect. We have to think in terms of the disease, what he is suffering from, because he is a post chemotherapy, post hemicolectomy patient, it's a cancer patient, and with COPD. So considering all the aspect, I think with this particular size of the mesh will be sufficient for him.
Okay. So I think more or less the panel is in consensus that the peritoneal flap would be a good, and that's what we did. And you can see, I don't know if you can appreciate, he's got this nice posterior sheath close with a bridging peritoneal flap of about 8 centimeter. And we've got a, and then after the mesh placement, the anterior sheath close without tension, came without tension. I think that's the main advantage of the peritoneal flap with a nice mesh sandwich. And he came back to us. I don't know if the video will play. And I don't think you can, there is much of a, so I don't think there is much of a bulge there per se that you can see. So, and patients have followed up now for a year and a half and he's quite happy with that. So we were happy with the peritoneal flap procedure in this patient as well. So then I'll go on to the second case. This is a patient who is a 30-year-old male, had a laparotomy for trauma 2 years back with small bowel resection and anastomosis. And this is his clinical picture. You really have to see the video to appreciate the defect there. And his CT scan. So this is his CT scan. So, Dr. Ashish, what would be your, when you look at the CT scan, what are your thoughts?
Yeah, if we had done a dynamic CT scan, the loss of domain would have been more. I mean, normally, obviously, he has a loss of domain. So this patient, no matter what we do, a bilateral TAR will not bring the PRS in the midline. So in this case, I think a peritoneal flap will be necessary. What Andrew DBU does is he keeps a flap with the ARS and he keeps a flap with the PRS. And then what he does is a sliding door technique or a sandwich technique that we use. I think that would be beneficial in this patient because anyways, the PRS is not going to come together even after doing a bilateral TAR. So that technique will definitely be helpful.
Mahathir, so what do you think about a TAR? What would be your procedure of choice in this kind of patient?
Yeah, in this patient, as you see, again, patient as such, so the physique of the patient, he's a thin, lean patient. So here the defect size is quite big for any procedure what we are doing. So here only TAR is not going to suffice, and there we need additional, if we get this peritoneal flap, then that will be definitely useful. And that is what an open procedure is the choice, no doubt about it.
Okay. So, yes, sir. So while we see the CT, Dr. Shinde, sir, can I ask you, how many times during a TAR do you think it's very difficult to close the anterior sheath?
I think the TAR gives a very comfortable posterior sheath closure, but the anterior sheath coverage, I mean closure, is difficult in about 15 to 20% of the times. And if we take this percentage to the larger hernias, then I suspect that that percentage will rise to almost 35% of the times. We talk about overall percentage, but a 10-12 centimeters hernia is not the same as 15-18 centimeters hernia. So if we take large hernias, then bridging repair percentage will definitely be higher.
Very, very true. So Dr. Sarfraz, would you agree with that, or your views on that?
So because in this patient, obviously a bilateral TAR is not going to work and you need something as an adjunct with it. And peritoneal flap suits this very well. And this is exactly what we published. We call it TAR plus at our center.
Right.
So TAR plus would work perfectly well for this kind of a patient. And the other area is the skin itself needs to be addressed, skin and the subcutaneous tissue. Those are very thin. So those cover has to be taken care of. Once we excise that skin, at least 15 centimeter wide excision needs to be done. I'm sure you're not talking about the skin and the soft tissue, but in that patient, the skin and the soft tissue needs to come out for at least 15 centimeters.
Yes, totally agree. He had retention sutures placed, and you very rightly observed that the entire skin is, along with the muscle is
So
gone.
there was a talk on the vascular anatomy, and I think for the sake of the audience, I'll repeat it because it's important. All the vessels which comes from the rectors, they perforate and they go up and supply the skin. But the skin over the sac, when the sac is out, there is nothing on the skin. So any skin that we leave behind, which is not supplied by the rectus perforators, is going to die. So do not be so, kind towards the skin. Be merciless towards the skin in this kind of surgery.
Do you think there's that not doing Botox here with the peritoneal flap, in the patient profile is okay?
So Botox usage in this patient, I will not use, although there is very robust lateral muscles. There's no harm in doing it, but I think with the peritoneal flap, I will definitely get away in this patient. Depends on each patient. thinner male patient, smaller girth male patients, I think this is where I use Botox and then do peritoneal flap these days.
So for most patients, you think we may be able to substitute the Botox with just utilizing the peritoneal flap?
Yeah.
But I
Yes, sir.
think that we also have to consider the patients, I mean, a male patient with strong muscles, and if he's got a heavy occupation, then maybe using Botox will make sense, because the better that we get the midline close together, at least the evidence today says that that should be the norm. Okay. And secondly, PPP may not work so well because it is difficult to contain the air inside the abdomen because his skin is ballooning out. And though we say that we use abdominal binders and all, but patients don't keep it all that tight, and it's very difficult to manage PPP in these kind of patients. In female patients with large abdomens, there with abdominal binder support, the air will remain inside. But in this case, Botox definitely can be considered.
So where the patient is affording, you think Botox would
Yeah.
usually be a good idea? It's a great point. Do you think Dr. Punjani, sir, also, but you would Botox this patient, or can we have a mic here, please? If you had this patient, would you Botox? What would be your line of management? Would you Botox him, or?
I'm a strong proponent of midline closure. Sorry. So I would do here the Botox, even PPP, and do a full-blown bilateral open TAR, and 95% times we will be closing it. In case I have to do it, the flap is already available for me to use it as a patch. But that will be a last resort and not first plan.
See,
Plan B.
Can I ask Dr. Ramana, sir, also, what would be your plan in this sort of a patient?
I completely agree with Ramesh. By and large, the important thing is, I would raise 2 points here. One is that if you look at the data, after repair of complex midline hernias, especially after bilateral TARs, in the best centers in the US,
Yes.
the recurrence rates, whatever they may be under 3% or 4% or 27%. The recurrence rates are the highest in those whose midlines were not closed. So wherever they have bridged, they have burned their fingers, they have had recurrences. So midline closure, when possible, has to be considered as the ideal goal, and where the patient is of a specific subset. For me, it would be an elderly, frail patient with loss of domain with poor physiologic reserves. I would not bother so much about midline closure in that patient. I would use a peritoneal flap, and I would be happy to just give her a better quality of life. So that is one thing. And the other thing is, a young man with good solid abdominal musculature and a closable defect, 15 centimeters defect is not impossible to close. What happens when you do your peritoneal flap repair and he develops a recurrence? That question has to be thought through as well. It's not magic. You can't do any repair and think that you won't have a recurrence.
But
you should give the best repair that you can with a patient.
so, but can I ask you, so the series by Dr. Andrew Dubue's group himself, so it's 251 patients with a recurrence rate of 2.8%, which is significantly lower than any TAR, recurrence or any ACST recurrence. I know it's a single.
That's why we are still talking.
That's why we are saying. So we are still looking for more data other than a single center, and we are, I think, getting more data. Yes.
Since we have come to this very sensitive question, I have a different look at it. Whenever these kind of questions need to be answered, whether it's an adjunct or a primary procedure, there are three things that would lead to the answer. One is data, but data is only one of it. Secondly is the social acceptance, the social pressure. Okay, because the social acceptance and pressure for a certain procedure could be so fast and so wide that even a large amount of data will get created, and that could act as even a graver and greater force than data itself.
Sure.
And third is our own human nature, the personal bias, the surgeon's mindset, who tends to think that complicated is better. Surgeons are, we find it difficult to accept something simple. A simpler technique might find it more difficult to sell itself and to get established. So maybe this could be a good procedure as a primary procedure, but evidence is not going to create that kind of an environment. It will be the data, the social pressure and the social kind of acceptance, and then the surgeon's mindset of how surgeons look at it.
Right. So I'll just show you. So we actually did do a TAR plus peritoneal flap in this procedure, and I'll just run this quick video. So this was a very good flap. Just taking down this flap from the hernia sac, and I'll just play it quick, and you can see it really is a misnomer. I think it's a part fascia, part peritoneum. It is much thicker than any peritoneum. So we got about 12 centimeter on one side, and this is the skin that we're going to excise. As Dr. Baig pointed out, this is all thin skin, and we can really excise all this skin. And so it actually came together well without, so this is the closure there. And this is you see that the TAR is done, and we've got beyond the TAR, beyond the TA division, we've got about 12 centimeters to help us. It's a very good thick flap, and the mesh is going to go. We of course done the complete TAR on both the sides.
But because
Sir.
mere thickness and appearance, if it were enough, the patient would never have had a hernia, because he has been living with this peritoneal flap intact. So how did that help?
Sir, but if you look at this patient, in spite of bilateral TAR, once all that the domain went inside, the defect became much bigger. I know it's 15 centimeter on the CT scan. So when you actually look at it with that kind of a defect, even with TAR, we have not done Botox. Maybe I agree with you, if we had done Botox, possibly it would have helped us a lot. But I think here preserving the sac, the peritoneal flap, came in really handy, and I think otherwise I would have ended up.
I'm not denying that at all.
Right.
Peritoneal flap is a splendid technique which salvages you on many a bad day. But my argument was precisely on one point.
Right.
It's a nice fleshy looking flap. This is not just peritoneum, it's much more than that. And see, it is so thick. So this is good enough to support the patient's organs in place. So I have a logical argument.
Can I make a point here, sir? Okay. Now this patient will be leaving with a 35 centimeter or 30 centimeter mesh that will form a new abdominal corset. Yes. So in spite of that, that is an additional barrier, and that would provide the maximum support.
So the benefits are of the mesh and maybe not of the peritoneal.
True. But yeah, I think it's the technique. The bridging the mesh. So I definitely I take your point. Yes, ma'am.
TAR, once you have done TAR, bilateral TAR, you have to support it with a mesh. Do you believe in those layers? No. So similarly, why are you arguing with them? You stop putting mesh after TAR.
Thank you, ma'am.
You don't. You put a bigger 30, 65, whatever. You are getting the support of mesh.
No, ma'am.
I'm really talking about the appearance and the fallacy that a thick looking peritoneum is good enough. I'm talking about that.
No, I think because the proof of the pudding is in eating it, and therefore we also had a lot of skepticism. We chose 5 bad cases, loss of domain cases, 50 to 40% of LOD and their Tanaka, and then thereafter we subjected them to TAR plus, and we observed their CT scans, we observed their rectus, we observed their bulges and the satisfaction rates. And if Andrew is around, I think he would probably be able to answer that. We found in those 11 months follow-up median, which means about 8 to 18 months, we found that all these patients were having a good tone of the abdominal muscle. The leg rising test, the CT scans showed that it was working. It is a thick layer. So whatever be the etiology behind it, we do not know. We could always subject to go for look at animal experiments, do histopathological examinations, but somehow it does work. So the proof of the pudding is in eating it.
Yeah, I agree with you, sir. But I agree with you as well. We need more data definitely to support the procedure like we are having. But yeah, having said that, we're having a very good result with it, but we need to publish it, of course. So this was him, that patient, but I'll just skip over this. So go to something less controversial. So this is our third patient who came in obstruction. The picture itself, speaks volumes. You can, and this is a cut of the CT scan. So again, Dr. Ashish, can I start with you? Where this is an emergency situation. Patients come in obstruction, and how do you think it can be salvaged?
Well, this is just one cut of the CT scan, but if the patient is obstructed, anyways, we'll have to relieve the obstruction. So I think if we could relieve the obstruction, leave the patient open, do a laparostomy kind of a situation, and fight another day.
Okay, Dr. Mahathir.
See, in emergency situation like this, the most important part comes with the closure of the abdomen. And that is where the problem starts,
Right.
So in those cases here, I think the sac which he is having is quite big sac. So peritoneum of that particular sac is the hernia sac itself. It will be useful for closing of the abdomen, and then the above part, if skin is getting closer, then it's okay. But if it is not, then we can put a vac or something like that.
So if you think you had a good peritoneal flap, would you be comfortable using that as your posterior,
definitely.
at least one of your
Yeah, to
posterior
closure of the abdomen, at least to close the cavity. No, in but this situation, just closure, because that is what is important in this situation. I'm not going to put a mesh for sure.
So you would just somehow get just for the closure purpose.
Yeah, and the hernia will be second thought. It's
as we're running out of time, I'll just take the last two comments from.
I'll just want to say that what Rahul is saying is using the sac as it is. Peritoneal flap means you have to go to the rectus sheath and open the rectus sheath bilaterally.
Right.
Then that will constitute anterior and posterior peritoneal flaps. Here we are just going to cut the sac in midline and use the two flaps to either in midline or maybe even double breasting.
Yeah.
Just to give an additional strength. This is not the true peritoneal repair flaps that we develop in a hernia repair.
But could you combine it with say an onlay mesh if it's well supported by a posterior good peritoneal flap?
In an obstructed patient, I would not, because this patient can have distension further, can have paralytic ileus further.
Yeah.
So it would be a temporary abdominal closure, even with a supportive vac. I would not do a definitive procedure.
Dr. Sarfraz.
Yeah, I think we are talking about obstructed hernia. It's just a GI surgery at the moment. It is not a hernia procedure at all. So whether you use a sac or not, it's up to you. It depends on the clinical situation. Where I would like to get back is because may I ask you a question?
Absolutely.
Okay, great.
I don't think that's
you saw us doing peritoneal flap in our center. You tell me, how do you use peritoneal flap? What is your technique of taking the sac? Do you shave off the skin right up front with the skin incision? What do you do?
No, sir. I do mark the skin edges, but I don't, shave it up front. Do the usual midline laparotomy. But yeah, I do mark the minimum required excision. What I think is but I may extend it if possible and take it as far lateral as possible during the closure time.
So when do you shave off the skin?
Towards the closure, towards the end.
Towards the end.
Same with me.
So do you use the vortex of the incision?
Yes.
Again, just going back, something that we learned and something which we published, when we do the peritoneal sac, taking the cues from, the criticism of peritoneal flap, which we think is absolutely okay. We don't have data yet. So what we see is when we make the incision, but we bisect it first. We bisect, do laparotomy. And while we are shaving off the skin from lateral to medial, we leave the vortex. The vortex is not good at all. The skin and the peritoneum are so thin that if you try to use that peritoneum, it is just my bias, that might lead to a pseudo recurrence, a bulge. So we leave the vortex of the peritoneal sac. So if it's a 15 centimeter defect, probably we'll end up using 5 and 5 on each side. The central 5 centimeters is not used at all.
Yeah.
And this bisection technique and using the lateral part of the peritoneal flap has given us more confidence, because that seems to be pretty tough. So just a point, which no scientific data to prove it. It's just something that we do.
Thank you. As we are running out of time, can I take some final closing comments from Dr. Andrew, if he's still with us?
Yeah, thanks very much. Interesting discussions. I think
can you put on audio visual?
Can you put on?
Can you hold on for a minute? We are not able to hear you.
Dr. Andrew's screen, please.
And he'll also have to speak pretty close to the mic, I believe.
Can you hear me?
Very faintly, if you can speak a little louder.
Yeah. In a sense, Botox is, which was discussed, is an adjunct. We only started using that recently. I think you need to have tools in the toolbox. You know, the carbon do component separation or not. The study by Love using that equation showed when the numbers were optimum, that even then 11%, that's 1 in 9 patients still needed a TAR for closure. And in the worst scenario, where you think you would definitely need to use TAR, 3 out of 20 didn't. They still managed to get it together. So no matter how big or little your hernia is, the abdominal walls are different and you have to behave differently. It was mentioned, well, what do you do if a peritoneal flap hernia repair fails? Well, I put it to you, what on earth do you do when a bilateral TAR fails? Because you've already done a whole lot of dissection with a bigger mesh. So there are things around that. Yes, we need more data for sure, but the best results for TAR out at 5 years to match our results are often high single figures into low single figures, around the 10% mark. And there are lots of publications out there about failure to get midline closure and concerns around iatrogenic hernias, where you're less likely to get a iatrogenic hernia with the flap technique. So you pays your money, you take your chances. Will it cope with large fit men? The gentleman I showed you at 10 years follow-up, he was in his 30s when I did his surgery. He's in his late 40s now. He's a county championship squash player and he continues to play squash. So the rigors of playing squash haven't caused his hernia to fail. Now, I know that's anecdotal data, and I'm really looking forward to all the data coming out of India using the flap technique, but it is an easy operation. It's something that it's relatively straightforward to do. Yes, you don't just cut the flap in half and use half each. Use as much as you need. And if you need none of it, take it all away. But it's there as a bailout. So I thoroughly enjoyed the discussion and wish you all the best.
Thank you. Thank you so much. Thank you. So I think we are in for the tea break. We could just take a short 10 minutes break and then rejoin at 4 o'clock.
अरे फोटो निकालना है ना, फोटो निकालना है ना. आ जाओ ना इधर. आपके बिना थैंक यू. अच्छा.
I just want to test if we're able to see the PowerPoint.
Hello.
Hello.
Can you hear me?
Just want to see if my PowerPoint is visible on the screen when I share it.
Hello.
Hello.
Yes, I'm audible to you.
Are you able to see my screen?
Can you share your screen?
Yes, I'm sharing the
Just
screen.
look at the screen. The top right third option, last third option. Yes. Next. No, the presentation.
Question remote control.
It is perfectly visible. Can you speak a bit, ma'am?
Oh, yes. Can you hear me? I just want to make sure the volume is good. Okay, thank you so much.
I welcome everybody back from the tea break. Our next session is on hernia emergencies. We first have a talk on salvage techniques for hernia emergencies by Dr. Shujun and Dr. Robert Ben. Dr. Shujun is an aspiring surgical resident pursuing a career in trauma and critical care surgery. Dr. Robert was trained at University of Wisconsin-Madison and Guthrie Clinic in Pennsylvania, followed by a fellowship in trauma and critical care surgery at Vanderbilt University in Nashville. So I'm handing over the dais to them. They'll be connecting with us via net, and it's an online presentation. Thank you.
Thank you, Dr. Singh, for introducing me. Hello, everyone. I'm Shujun. It's my honor to give this presentation prepared by Dr. Bain and me on open abdomen as salvage techniques for hernia emergencies when elective hernia repair turns into acute care surgery. Let's see. We have no financial disclosure or conflict of interest. So the objective today is we would like to provide an acute care surgery perspective on open abdomen as a potentially life-saving technique when patients who underwent elective hernia repair presents with disastrous complications. And using a clinical case, I'll describe the history and current practice of open abdomen management and how open abdomen can be a helpful tool in managing patients with particular complications after hernia repairs. So acute care surgery is a relatively new concept that is now widely popular in the United States. It is the application of trauma principles to the treatment of patients with other urgent, time-sensitive surgical condition emergencies. So without further delay, let's start the case. So as shown over here, this is a patient who has a surgery of hysterectomy, laparoscopic cholecystectomy, laparoscopic appendectomy, prior laparoscopic adhesiolysis, and prior XLAP, who is now undergoing a elective ventral insertional hernia repair. As shown in this CAT scan, the patient has a few ventral insertional hernias, and there is just one knuckle of the transverse colon that is incarcerated in the hernia. So this patient was taken to the operating room, and it was an elective ventral incisional hernia repair. Both the surgeon and the patient was expecting a same-day surgery or maybe overnight admission for pain control and then recovery starting from that point on. So the patient, because of a history of COPD, actually she was reintubated post-op for hypoxia. Afterwards, she was successfully extubated on post-op day 2, and she was kept in the hospital for prolonged need for IV pain medication. Eventually, she was discharged to home on post-op day 7 after she's having good pain control, tolerating diet and ambulating. However, she returned to the emergency room in 2 days after discharge with hypotension, tachycardia, generalized peritonitis, and we have the CT from readmission shown over here. So as we can see, there is extensive subcutaneous air, and there is intra-abdominal free air, and there's material inside the abdomen that's concerning for infected hematoma versus bowel contents that's leaked. So the patient was emergently taken to the operating room. And in the operating room, what is found is that patient has frank feculent peritonitis with a missed enterotomy in the transverse colon. And the ventral mesh was completely adhesed from the abdominal wall. Because of the extensive subcutaneous necrosis and also in the fascia, the patient was also debrided in the fascia, muscle, subcutaneous tissue, and skin. So after debridement, there was a 30 by 18 centimeter defect because the bowels were all swollen from the inflammation and because of the loss of fascia from the debridement. So what can we do at this point? Because clearly we are not exactly sure whether the repair for the missed enterotomy and the transverse colon was definitively controlled due to dense adhesion from the omentum to the transverse colon. And also we have a abdominal wall that is not suitable for primary fascia closure. So what we did in the operating room is open abdomen management. So it is a concept that is started in the 1990s, and it's mainly for damage control now with also wide application. It initially was for trauma with bleeding for damage control before a patient reaches physiological exhaustion, but now it's having selected indications in emergent general surgery, including peritonitis with intra-abdominal sepsis without adequate source control, such as in our case. So why are we using damage control? Because we found out that there are less hypothermia, fewer infection, including intra-abdominal abscess and fistula, if we are able to do quick source control during the initial damage control operation without having the patient stay in the operating room on the table for any prolonged surgery for definitive repair or abdominal closure. But usually they are able to achieve definitive abdominal closure during their initial hospital stay. So here I present a algorithm by Dutton et al. And this is showing the management of open abdomen in stages. So this stage that we are having is an emergent laparotomy with damage control. The best thing is definitely to close the fascia during the initial operation, but when the patient is not physically suited to be closed during the operation, we'll do open abdomen. So in our case, an Apthera vac was placed. So a brief overview of the historical temporary abdominal wall closure techniques. There are the plastic silo with Pagoda bag, skin approximation with towel clips only to prevent the bowels from eviscerating, and zipper. So this is Dr. Boraz who invented the Pagoda bag. So this technique is simply by sewing a 3-liter sterile saline bag with the edges sewed to the skin. The main function is to prevent the bowels from eviscerating. And here, as shown, are the towel clip closure techniques for really temporary and fast closure. And here is the zipper. So all those techniques, those 3 techniques are good for temporary management of the open abdomen in places lacking resources as a bridge for transfer to higher level of care, because studies have shown that they have a worse rate of primary fascia closure and also higher rate of enteric atmospheric fistulas. So for the more current options, what we have are vacuum pack technique, Barker vacuum pack. There's also commercially available vacuum systems with the negative pressure dressing. There are also dynamic securing device for fascial edges to facilitate serial approximation of the fascias to for attempted closure in more difficult cases. So we'll also discuss all of this in the further slides. So the Barker vacuum pack is also a great technique in areas lacking resource. If commercial dressing is not available, we have actually used it in one of our satellite hospitals, which doesn't stock Apthera routinely as a bridging method to transfer to a higher level of care within our system. So it is pretty simple. So what we do is we apply a tin drape to cover the bowels, and we perforate holes on the tin drape, sterile tin drape. Then we put sterile towels, lap sponges on top of it, and we put in a JP drain, and then cover the whole area with ioband dressing to occlude it, and then we connect the JP drain to suction to provide a vacuum negative pressure to remove any fluid. So the advantage, as shown over here, is it prevents adhesion between bowels and abdominal wall. It is readily available in most areas. It's also simple, atraumatic, and inexpensive. Now, as mentioned before, there are Apthera vac systems available. That is dressing attached to a vacuum machine. So as shown over here, these are slides right from the company, what we do is we put visceral protective layer on top of the bowels, and then we apply foams for the vacuum dressing, and then we occlude it and attach it to the machine. So in a couple studies sponsored by the company making this, they were comparing it to previous best of care with the Barker's vacuum packing technique. What they found is that trauma patients and surgical patients in this multi-center study who has either Barker's vacuum packing or Apthera for at least 48 hours for damage control laparotomies and treatment for intra-abdominal hypertension or severe sepsis, that the Apthera has better closure rate of primary fascia closure rate. It also has a lower all-cause 30-day mortality. The reasons are studied. Most likely, the reason is because of removal of toxic ascites from the abdomen. There is actually a better prevention of heat loss, as open abdomen actually is a great source for heat loss. So one of the study also using the negative pressure wound therapy to remove the ascites, they shown in a porcine chronic inflammation model that this wound vac is able to reduce systemic inflammations. It also reduces organ injury and mortality rate. So after temporary closure of the abdomen, our patient was transferred to the ICU for resuscitation. Other than the standard management of patient on vent who needs sedation and the routine correction of lithotrient in patient physiological distress, the main issue about open abdomen is patient needs enteronutritional support. They also need a more judicious management of fluid balance other than aggressive crystalloid resuscitation. This is because the open abdomen is a really hypermetabolic condition with loss of 2 grams of nitrogen per liter of abdominal fluid output. So what has been shown in multiple studies is that it's safe and it's mandatory to feed a patient with the open abdomen. The best thing is to start early and start enteral nutrition if possible, because it has been shown to reduce time to fascia closure. It reduces fistula rate. It also decreases the rate of ventilation-associated pneumonia. So unless the patient has high output enteral atmospheric fistula with open abdomen, then all patients we routinely start tube feeding right after surgery once patient achieves a physiologically stable state for feeding. So in the meantime, our goal is to have early fascia closure. The management is continued and goal is to close by day 8. If that is not possible, then we'll try attempts for a serial fascia closure technique. So in this study with the 344 damage control laparotomies, what has been shown is that patient with fascia closure before day 7 has a significantly lower wound complication rate than those who have fascia closure beyond day 8. So they have seen a lower fistula rate and lower wound complication rate if fascia is closed earlier. And in this consensus paper for open abdomen in patient with non-traumatic indications for open abdomen, they have shown that negative wound dressing with fascia traction is the best way, with traction provided through mesh or dynamic retention sutures, because they have higher fascia closure rate and lower EA fistula rate. So this is a study where they're using synthetic mesh to approximate the fascial edges and provide traction with wound vac removing any toxic cytokines. So what they have shown is a fascia closure rate of around 75% and a fistula rate of 7%. There are also other ways to approximate the fascias, including the Whitman patch, which is a Velcro sheet attached to each side of the fascia to provide continuous traction. So patient will return to the operating room for serial closure of the fascia and eventually, hopefully, to achieve primary fascia closure. So this is one study where they shown primary fascia closure rate of 100% with a mean time to fascia closure of 8.7 days, right around the time when complication rate will increase. There are also other commercial dynamic retention sutures for improving fascia closure. And if those are not available, the salvage technique is to use skin graft or use a biologic bridge for definitive repair. This is because open abdomen is inherently fistulogenic and it's a higher energy demand state. So sometimes using biologics and accepting later hernia repair will be better for patient care. And what we want to show is that compared with the routine resuscitation in the ICU, in patient with open abdomen, we need early fascial closure, and we also need a more balanced resuscitation between crystalloid and vasoactive medications. So the cornerstone for managing patient with open abdomen is a overall management of the patient rather than just preventing the bowels from falling to the floor. And here we described many different current options for achieving better primary fascial closure and to salvage patient from emergency after elective repairs of hernia surgery. And one important point I still want to stress is we want to achieve closure of the abdominal wall by day 8 after initial surgery to reduce the wound complications. And eventually, patient was taken to the OR with a biologic bridging mesh, and she had multiple post-op follow-ups, and her wound was eventually healing well without any EA fistulas. So thank you for your attention, and I would be available to take any questions.
Thank you, Dr. Shujun and Dr. Robert, for that talk. We request you to please stay back for the panel. The next we have a panel discussion on hernia emergencies, which will be moderated by Dr. Amanjeet Singh. Dr. Amanjeet is the director and head of colorectal surgery at Medanta Medicity Hospital in GI surgery, GI oncology, and minimal access surgery department. He's a pioneer in his field, having described and popularized the Medanta hand-port technique for hand-assisted colorectal surgery. He has received training across the globe from South Korea, Taiwan, Japan, and Strasbourg, also a member of the American Society of Colorectal Surgeons. For the panel, we have Dr. Subhash, Dr. Ashwin Bava, Dr. Jyotsna Kulkarni, Dr. Suresh Vashist, and Dr. Sanjay Chore. I invite them all to the dais here, please. Thank you.
So after a very fancy techniques of abdominal wall closure, so we'll be coming to the basics of in a hernia repair. So I think we have a very distinguished panel today, and I hope we'll be able to learn a lot of new things. So I think just we have a limited time, so we'll just keep the answer short. And better than citing individual cases, let's talk of some evidence on that. So the first question I think is, how do you differentiate? This is a basic thing. How do you differentiate whether a hernia is obstructed, incarcerated, or strangulated? So maybe start from left to right. Dr. Sanjay?
Yeah. So obviously the history and for how long has he had it, incarcerated would obviously be something which has been there for long. It is actually a irreducible hernia. So the difference between the obstructed and a strangulated, of course, making a distinction would be slightly difficult. It would depend on the clinical signs, whether there is any redness locally, tachycardia and other things. And of course, you can have other investigations which are fancy. You can have,
We'll come to that. Just the definition. So any hernia which is irreducible, which we cannot reduce, is an irreducible or incarcerated hernia.
Yeah.
So, and if it is associated with obstruction, it's obstructed, and if signs of strangulation, it's strangulated.
Yeah.
So what are clinical indicators, Dr. Jyotsna, of strangulation?
Yeah, I think an obstructed hernia compared to when strangulation occurs, initially the patient would say that it is not reducing, but later on with strangulation, when it sets in with the compromised blood supply, he would complain more of a lot of pain. He could have, depending on the what is the segment of the intestine obstructed, patient could present with vomiting, abdominal distension, not passing gases. There could be localized redness, tachycardia, and patient would look ill. Okay. So depending on what stage of strangulation it comes to you, all these signs will be evident.
Okay. So any blood tests, sir, you will like to have? Just to
Simple
rule out
counts.
strangulation. Dr. Subhash?
Yeah. So first and foremost, of course, is the CBC where the counts matter somehow. In these patients, there is always a leukocytosis. So we should, that is the first and foremost investigation which is required in this.
Okay. Any particular test which can rule out strangulation?
Any particular?
Test, blood test,
Blood
which might indicate that it's a strangulation.
CRP might.
It's a
CRP might.
It's a CPK, lactate, and maybe D dimer. Yes. So any role of imaging, Dr. Suresh?
CT?
Any role of imaging?
See, basically strangulation is clinical suspicion. And there is recent, change in the intensity of pain along with the tachycardia. Patient's face itself indicates, rather than going into fancy investigations, that patient has gone into strangulation.
Yes, yes. So it's basically a constellation of signs and symptoms, augmented or supported by clinical or laboratory data. And usually would not need an imaging. Any specific signs where you get a CT scan?
These patient, very, very sick looking patient, you are in a diagnostic dilemma and you cannot sometimes, what I clinically, classically remember is a very obese patient landing up in the emergency with incarcerated hernia. So my resident calls me up in the evening. He said, as a patient, hey, tachycardia hai, I'm starting with dopamine and other things, but I think the patient is stable. So somehow I had this inclination, obese lady, I should go myself. It was a Sunday evening. I landed up in the emergency. I found the abdominal wall absolutely cold. Patient cold clammy in shock. Very, very fat patient, lady, post nephrotomy and trauma 10 years.
Yes, so that is the first indication that where you cannot.
When you cannot say that it is strangulation to
Yes.
find out some other cause, then CT can be.
Yes, yes.
So,
And in a obese patient where
so
you cannot.
immediate CT done showed absolutely no flow to the bowel wall. So we had to take her up that night. Otherwise, it was early morning surgery.
Yes, so
We were able to
basically,
save the patient.
yes. No, not ruling, but they might indicate strangulation, sir. Not ruling out.
Lactate, sir. perhaps.
Lactate, D dimer, and CPK, there have been some studies have shown that they might rule out. Sir. Okay,
So
so
they would
these
only
are the.
indicate, they would not,
Pardon?
they would not diagnose, they would only.
They will not diagnose. They are just an indicator, sir. It's mainly signs and symptoms supported by these clinical.
PM and leukocytosis,
Yes, yes,
tachycardia,
yes.
pain, and all these
Yes,
skin
sir.
signs, obstipation, distension, vomiting, all these things.
Yes, yes. Sir. So CT is only where the diagnosis is in doubt,
Yeah.
or you think that you never know that the symptoms are only because of hernia, or you are suspecting some other pathology also. So don't doubt those things. So these are the some intraoperative pictures. Would you like to comment that, Dr. Sanjay?
The intraoperative picture of the second one looks like a doubtful, it is dusky, but it needs observation.
Yes.
The second one. The third one is quite obvious, it is.
Yes, yes. That needs a section.
White, gray, and black.
Yes. So the first and second, they improved after some time. The third one required a section. So will you place mesh out of these three?
The first one I might, the second and third I will not.
Dr. Josna? Anything related to the wound class?
I think putting in a mesh or not is a debatable, and people will have opinions either way. If there is, I would rather not put a mesh. If
Which
it is a
class of wound?
contaminant, the third one definitely not. If there is contaminated fluid there.
Dr. Subhash?
In first, I will. In second, if there is a fluid, when I open the sac, I will not. And third, obviously, I will not put.
Third, four, big no-no. First, you may consider. Second is doubtful, but more than important than fluid is the color of that fluid. If it is little dusky or you see it is turbulent, then big no.
Even if it is not dusky, microscopic, these organisms which are there, fluid may appear clear, but there are transmigration of bacteria. So I'll be always doubtful if there is a fluid.
Okay. Is bowel resection a contraindication to mesh? What's your
See,
opinion?
if I'm opening the bowel and there is some sort of spillage, then no mesh. No mesh from my side. Absolutely.
Any other different opinion from the I know that because this is a debatable issue.
I said debatable. No, this.
Mike?
Ramana might have different opinion.
No, because the
before
evidence
we say
is different.
No, the evidence is altogether different, but you ask whether you will put, I will not put. The evidence is in favor of mine.
Septic patient, no mesh.
That is
The thing is,
It's like, sir, having trust and faith. एक आदमी रस्सी पे चल के जाता है अपने बच्चे को कंधे पे लेकर के दूसरी तरफ जाके ताली बजाता है, then he asks कि would you believe, do you have faith that I can do it again? Everybody said yes and clapped. तो उन्होंने कहा आप अपना बच्चा मेरे कंधे पे रख दो, then I'll cross. Nobody agreed to that. So there is a difference between faith and trust. So for my, if I am getting operated, I'll say no beforehand.
Yes. Right.
Anyhow, to bring some science or evidence to this discussion, bowel resection per se is not a contraindication for mesh, but the perspective has to be that without a mesh, your chance of a recurrence approaches probably 50% or even more, depending on what kind of patient and what kind of hernia we are talking about. And with a mesh, say a lightweight or macroporous synthetic mesh or a biological mesh in the US,
That I was coming next.
the chance of that recurrence would probably be in the region of 20% to 30% or even fewer. So as such, it is now well demonstrated to be safe and has decent results. We cannot expect miracles. So I would say it's not, medico-legally, this would be an important issue. If somebody has an infection and then an explant and somebody puts a charge of negligence, I would say this is very defensible. Somebody puts a mesh in a bowel resection in an obstructed hernia, yes, we can definitely defend that person.
But if you see the latest guidelines of hernia surge and WSCS, so they recommend class 2, you can place a mesh. And there are a lot of studies on that. Even the NSA KOP data, there's a large database. So they've shown that the results.
There's a big Egyptian study also which states that it is quite, it's not that complicated and that much infection, it's not there seen in their studies.
I think with the raise of hands, I would like to ask each one of you who would
Yes,
put
I
a
think
mesh
it's a
in
debatable issue,
infected
yes.
fluid.
Yes.
Forget
Class
about
two
what
would.
is in the evidence, but
Yes.
actually, if the patient comes to you, how many of you will put a mesh? Please raise your hands. So what is this evidence-based medicine? Sometimes I wonder.
Evidence are created, sir.
If the evidence is
cannot
clear.
be just because you do it.
No,
then it
no, that's
becomes
why
Rama-
I'm asking
Ra-
everybody. That's why I'm asking everybody.
Minority of
Question
There should have been at least one hand raised.
The next question would be,
Why there is not a single hand raised?
let him ask. Yes,
I want to make a point here. The evidence says that if you put a biosynthetic mesh or a synthetic mesh in an infected field, a class 2 wound also, then the infection rates are equal to what they would have been without a mesh.
Yes.
They are not equal to an elective repair.
That is true.
So you are exposing the patient to an extra risk of infection, and that consent should be taken beforehand to avoid litigation later on. That is my point. I'm sorry to.
Okay. So which mesh will you prefer?
When I will not put, there is no question of which mesh.
I think biological class, for class 3.
Look.
So as
Role of
far-
laparoscopy. Okay, next question.
As far as biological mesh is concerned, I think most of our experience is theoretical.
Yes, theoretical. So role of laparoscopy.
So
Pramod, I will go for laparoscopy.
In the era of physics mesh, how about physics is what I would like to ask.
Okay. Sorry.
No, he wants to ask
So as far as physics is
Well,
concerned.
he's asking.
For people who are saying they may not put a mesh, I have a doubt. So if you're doing a complex hernia repair, and by mistake, if you do an intraotomy, which happens quite often, would you decide not to put a mesh because it's unsafe?
If there is no spillage, I would go ahead with, because we normally prepare the bowel also when we have a planned surgery.
If it is a
And if there is no
Does
spillage,
everybody prepare the bowel before a complex hernia?
No. There is. If it is a clean contaminated case, it's controlled only. Then you can place a mesh.
So in that particular case, when you resect, I'm sure all of us are good surgeons that you're not going to spill. So does that not make mesh a logical choice?
There is
There's a
infected
50%
fluid also.
That is what we are discussing.
there is infected fluid
There is
also
an
in such
infected fluid
cases.
and
It's not
gangrenous
just
bowel.
pure contamination by
It's not
resecting.
only elective resection.
Infected fluid there.
So yes, so coming back, I think Sir was telling the color of the fluid matters. So again, so there can be either a transudate or an exudate. An exudate is likely to be infective. A transudate is likely to be non-infective. So if there is a transudate, so would you go for a mesh? If it's just a transudate, there is no spillage, would you go for a mesh? Because evidence also says that mesh is safer because you don't want another hernia in this particular patient.
So you're working on a patient who's emergency, or we are obviously talking about emergency surgery. It's hardly a setting for you to decide whether it's a transudate or exudate. I mean, are you going to wait for the lab reports before you take a call?
So basically, it's an individual decision. For class 1, there is good evidence. You should place a mesh. For class 2, debatable, but evidence still supports the use of mesh. For class 3, the role of biological. Class 4, dirty wounds, no mesh. That is evidence based.
Even for
rest
physics,
is eminence based. Sir, it all depends on where you are working. I know. It depends on where you are working. And
See, that's why nobody raised a hand, because of your own experience.
चोपड़ा साहब आपने हम और लगा दी होती
so role of laparoscopy, I think we have limited questions. Sir.
So I would definitely use laparoscopy as a diagnostic tool. That means if I have any doubt, I would definitely put in a laparoscope and see.
So one is diagnostic laparoscopy, the other is laparoscopic repair.
Yeah. So
do you prefer TEP, TAPP in
an
emergency
setting?
Yes.
No, I would not. I mean, if I'm not putting a mesh, that question doesn't arise.
Any panelist with a different opinion?
TAPP is definitely better. People are doing TEP also, but TAPP is definitely recommended, and it can.
Setting, I think so.
No,
TAPP
TAPP
I
is
think one
the.
person at a time. Pardon? Yes, I know, but they're
Incarcerated.
We have to listen to them.
Incarcerated. Incarcerated hernia.
Incarcerated, basically emergency hernia.
Emergency hernia.
It's only emergency hernia. Will you use TEP or TAPP?
Only TAPP.
TAPP.
Definitely not TEP.
So initially it was thought that maybe TAPP is better, but now people
now
say
there
the
is
ball is
evidence.
dilated, it's difficult to do. So going in a better print, probably the chances of infection are less. There are some studies which have recently shown.
But in case we have to judge the color of the bowel or
So they do a diagnostic laparoscopy and then use a
so
TEP.
we are already in the TAPP.
Okay, role of antimicrobials. Dr.
Definitely.
Subhash.
It is.
It is.
It is.
Okay.
I think we should talk about abdominal or ventral hernia also strangulated. Not
It's
only-
coming, sir.
Yeah.
It's coming, sir. So this is an incisional hernia, bowel gangrene requiring resection. So what will be the next surgery? Will you place a mesh? It will require bowel resection.
Peritoneal flap. No foreign material.
Exactly.
If you are not an AWS surgeon.
Peritoneal flap, of course, if it falls short still, then of course VAC.
In this kind of a patient, I definitely wouldn't think of putting a mesh.
Yes.
Resect anastomos if the patient is very sick, stroma, get out of the
So this is what
situation.
we did, yes.
And perhaps just get fascia together. That's it. Leave the skin open.
The same thing we did, anatomical closure and this. So another hernia, I think this part has been covered in the last talk. Incisional hernia gangrene involving the bowel loops, loss of domain, and patient is unstable. So I think we know the answer. This is open abdomen. It's a clear-cut case for that. Okay, so aim is basically correct the life-threatening problem first and then attempt the safest and most durable hernia repair possible. So this is, I think all of us must have encountered this scenario. So cirrhotics, there are 20% chances of umbilical hernia. With ascites, there are around 40% chances. So this patient coming to emergency with the ulcerated umbilical hernia and ascites coming out. We call it as a flood syndrome. Dr. Sanjay?
So I would obviously try and stabilize the patient as far as possible. And if I have to go in and do the hernia, I would only do a suture repair.
And control the ascites with medical management so that the pressure is less on those suture lines.
And, at the time of surgery also, we have to take out the fluid because that might have got infected also. So even ascitic fluid is taken out along with it and do the open repair.
Open repair under block.
Okay.
Tap
So
lock.
try, yes.
No spinal, no general anesthesia, just tap lock and surgery.
Okay. So basically try to do it under, pardon? Yes, yes, that is what I've shown, sir. Try to do it under local or regional unless there is ball gangrene, PCD to drain ascites, and always include hepatology.
Sir, we've been very comfortable doing surgery under tap lock with minimal sedation to the patient.
Why?
Any kind of
Why?
regional block.
Why?
Ma'am, if we give general anesthesia, you have hepatotoxic drugs going in and causing decompensation to the
Why
patient.
not regional?
Regional, matlab ki, spinal anesthesia, again, you'll have hypotension and other problems.
No, but
No, if patient is stable, what's the problem in, rather we are more comfortable
in. To
in.
do it local or regional.
Yeah.
What is safer for the patient?
So one more thing is ki your anesthetist is usually not comfortable operating
Depends on
these
the anesthetist.
patients
Yes,
with
because of low
spinal,
platelet
because of
count and
coagulopathy and other things. So plasmas and everything. So local and blocks have been a preferred method in our institute.
Okay. So another debatable question: prophylactic hernia repair, elderly cirrhotic and incisional hernias. What's your opinion?
छोड़ दो
One by one of all.
छोड़ दीजिए
Dr. Sanjay, please
Cirrhotic,
start.
definitely not. Elderly depends on the kind of hernia, probably watchful waiting is what I would do.
I think unless the patient is really fit, the elderly person especially, and the one who is cirrhotic, unless it's if it is not bothering, I would leave them alone.
Same. I will leave them alone.
Cirrhotics do not touch.
Amandeep,
Let
can
the
you explain the
gastroenterologist
question? I didn't understand the
We
question.
just want to say the patient has a hernia, asymptomatic.
Which cirrhotic patient or any patient?
No. There are different scenarios. Will you do a prophylactic hernia repair or wait and watch? Asymptomatic. Asymptomatic cirrhotic patient with a hernia.
Empaneled patient, some CGHS or something like that, without any symptoms, either cirrhotic or elderly.
I think that is the comment of the day.
This is being recorded and placed on YouTube. So anything evidence-based, Dr. Ramana, evidence-based, asymptomatic hernia in cirrhotic, elderly, or any kind of thing.
I'm not aware of any evidence to this. I'm not aware.
Well, cirrhotics with umbilical hernia should undergo prophylactic repair unless they are waiting for a liver transplant. If they are waiting for a liver transplant, then that hernia should be repaired during the liver transplant is what the guidelines say.
Any other different opinion of the?
I would not operate on a cirrhotic.
Asymptomatic, I will not.
And the reason why they should be operated on a cirrhotic because ultimately later on they might present with an emergency ascites
Because
where the
yes,
mortality is
the chances are very high. So evidence support the repair of even an asymptomatic patient.
You should do it.
Because chances of strangulation are very high, and in elderly, maybe more than 70. So anything, yes, definitely optimize. Yes. It's only optimization and then doing it electively rather than in an emergency. In elderly, more than 70.
Before they become severely ill.
When you're talking about cirrhotic, obviously you're not talking about a child C cirrhotic.
Yes, majority will be child C with ascites and umbilical hernia.
What is there discussing?
So in elderly, more than 70. Dr. Bhatia?
Challenges in bad types, clear types.
Yes. Child A, anybody will operate. Dr. Bhatia? In elderly patient, more than 70 asymptomatic because they have.
So you'll use a mesh. Use a mesh in those cases where they are asymptomatic.
Majority do it's umbilical hernia that just do an anatomical procedure.
It will not stay with the ascites. I wouldn't agree with that. Unless you back it up with mesh, it will not stay. The pressure of the ascites fluid will not allow it to heal well. Because whatever the management of medical management, there is still going to be ascites.
Operate electively if there is an ascites. So you will first dry the ascites.
Yes.
Yeah, but they will collect
So
again. They
pre-op
will
observation is a
collect
must.
again. Within days, they will.
Then you put in a mesh when you dry.
Yes,
If it is
He's saying he
refractory
will not
ascites.
put a mesh.
No. I'm not saying that. It all depends on patient to patient.
No. When you are electively operating on a patient who is asymptomatic,
If electively and patient is full.
so you'll put a mesh.
Yes.
That's fine.
You can
That's
place a mesh.
fine.
There is no
That's fine.
contraindication to push a mesh in a cirrhotic.
If he's putting a mesh, yes.
I agree.
What Pradhani said was right. The essential is the management of ascites.
Yeah.
Very
If you
important.
don't manage your ascites, you put a mesh, no mesh is going to recur for it.
If it is an
So-
infected ascites, definitely you
So
will
will you
not
put onlay? Will you put onlay or intraperitoneal?
only. It's an open repair, only mesh, anatomical
say
closure.
something? Dr. Adarsh Chaudhary is absolutely right. The guidelines say that the only contraindication in a cirrhotic will be an uncontrolled ascites. If you can't control it, then you have to first do tips or whatever. Otherwise, you can't.
Yes, we're talking about prophylactic repair only, sir, after optimization of the patient. The same in elderly more than 70. So what is your opinion?
So this is what I was getting confused about. This is not prophylactic repair. This is elective repair, not emergent.
Elective, you can say. It is the same thing, sir. No, for a asymptomatic hernia more than 70, what you usually recommend?
You were asking me about elderly. Honestly speaking, I will never reject because of the age. I will investigate the patient thoroughly. And if definitely the criteria are there, the general anesthesia or local anesthesia or spinal anesthesia, I will go ahead.
Yes.
Definitely.
So that is what the evidence says, that there, in studies which have done a wait and watch for asymptomatic hernias, they show that the crossover rates are very high, to the tune of 70% over a period of 5 years. So it's better to offer them repair rather than rejecting them.
Even for
that is what the evidence says.
even for direct inguinal hernia?
Yes, yes, for everyone, sir. It's more for femoral hernia in female, that anyway all of us know. So the evidence says we should offer them surgery.
So the question should have been symptomatic cirrhotic patient. Yes.
Cirrhosis will
asymptomatic.
Even asymptomatic. We're talking about asymptomatic.
The presence of a hernia is a symptom.
Because chances of complication in a cirrhotic are very high. So that was the question. That Dr. Suresh Vishesha said that. I'm not sure.
You don't have to say who said it.
So are there any?
So going back.
Anji Raman. Yes. Yes. Yes, yes, yes. The evidence still says that even in asymptomatic cirrhotic, you should do it.
If somebody has got a lot of varices in that area, obviously is not a candidate for surgery. If your patient is going to bleed so much, then a hematoma will form, a mesh will form. So if a patient has got caput medici and a umbilical hernia, most of us will not do it, because it will be very difficult to manage those patients. So it's a theoretical question, but if it's a caput medici, at least we won't operate, because there'll be bleeding, and the problem of bleeding in portal hypertension is that it does not stop with sutures. When a portal hypertension patient starts bleeding, the only thing you wish is that you were not born.
Or you didn't become a surgeon.
So the third is incisional hernias. So are there any indicators in incisional hernia where you will say that yes, the chances of strangulation are more?
If he has a history of recurrent obstructions, he's intermittent
Yes.
obstruction.
So that is symptomatic for asymptomatic. Sir. That is a symptomatic and anyway needs surgery.
Again, if he's fit, I think we should go ahead.
So this is an interesting article which has shown that this is the hernia angle. So the angle between the sac and the abdominal wall. So based on this, they have made this OER score. So there is this article was published in American Journal of Surgery. So based on different parameter, sac height and hernia angle. So they have shown that less than 5, the chances of getting it complicated is very less. More than 10, it's very high. It is just something which is an individual center, not of some kind of.
Depends also on the contents of the hernia. If there is intestine, you would rather operate.
Yes.
Yeah.
Perhaps a narrow neck with a lot of bowel inside.
There was an old teaching that a small neck, narrow neck with a small hernia is more likely to get
It's
strangulated.
a scientific name for same only, sir.
Yeah.
If it is a narrow neck, the angle will be less.
Yeah.
So it's a wide neck, the angle will be wide. So it's the same thing, but something objective. I think any questions from the audience to the panel?
I have a very pertinent question. We are talking about the ventral hernia repair in contaminated surgery or putting the mesh. So the most of the studies have shown, even Dr. Jignesh says in the morning told us we are micro-Rosenstein that prefer for the biological mesh. But again, a newer randomized trial by micro-Rosen study, they have said the synthetic mesh is better. So what is what the panel says about it? This is recently published in the JAMA January, the micro-Rosen team only. They have said about that the synthetic mesh is better than a biological mesh.
Which
for
mesh, sorry?
2 to 3 years recurrence rate, safety outcome is similar. So I think.
But the panel has said they will not put a mesh.
No, I'm. Just
Panel has said
for my
that.
knowledge.
Evidence says that, but the panel has said that no mesh.
No, not only the panel, everybody in the audience also. Nobody raised the hand except one. So in the audience,
didn't raise his hand.
nobody raised. No.
Because we always keep on
So biological
talking
mesh,
about- So in case if you have to put a mesh, suppose clean surgeries, I mean, you have done a, you want to put a gloss of the.
When it
you want to
depends on
put
the
a
class
mesh.
of wound. So for class 2, evidence says you can put a synthetic mesh. For class 3, you will not put a synthetic mesh. So biological are basically for class 3 wounds. So it depends on the class of wound. Okay. And any comments or questions, sir? Can you hear us? I know, but doctor?
Dr. June.
Hi.
Hi, Dr. Susan. Thanks for your talk. Can you, could you hear us during the
Yes.
panel? Do you have any comments? If you or Dr. Robert Bem are there, if you want to make any comments, would you put in a mesh in US in that kind of a setting?
So actually, Dr. Rim, so recently in our institution, we actually have a research. So you can put in synthetic mesh in class 2, and we will probably do it, and we will back it up with the negative pressure wound dressing, because it has been shown that with the wound vac, you're able to decrease the chance of infection in even class 2, and it will just provide some further reassurance, because it's definitely it's counterintuitive to put a mesh in a somewhat contaminated field with the class 2 wound classification. So what our experience is, if we believe the recurrence chance is high, we'll place it, and then we'll use a negative wound dressing on top of it for the subcutaneous to decrease the chance of seroma or any further infection or complications.
So you, in a clean contaminated, you may put an onlay mesh with a wound vac on top right away. That's
Yes.
a great point. Thanks a lot, and thank you for staying. Thanks a lot to you and Rob.
Yeah, thank you so much for the honor to present.
Thanks a lot. Bye.
Thank you, sir, and all the panelists for this session. And next up, we have a session on parastomal hernias. The first talk would be by Dr. Eric Pauly on parastomal hernias, choosing the right technique. Dr. Eric Pauly is a professor of surgery and director of endoscopic surgery at Penn State Hershey Medical Center. He is also the chief of division of minimally invasive and bariatric surgery. His areas of surgical expertise include AWR and therapeutic endoscopy. Dr. Eric Pauly.
Hey, good morning, everybody. There we go. Good morning. It's nice to see everybody so bright and early in the morning here. And it's always good to hear some familiar voices. As soon as I came on the web chat, I heard Dr. Ramana making a point. I knew I was in the right place. So I was asked this morning to spend about 20 minutes or so talking about peristomal hernias and how to choose the correct technique. I have to say this is a really in-depth topic, and what I'm going to do, I think, is maybe a little bit of a disservice by using some broad brushstrokes, but let's see what we can accomplish here in 20 minutes. I do have some disclosures. I'm not making any recommendations about mesh, which I think is probably the main thing that I'm going to say here. I'm going to spend most of the time talking about technique. So the first successful stoma was actually performed by a surgeon named Durrett on an infant who actually had imperforate anus and had a colonic obstruction. And, you know, we've had 229 years since this event, and we really still haven't figured out the best way to repair hernias around stoma sites. My objectives for today, therefore, are to talk a little bit about the algorithms, more or less, that I use when I'm thinking about managing a patient with a peristomal hernia. I want to review some technical considerations. We'll talk a little bit about the techniques that we use, and we'll talk about some novel options, including a couple complications of those more novel repair procedures. So let's just start off by defining the problem. Peristomal hernias are unfortunately quite common. Up to 50% of all ostomies will eventually develop one. And they're very technically difficult to repair. We know that they have a higher recurrence rate. We also know that they have a higher surgical site of occurrence rate, typically surgical site infections, because again, let's remember that at a minimum, these are clean contaminated cases no matter what you do, because there's a loop of bowel right in the field. If you're taking down or moving the stoma, even if you're not moving it, just suturing the fascia closed, you can have some morbidity related to the stoma. As you see here, the stoma was caught with a stitch, and there's a fistula here to the skin that goes up to the abdominal wall. So even if you're being careful and working around them, you can have problems. And we also know that many patients have concomitant midline hernias as well, which makes repairing two hernias near one another the challenge. So when I think about doing this, I typically break it down into mesh or non-mesh repairs, okay? And the primary suture repair is probably the easier side of this algorithm, because you're basically talking about, am I moving it to a new location, or am I keeping it at the same spot, okay? And it's relatively simple from that perspective. Once you move into the mesh repair algorithm, you wind up with some options. The open version is where I have to be honest, I spend most of my life. And that's true because a lot of the people that I meet have already failed some other repair. MIS repairs, from my perspective, are still a very good option. They almost all leave the ostomy in situ. And again, the preferred method for that would be a non-slit or a sugar baker technique. Before we get too far along, let's just make sure that we're all on the same page here about what I would say are probably the three most common mesh configurations. You have a keyhole repair. In a keyhole repair, the stoma is generally being left in the same location. The mucocutaneous junction is not taken down. You're cutting the mesh and you're wrapping it around the stoma, as you see here. And typically we would close the edges of the mesh back together on the side. Now, just thinking about the layers of the abdominal wall, where can you perform a keyhole operation? Well, lots of different places. You can perform it as an underlay. That's probably the most common thing that people are used to, a laparoscopic keyhole, for example. You can do this in the subcutaneous space. That would be an onlay repair. If you make an incision around the stoma, not at the mucocutaneous junction, but lateral to the stoma, you could do that operation. And then obviously you can do that in the retromuscular spaces as well. In a cruciate repair, typically an X or a slit is cut in the mesh and the stoma is delivered through it. And so that almost always means that you have taken down the mucocutaneous junction. Maybe you're moving it to a new location, maybe you're keeping it at the same spot, but you have taken it down. And again, the three planes where you can do that operation are the underlay plane, the onlay plane, and the sublay plane. So all three of the layers of the abdominal wall where we put mesh are available for that. Now, a sugar baker repair is a bit unique in that the mesh is not cut in any fashion. And as you can see in this drawing, you're essentially making a sling of mesh. When sugar baker first developed this, when lap inguinals were first being done, they looked to sugar baker's version of a surgery as the method by which they would allow cord content to sneak around the mesh. And fundamentally, that's the same concept. You've got a hole in the abdominal wall, you want to cover it, but you need other content to slip nearby. So sugar baker's configuration and preperitoneal mesh for inguinal repairs, same concept at the end of the day, okay? For many years, however, the intra-abdominal version of a sugar baker was the main way to do it. More recently, people have described retromuscular sublay repair options for this, again, in an operation that is much more like a lap inguinal repair in terms of the mesh configuration. So that's a sugar baker configuration mesh, okay? So I think when most folks talk about a sugar baker operation, what they're describing is an intraperitoneal version where the mesh looks like you see here. I like to use the term sugar baker also to describe the mesh configuration. And so I will specifically call it sugar baker configuration mesh in this talk. So open repair algorithm. Open primary repair is, I think, a great option for an older patient, a smaller hernia, somebody with an abdomen that you don't want to go into. I think it's a very good, you just finished a session on emergency operations. It's a great emergency operation. If patients have a fear of mesh or you have a fear of using mesh in that circumstance, this is a good operation. And if there are no other hernias of concern that you're responsible for dealing with. I think an open onlay mesh repair Similar concept, small to medium hernia, an abdomen where you do not want to go into, patients who aren't concerned about mesh, and again, no other hernia concerns. Your decision to make it a keyhole or make it a cruciate depends on the incision that you're using. If you're taking down the mucocutaneous junction, you're going to use a cruciate. If you're leaving that up, and if you're leaving the mucocutaneous junction up and have made an incision lateral superior to the stoma, then you're going to use a keyhole configuration. Now, the open sublay mesh repair for me is typically a cruciate or a sugar baker, and that depends entirely on how much I can lateralize the stoma. A medium to large hernia is almost always found in these patients. I know that I can get in and manage what's going on in their abdomen, even if it's challenging. It's not, it's not a no-go. Patients have to be comfortable with me using mesh. Most of these patients have some form of a concomitant hernia that also needs to be managed, okay? And again, I think for me, the biggest issue is just thinking about, is the abdomen unforgiving or is it not, okay? Let's talk about MIS repair algorithm as well. I think a lap and a robot IPUM repair is still a very good option. Typically, these are patients who have a smaller peristomal hernia with no or a very small midline component that's going to be covered with the mesh used for the sugar baker repair. And it also has to be a loop of bowel that is going to be easy enough to lateralize, because again, in a sugar baker configuration mesh, the lateralization of the bowel is really the Achilles heel. If you can't lateralize it, then you're skimping on that lateral overlap, and that's where the recurrences occur. For a retromuscular sugar baker repair, this is, again, a small to medium hernia with no midline component that's typically done as a unilateral dock on the contralateral side of the hernia. It's got to have a small to medium midline component. If you're going to do a bilateral dock, the midline component shouldn't be particularly large. Now, there are people who have done ETEP MIS retromuscular sublay sugar baker repairs. I know of a few of them having been done. I just undid one on Wednesday of this week. It took me about 14 hours to undo because there were 2 mesh fistulas and a bunch of other problems. And so what I would say is, like on the hierarchy of complexity, this is really, really complex. And I think that if you're moving to that realm, you should probably be, an expert in all of the other things that I've just described before you jump to that as your repair method. And I'll be perfectly honest, I don't do that operation. Let's talk about some of the repairs that we've now mentioned in that algorithmic approach, okay? Primary suture repair has a very high recurrence rate, 46 to 76%, 100% for recurrent hernias, and it's got a 9-fold higher recurrence rate than mesh-based repairs. But this is the first operations that were described. This is an image from a paper by Thorlaxson in 1965, and this is, as far as I can tell, the very first referenced method of peristomal hernia in the literature. So again, 1965 is where these repairs start showing up. You can see that what Thorlaxson was doing here was making a peristomal incision and leaving the mucocutaneous junction intact. These are technically simple and they avoid stoma relocation. They avoid mesh, again, a relatively low morbidity. What I like to do when I'm doing this operation is look at the CT scan and figure out where is the hernia content in relation to the loop of bowel that's going to be the stoma. Is it above? Is it below? Is it to the right? Is it to the left? And then I make my incision at that location. So here is a picture of Thorlaxson making an incision medial because he believed that that's where the hernia sac was going to be. They've opened the sac, they've reduced the content, they're closing the fascia. Again, I'll close these in whatever direction appears to be the least amount of tension. So that could include craniocaudal, it could include right and left lateral. There are obviously other versions of this surgery, and I mentioned that you can do this as a keyhole repair with onlay mesh. So same incision. Here you see a skin flap has been raised around the level of the stoma. A piece of mesh is wrapped around. It is secured to the fascia, however you like to secure mesh to fascia. Typically, a drain is left in place in the large subcutaneous pocket that's been created, and you close the skin nearby. Now, the other sort of easy open operation is to just relocate the stoma. And again, that typically would be a midline laparotomy with a takedown of the mucocutaneous junction, and then moving the stoma to a new location. Again, it's technically very simple to do, but again, it's got a high recurrence rate, not only at the old ostomy site, because that was a primary closure site, but also at the new ostomy site as well. And it does require a laparotomy, and you've got essentially 3 wounds to deal with. But again, it's a very nice get out of Dodge in the middle of the night operation. It does result in things like this, though, as I said. Now you've got old hernia sites and new hernia sites, and now you've got a more challenging thing to fix down the road, but maybe it's not an emergency at that point. Let's talk about mesh-based repairs. This is a paper by Reiger from colorectal disease in 2004, and it's not like the world's best study, but I really do like this study because they looked at 51 consecutive peristomal hernia repair patients, and they just looked at what they had. About a third were primary repair, a third kind of local repair with mesh, and a third included moving the stoma to a new site and closing the old site with mesh. And overall, they had a 38% recurrence rate. But if you break it down, the primary repair, about 60%, local repair, about 40%, stoma relocated with mesh, 25%. So what that tells me is repairs that use mesh have a lower recurrence rate than primary repairs. And if you're moving the stoma to a new location and are starting over, yeah, you got a high chance of getting a hernia at that new site, but you've really reset the shot clock back to 0, and you've given yourself some new time for that new hernia to start developing, okay? So where did mesh-based repairs start? Here's the first paper, 1977, Rosen and Bernardi. They had 7 patients with prior APRs. Here's a picture from that with the grotesque appearance of a pericolostomy hernia. They took a big skin paddle around the stoma site to remove redundant skin. So they're taking down the mucocutaneous junction here. They closed the peritoneum as its own layer. They closed the fascia with some permanent suture. They removed the redundant colon by doing a bowel resection. And then they used a piece of Marlex mesh. Now, back then, Marlex was not polypropylene, it was polyethylene. The companies have changed what Marlex has been made of over the course of time. So they used a polyethylene mesh. They secured it to the fascia with suture. You can see they made a hole in the mesh and delivered it through. Secured it to the fascia, placed a drain. Again, even back then, at the very first time doing this, they said you have to make sure that the aperture is not so tight that it doesn't impair the blood supply to the new stoma. So even at the very beginning of people doing this, they're thinking about, what is the right way to keep the blood supply intact. They left a hemovac drain, kept the patient on some antibiotics, and they had pretty good success. So much success that in the very first mesh-based peristomal hernia paper, they suggested the use of Marlex mesh with the construction of the initial colostomy to prevent future herniation. So there you see peristomal hernia prophylaxis being suggested in 1977 in the very first paper on mesh-based repairs. All right. Let's talk about laparoscopic approach. Again, I don't use this a lot, mostly because most people that I meet are not candidates for it. And I have a lot of partners who are very good laparoscopic and robot surgeons, and they manage these patients, and I get them when they're a little more challenging. Typically you want to reduce the peristomal content. It can be easy, it can be hard. Here you see a really easy one. This is me with my fellow doing a case a couple of years ago. I'm saying, pull right there. That's the adhesion. And that's the entire adhesiolysis for this acutely herniated peristomal content. You can see this is a sugar baker repair with a double crown. At that time, which was many years ago, I was still using EPTFE for the repairs. And I think there's a lot of people who still do that, okay? This is a modification of what Sugar Baker originally described. And this paper first came onto the literature in 2000 by Voigt. And what they describe is exactly what you see here, a mesh with lateralization of the colon. You can see they put tacks circumferentially. They put tacks along the edge of the bowel. So tacks along the edge of the bowel here to help keep that tunnel configuration. And they also used sutures to keep the colon from sliding through the tunnel as well. So some things that we may or may not do currently. Let's end the talk here on open retromuscular repairs. The first open retromuscular peristomal hernia repair that I can find in the literature came from Alexander and Billiot in 1993. And what they described was an open takedown of the ostomy. and subsequently the development of a retromuscular pocket. Now they went retrorectus, that's pretty clear. And then based on the drawings in their paper, not so much the words in the manuscript, it appears that they were dissecting between the transversus abdominis and the internal oblique. So they were doing a Carbonell style posterior component separation, okay? They used a 20 by 20 piece of Dacron mesh. As you can see from the picture, they created a trephine in the mesh, a straight up hole, and they delivered the bowel through that at a new ostomy location. What this allowed them to do was to close the old hernia site with mesh very widely, and also to reinforce the new site with mesh from the very beginning. So a little bit of hernia prophylaxis going on there. Now, when they had a hernia that needed to be transposed to the contralateral side, or if they had a midline hernia, they would also do contralateral retrorectus dissection. And so here you see a bilateral retrorectus with the unilateral posterior component separation between the oblique and the transversus with wide mesh overlap. So the very beginnings of these retromuscular hernia repair operations, okay? I would say the modern version of an open retromuscular repair was put on the field by Rosen and Nowitzki when they worked together at Case Western. And again, just to go through some of the steps of that, it's a standard open, retromuscular TAR. They would take down the ostomy site, and so you're going to have a peristomal defect in the posterior sheath, and that's okay. That's easy enough to close. You just you struggle a little bit to make sure that doesn't become sort of super massive as you work. Then you do a TAR around the old ostomy site. When you complete that, you close the midline back together as you do in any TAR. You close the old ostomy site defect as you would with any other hole in the posterior sheath. Then comes the hard part of the operation. You have to find a new location for the stoma to go. And we would almost always transpose that to the contralateral side. So you have to make a defect in the posterior sheath and deliver the bowel. You then place some mesh into the wound, and you have to make a trephine in the mesh to deliver it. Then you've got to make a hole in the skin, the subcutaneous tissues, the anterior fascia, and the muscle, and deliver the bowel through. And what that repair should look like is something like this. Again, transfascial sutures being used here. I no longer use those. This is from the original sort of publications on the topic. But the old site is well supported with mesh. Any midline hernia is reinforced with mesh, and the new site is primarily reinforced from the get-go. But there are a few problems with it, and those problems are easy to see here in cross-section. Number one, lining up the posterior sheath, the mesh, the muscle, the fascia, and the skin, and keeping these in a perfectly straight line without any zigzagging or shifting in the subcutaneous space is very challenging. And if you have shifting, especially against the mesh, you have a point of tension, and that tension can lead to a very local mesh erosion relatively quickly. Kinking in that region can also lead to a bowel obstruction in the early postoperative period. The second issue is that you have cut the mesh. And so we know that, anytime you make a hole in the mesh, you've got a higher rate of recurrence. And this hole in the mesh is oftentimes within just a few centimeters of your midline repair. So you've compromised both the peristomal repair and the midline repair by doing this. But what I will say is that it has a very acceptable risk of recurrence. In that paper, which was published under Regani by the first author, they had an 11% recurrence at like 2 years, okay? My personal experience is over time, it goes up. I had about a 10 to 12% recurrence rate in the first couple of years, and then slowly these folks start to come back with some recurrences. Why is the risk so low, though? Again, you're relocating and reinforcing from the very beginning, and you're widely using mesh. But the downsides, you've got to take down the stoma. You're dealing with multiple wounds. You're transecting and have to mobilize bowel, and the mesh is cut. And as I said, those hernias reoccur at the new stoma site. So you get a new peristomal hernia. And that's where our concept of a polyperistomal hernia repair came about. And again, this is nothing really novel. Okay, everything old is new again. This is just a TAR and a sugar baker configuration mesh put together. That's essentially a retromuscular sugar baker repair, and that's kind of how I describe it. But it has those advantages that we like in a retromuscular repair. The mesh isn't cut, the stoma is not moved. But it is very hard to perform and configure correctly. You've got to do your retrorectus dissection and leave the stoma in situ. You've got to perform a TAR and not injure the neurovascular bundles, as you see us working around here, and not injure the ostomy site, which is obviously the most important part because you're going to get a leak or a fistula post-op. But you then develop a very wide retromuscular pocket. You then have to cut that retromuscular pocket, and this allows you to essentially lateralize the loop of bowel that becomes the stoma into the retroperitoneum. So you are retroperitonealizing a loop of bowel. You close the posterior layer from lateral to medial. That gives you, again, that mesh overlap in an uncut fashion. You complete the contralateral dissection so that you have a landing zone for the mesh. And then you fill that space with a large piece of mesh. And again, your mesh choice is up to you. Put in there whatever you feel comfortable putting in there. Oftentimes nowadays, I just use a reduced weight macroporous mesh. We try to get very, very wide overlap. And what that repair looks like in cross section is, again, it's a sugar baker configuration mesh, but the mesh is just in the sublay space. In this cross section, actually, this is probably the better way to view it. Old site closed, stoma not moved, so no old site, midline widely reinforced. I no longer use the transfascial sutures. I've removed those from this repair. Now, you can do this repair robotically as a unilateral dock or a bilateral dock. Again, the steps are the same steps I just showed you open. You're just moving them to a robotic platform. So I won't go into great detail other than to say that taking down the posterior sheath and doing the TAR around a stoma in situ with a 3-port configuration can be challenging. An assistant port to help wrangle and move that ostomy out of the way is a very helpful thing. So please add that extra port if you need it. Similarly, lateralizing the bowel, it has to be a loop of bowel that wants to lateralize pretty easy in a minimally invasive platform. And oftentimes you'll see surgeons who do this suturing the bowel to the abdominal wall to help keep it lateralized, because when the abdomen is widely inflated, you're taking some of the lateralization distance for the insufflation. And so doing it at a reduced pressure allows you to kind of push that bowel out lateral. But the same maneuvers, cut the posterior sheath, move the bowel lateral, close the posterior sheath, and then place some mesh. This is a video. I think this is a video that I did with Jeff Blatnick. This is probably him doing the surgery because it looks pretty slick. So it's definitely not me. But you can see the amount of overlap that you're getting on that ostomy. There's at least 5 centimeters of overlap there along the stoma site. What that repair looks like when you're done is this patient here. You can see the large multiply recurrent peristomal hernia in A. And in B, you can see the colon sneaking into the posterior sheath there where the arrow is. It's in the retromuscular space and then heads up to the stoma. I will say, however, that there are a lot of complications of this repair. This is that same patient who still has a well sugar bakered loop of bowel. Unfortunately, he fractured his mesh in the midline. This is the patient that I just fixed this week. She had the ETEP version of the surgery, and you can see some air there coming to the midline. She has 2, I found out now, I thought it was 1, but it was actually 2 mesh fistula related to bowel injuries during the initial surgery. And as you can also see, she has an immediate recurrent peristomal hernia from lack of mesh overlap. This is from the publication from the Cleveland Clinic group showing a patient who had their mesh erode into their mesentery and a dead ostomy on presentation. So I'm just going to conclude by saying that peristomal hernia repair is challenging. And while we have lots of options in our armamentarium, we don't really know what the best repair is for any particular patient at any one time. We know even less about the long-term risks of these repairs and recurrences. And while we have a lot of novel options that address some of the problems of earlier versions of the surgery, we now have new and very novel complications that need to be managed. And again, as a person who sees a lot of these complications in patients, I promise you that as the complexity of the repair goes up, the complexity of these complications goes up. And undoing that polyperistomal hernia repair this week was a beast. So if you're gonna do that operation, you got to be prepared to manage the complications of it. Looking forward to the panel discussion in a few minutes. If you guys have any questions or things that I didn't get to, please feel free to reach out to me and let me know how I can be of assistance. Thanks, guys.
and gastric diseases. And he has multiple international and national publications to his credit. He's also a console-trained robotic surgeon. Yes, sir, hand over to you now. Thank you.
So I think Dr. Eric, I didn't know whether he made my job easier or difficult because I think he released all the questions to my panelists. So I will, okay, I know that. So I will just invite my panelists, Dr. Parveen, Dr. Sudhir Kallan, and Dr. Ramanna, please be on the stage. So, okay, let me start the module of my discussion of panel today is I am the moderator and I have esteemed panelists. You don't need any introduction. You are too good. And all my audiences, all of you are very nice. Stay back for your time when you can ask questions or any answers you want to give. Thank you. Was it very turbulent? No, thank you. Okay. So I will start with the fact that we are talking about parastomal hernia. I will start with the statement that it is an inevitable consequence of an endostoma. I hope everybody agrees. And if you talk to me, this is most relevant to all of us GI surgeons. And actually, we have a lot of fear when we are trying to do an endostoma following APR. Dr. Aman, who is my colleague, who is one of the highest volume kind of colorectal surgeon, he do almost 3 to 4 APRs every month. And every time we think how best we can prevent such hernias. So as we know, that is almost inevitable to have no hernias in this kind of endostomas. And if you follow someone more than 2 years, almost 50% of them have a recurrence or a hernia in this endostoma. And the problem is more worrisome that even if you repair it, the chances of recurrence are very high. Dr. Eric has shown that ranges from 10 to 60%, and this is not easy. Imagine a patient who is requiring endostoma and you're telling that you're going to have a recurrence in 2 years, and then I repair you, or you're going to have a recurrence in another 2 years. So you're treating a disease or you're creating one. So this is what the problem is with this. I will come to Dr. Sudhir. This is the situation you see. You know, there is a problem where you can see the picture like this here. The bag is
I think the topic before this with discussion was there that whether incidental or asymptomatic hernia should be repaired, and now there
consider tissue repair. Why this question is still relevant to GI surgeon is that we have seen mesh eroding into bowel and bigger problems. So Dr. Ramana, my question, our perspective, Indian perspective, we have already seen one thing that we commonly, Eric Polai said that though he do open, one of his colleague do robotic, one of his colleague do kind of laparoscopy repair. So what is your opinion about what is the best approach? And will you use mesh? Are you scared of mesh eroding into the colon or something like that?
Intraperitoneal mesh can lead to bowel erosion. We know that from a long history of IPOMs. So this was actually one of the things I was thinking of asking Eric, that there are still many surgeons who would do a laparoscopic sugar baker for a smallish parastomal hernias. But those may be the same surgeons who would do a robotic tap or an ETAP or some other procedure and not do IPOMs, because IPOMs are not favored by many surgeons in the US. But when it comes to a parastomal hernia, they may be doing an laparoscopic sugar baker, which is basically an IPOM. So the point is that just like in IPOM, there are ways to reduce the chance of complications. The same is true in case of parastomal hernias and sugar baker operations. The important area where the chance of erosion is highest would be at the edge of the mesh, which is fixed to the abdominal wall. So that kind of becomes fixed and rigid. And when it starts contracting, then it may erode into the bowel. So keeping it relatively loose is probably one way of minimizing the chance of erosion. But yes, you can use mesh. And if you don't use mesh, the patient would pretty much be a very elderly, sick patient, and you're just doing it for the time being, basically to obviate
so to have
an
more
emergency.
clarity, I want to, for the sake of audience, we prefer laparoscopy or open?
Again, depends on the patient. More or less, if the patient doesn't have a hostile abdomen, I would go laparoscopy.
So would you say that is patient-based or your technical preference because your familiarity to the technique matters or the technique itself?
As I said this morning, the triangle of outcomes, patient, surgeon, hernia, all three have to be considered together.
So what is kind of best repair result comes from like choosing correct patient and what you're familiar with. And of course, we know there is a problem of mesh, but yes, without mesh, you're almost going to fail as high as 50 to 60%. You are going to fail without mesh. So you need a mesh. Different places already been discussed. I'm not going to repeat. So I will just go into certain guidelines, which is published in 2017. I think actually that guideline of European Hernia Society published in 2017 hernia has made our job as a parastomal hernia repair very easy. They say that there is insufficient evidence to support optimal technique. So it is better you define your technique, repeat it, become master of it, do better results with that. Second is regarding what is laparoscopic repair. There are two ways, keyhole and sugar backer, already discussed. Then it is just said that even if it is best technique is when you repair is without a hole, means a sugar backer, but technically it is not that easy. Regarding laparoscopy versus open, again, there is no evidence to favor one technique over another. So it is your preference. How good you are at the technique matters. So regarding the ideal mesh of a parastomal hernia, I will come to Dr. Praveen Bhatia. Sir, we have options, which is in front of you in the screen. So would you like to tell our audience, our colleagues, what is the best option? And which mesh you would prefer and what is the ideal one?
I would say that polypropylene mesh, no. Intra-abdominal, no. EPTFE, yes, there was an era when it was being used, but lot of challenges, lot of complications were there and they have been reported. So again, no. Now the question is whether we are using the dual mesh vis-a-vis bulk mesh. There are situations, as Dr. Aman was also pointing out, CDC guidelines. So what of infected environment is there or not? If it is an infected environment, then we
Okay, can I just add here, sir? Sorry,
Sure.
this is not my thing. I don't interrupt. Like if you are doing a parastomal hernia repair, you are far from a clean wound. You are best clean contaminated, or in the most of the time contaminated wound possibly. Hope the panelists agree. So please, sir.
Sure, sure. The answer is basically yes, biological meshes have been used, but they have their challenges also because they are remodeling. The bulge may persist later on. The discharge is also there. So one can go in for dual meshes, but the most important caveat for this is that one has to know the technique well, that whether we are exposing the intestines towards the polypropylene side or we are exposing it towards the other side, which is covered kind of mesh. So one has to be very, very cautious about it.
Okay, fine. I will just sum up this discussion with a guideline on the perspective of the guideline, that it is said in that guideline that, and I think it is very understandable, that is insufficient evidence on the most effective mesh material that should be used for PSH repair. Regarding, there is no evidence to support biological mesh over synthetic mesh. Every word matters for information here. No recommendation on specific mesh material. Biological mesh are associated with higher recurrence. So you need to be kind of careful because you're putting a lot of money in this. Then synthetic uncoated mesh, which is against what Dr. Parveen just said, that may be not suitable for intraperitoneal, but only, of course, it is useful. But if you look at the overall qualitative evidence to support any of the statement, it is not great. So this is what we do. As I said, that it is what you are comfortable with. We initially did a lot of parastomal hernia repair laparoscopically. Unfortunately, we failed. Maybe we were not good at that. We moved toward open technique. So what we do is first, before draping, and what we do is we put a purse string around the stoma and close it so that there is no fecal spillage. Then we do painting and draping. 3 main steps is close the trephine with interrupted proline suture. Then what we do, onlay mesh, we always use the part of the sac which cover it from, you can see here. So it is just, we cover the sac with the trephine of the mesh so that the mesh is not in contact with the colostomy, and that possibly may prevent chances of mesh erosion. And then we close the wound with suction drain. This is before and after. How does it look? And this is one of the urostomy. So I will just, for the sake of information, when you are doing a repair of end colostomy, you have bowel, maybe you can go easy on it. But once you are doing a repair of urostomy, parastomal hernia, you don't have much bowel. Be very certain that you are not injuring anything, because at the end of it, you have a small segment and the ureters are attached. So with that, we know that end stoma is unavoidable and parastomal hernia is inevitable. I think there is no denial on this. So let's talk about certain preventive strategy. Today, unfortunately, Dr. Arvind Prasad is not with us due to some personal reason. So I have 2 questions. So I will be open to my panelists. Any of you can pick up how to prevent it. Let's talk about little preventive strategy. Although most of the time, Dr. Eric has talked about prophylactic mesh. So what is your opinion about prophylactic mesh?
I think if one addresses this on a very general, practical level, I would say something completely different. If you look at the Western literature, the talk on preventing parastomal hernias is mostly about prophylactic mesh, whether you place it in the onlay plane or whether you place it in the retromuscular plane. That's the level of discussion. But what I would say for our country is that surgeons need to know how to do a proper stoma in the first place. I have seen colostomies going through the linea semilunaris, going through the obliques, going through the midline linea alba in the center of the wound, going through the umbilicus.
So can I interrupt here? Are you just reinforcing the statement that the surgeon has gone home and resident is still sleeping or something? Class is late in the morning.
Well, the important thing is parastomal hernia is worse in certain situations. So we should start with teaching and learning the proper technique first, and then we take we escalate the level of discussion to the prophylactic mesh.
Yeah. Dr. Parveen Sarab, you want to make any comment?
Yeah, I would say that again, it is plus minus minus plus, but we are not at all in favor still, according to evidence also, of placing the prophylactic mesh in every
Okay.
case. No.
Okay, Dr. Sudhir, you want to add anything?
You see, if you just review the literature, of course, as is rightly said, for any hernia, the outcomes depend on only one thing, and that is the surgeon. Now, how well he does the hernia repair. That is, of course, important. How you do the ostomy. The other important thing is that evidence now is available, which says that there is a definite role of prophylactic mesh, and this is evidence based.
Okay.
There is
So,
almost a
yeah.
grade C recommendation.
Yeah. With that, I would just go into the
And
concluding-
one thing
yeah.
I think we have not discussed, Eric also did not discuss, and we have also not included, is the role of the
I have
newer
not over
mesh
yet. I have not
physics.
completed.
Okay.
I have not completed, yeah. So, okay, we can talk if I forget it, you can just
Yes.
take that part on discussion. So let's talk about preventive strategy. What I say that we need to have one single word slide for each. Like we have been taught that what you do is transperitoneal stoma. What has been asked to you to do a kind of a retroperitoneal or making a periperitoneal tunnel. That doesn't make any difference in terms of recurrence of parastomal hernia as per the guidelines. Now, point number 2 is it has been told to you to take the stoma trans rectus. Maybe the muscle may support, but evidence is not that strong. But yes, it is suggested maybe it is a good choice to do. But will that prevent recurrence? We do not know. About the trephine size, don't worry about measuring 2 centimeter. Most of us surgeons don't take a scale and measure, we know. But yes, don't strangulate the bowel when you're passing through it. So your surgical discretion is important here. Regarding prophylactic mesh, I will not add too much except the fact I will just go through the evidence today. If you ask me, this is the only evidence to support role of prophylactic mesh in prevention of parastomal hernia. The incidence have been reduced to 16.4. Now here, I will just stop everybody saying that there is no way you can have a 0% problem. You will have a problem. So it is better to have lesser problem, and lesser problem is easy to manage than a bigger one. So of now, prophylactic mesh is the only strategy preventable for a parastomal hernia. And overall, there is sufficient evidence to support it. I have a question related to that at the end of a session, but I have another question before I start regarding stoma relocation. So any of the panelists, please, one words.
What's the question?
What is about your opinion about stoma relocation?
I generally keep it very simple.
Yeah.
If the bag fits, then I wouldn't relocate it.
So the answer possibly is you relocate for kind of a desperate situation and recurrent stoma. One very interesting thing that Dr. Eric Polai discussed, that if you want to relocate into contralateral side, and then in European Hernia Society guidelines also it says that
There is evidence to support that. There is evidence to support that.
But you tell me one thing, it is an end colostomy after APR on the left iliac fossa. Dr. Aman is here. I will not allow you, even you are a great friend, to answer now. He knows that how difficult it is to take an end colostomy from the left iliac fossa into right iliac fossa. It is almost impossible. So we need to understand that the practicality and the practice guideline has to change, has to be understandable. So relocation is the last thing to do. And one more thing, when you relocate, like from contralateral side, then prepare the ipsilateral side with a mesh so that that area is ready in case there is a relocation needed subsequently. No, sometimes patient of C rectum, they might get lucky to survive 10 years. So we should not underestimate that. And the end, I would just say, since morning we have seen terrible pictures. This is one such thing I think we have just messed up, and it happens. And unfortunately, as a high volume GI center, we are most of the time in the receiving end managing this problem. And most of my team colleagues are here. My boss is here, he understands and he agrees. So I would just end by saying, and then I will take a question that if an end stoma is an undesirable necessity, then of course PSH is an inevitable problem. Watchful waiting depends on surgeon's discretion and patient's quality of life. Now, point number 1, the best evidence-based strategy to prevent parastomal hernia to use prophylactic mesh. Well, it can be debated how many of are comfortable doing it. One of the example of we are not comfortable doing it. We have done 4 hours of APR, and of course, then we need another 3 hours more. It increases the time as well. Regarding ideal site, ideal aperture, and extraperitoneal ways of doing the stoma is all debatable. Regarding the evidence-based strategy in treating parastomal hernia, use mesh. Rest everything is debatable. Best mesh is the one which is without hole. Now, best location, doubtful, maybe it is possibly retromuscular. Again, it is not that easy. Regarding stoma relocation, the answer is avoid. Contralateral side, I don't agree, but it should be reserved for recurrent parastomal hernia. With that, I conclude my panel discussion. I am open to take questions. We have 15 minutes from the audience.
Maybe get closing comments from Eric as well.
Yeah, of course. And then we will take questions and my panels will answer. I am not read enough to answer your questions. So please direct yourself to my panelists.
You said that which side. So when you're doing a sugar vector laparoscopy, you're going to put a barrier on the intestinal side, on the abdomen side. So your protein is right on the colon.
No. I honestly, I felt told that if you are using the dual mesh, the barrier side has to be on the peritoneal side, and one has to be very, very careful when we are putting the proline surface towards the intestine. It can cause, obviously. That is what I'm saying. That is what I'm saying. It's challenging.
Eric, don't worry, we are still awake. And if you want to answer, please go ahead.
You know, the only comment that I wanted to make was that it doesn't matter what mesh you use, because these meshes can all have problems. Okay, it's just a matter of what complication are you able to deal with and manage. I have seen every kind of mesh erode into a stoma, literally every kind. EPTFE, permanent synthetic mesh, biologic meshes. Okay. I think that Ramana made probably the most important point, which is the configuration of the mesh and the bowel are what makes the most difference. I've seen sugar baker erosions, I've seen keyhole erosions, I've seen cruciate erosions. Again, so if that's the argument that mesh can erode into bowel, we've seen mesh erode into bowel in non-peristomal repairs. Okay, it happens. I think it's important to just acknowledge and talk with the patients about the use of mesh around bowel, and then choose the mesh that you are sort of the most comfortable with. But there's no argument that one is better than another, because there's no data to support it. It's just what you're comfortable with doing. The second comment I want to make based off of those questions was just about the forming the stoma. At my center, you know, in most circumstances, patients getting an elective ostomy formation are marked by a stoma therapy team. They stand the patient up, they sit the patient down, they look for skin folds, they ask, you know, where do you wear your pants? And they mark the site that they believe to be the best site. One of the problems that I run into is that oftentimes they have marked a patient in a spot that is not through the middle of the rectus. And that's especially true if you're doing a peristomal repair and they're looking for sites to move it. I typically will use the cranial caudal location, but then I will move that site to the dead center of the rectus muscle. And so I think if the site has been marked, that's a useful rough guideline for where you should put it, but it should not be exactly where you put the stoma. You've got to make sure that it's kind of dead center in the rectus and that you're not too close to the midline and not too close to the linea semilunaris. So those are my only two comments based off of.
Dr. Eric, because of constraint of time, any more questions from the audience? Yeah, please, Dr. Punjani, go ahead. Dr. Eric, there is another question for you, Dr. Punjani, please.
Many times I've seen urostomy is done in an extraperitoneal manner where the conduit is on the obliques. So then how will you do a polyperistomal repair? The conduit is in the obliques.
Yeah, so as I think it was Ramana said, if the stoma site is functional for the patient, meaning if their bag fits, if they can pouch it easily, if they're not leaking, I'll try and leave it where it is. So I don't really care where it is, so long as it's a functional site for the patient. So the first question I would ask that patient is this site okay for you? If it is, I'm going to leave it there. If it's not, we're going to think about moving it. Now, conduits, as was mentioned earlier, are oftentimes very short, all right? And that makes moving them a challenge. One of the things that I will look at is I always look at those, the images ahead of time. Interestingly enough, when a conduit is pulled up into the abdominal wall with the peristomal hernia, you oftentimes get additional length. That bowel stretches over the course of time. And what that means is if I need to move it, mobilizing the stoma off of the subcutaneous tissue layers and off of the anterior fascia, mobilizing that entire portion allows you to pull it down back intra-abdominal and either use that length to move it to a new location, or what I typically do then is do a sugar baker configuration mesh. So you can look at the CT scan and get a sense of how much length am I going to have here before you're in the operating room. But the bottom line is, if you're out of conduit length in a urostomy, you can't do a sugar baker repair, and you may have to do a keyhole or a cruciate or some other method. So you got to have a backup plan for your initial, for your initial operation of choice.
Dr. Eric, just one question, like one of the problem as a GI surgeon we face sometimes that you have an ankylostomy and these patients take a lot of time to start functioning. There are chances of ileosis, colonic distension, and we are really actually worried with this retromuscular elective mesh placed for prophylactic repair of ankylostomy. We worry that it may erode into the bowel wall. So what are your experience in your center? How often you have seen mesh erosion in elective situation? Since you recommended that, of course, this is one of the technique.
Yeah, prophylactically, I've never seen it. I mean, listen, I certainly understand the concern. And I will say that in the US, it is not a preferred method of prophylaxis, okay? It's very big in Europe, and that's where almost all the literature comes from. Please also remember that in the US, we have a very litigious society. And so I think a lot of surgeons are concerned about putting a plastic mesh around bowel to prevent a problem that is only going to happen 50% of the time.
So I think you have already answered that we are still very scared of using that prophylactic mesh. So with us, Dr. Amanjeet Singh is with us. I would just request you to answer my last question. Since I think you are the right person for this, you do a lot of APR and colostomy. Would you consider prophylactic mesh using colostomy? Or in your opinion, you have anything to prevent that kind of thing to happen in future, please?
I think we're planning a study now. So main issue with prophylactic mesh is we are placing it. We're planning that because this is the patient that rectal cancer, and they are going in for radiation. We're planning that we will do a ETAP in these cases before starting radiation. So there will be a mesh in the left leg, and then we'll go through that mesh area and then plan. So might be that area will be more stressful than the mesh.
And about you are already tired of 4 hours of APR. Would you consider taking a prophylactic? No, I'm talking about. Yeah, I understand that strategy. That looks quite an interesting strategy in terms of research as well, in terms of clinical practice as well. Regarding prophylactic mesh use, what is your message to the audience?
We have never used it, although there is evidence for that now. But as of now, I don't think anyone of us is using that.
Did I understand what you said earlier that for an APR, you're saying that you'll do an ETEP and lay the mesh in the retrorectus plane, and then you're going to do the colostomy, the entire procedure?
So, yeah.
Oh, I see. Staged. Okay. So 2 surgeries with radiation in between. Okay.
So I think we are reaching time, and if no panel.
So 6 weeks of radiation, 6 weeks of waiting.
I still kept that question on physics.
Yeah, Dr. Kalan, you wanted to make some comment.
What is comments? Eric, can you answer this? What do you think it is feasible?
So Eric, what the question was that if I am planning an APR, I will ask to Eric. I can ask to, I think, yeah. So he is planning an APR. Before doing an APR, what he does is all of his patients require chemoradiation before surgery. So electively, he go do ETEP, place a mesh, large mesh on the left iliac fossa where future colostomy he want to construct, and then he give the patient radiation. Then after that, he underwent APR, and he bring out the colostomy through that mesh which you have placed 3 months before. So do you think that look like a scientific or attractive strategy to you?
I mean, it's an interesting concept because you've got mesh that's obviously at that point well incorporated. I don't know of anybody, doing that. Let's look at some results from it. I mean, the downside is obviously it's 2 operations to perform a procedure that could be done concomitantly. Again, I think the argument there is let's get the mesh in and get it incorporated before we start doing bowel work. Okay. And so you have to have a belief that incorporated mesh is less likely to get infected at a high enough rate that it counteracts the risk of infection when you put it in the first time. But remember that the European data suggests that these meshes do not get infected very often the first time around. So interesting concept though. I like it.
So Eric,
anyway, majority of now rectal cancer they will survive. So they will survive a 5-year survey, and after 2-3 years, almost I think 90% of them will be having a parastomach hernia. So they will anyway be doing a surgery. So doing a laparoscopic surgery just before starting radiation, I don't think that will be that much morbid for.
Will you be delaying the primary surgery?
No, definitely not.
Anyway, it will be delayed. Yeah, 3 months for radiation.
No, what I mean to say that, for example, patient lands up for surgery, then again he or she has to wait for some time for the chemo radiation to start, and then
it's
again
only 1 week, sir. For an
only 1 week.
It's only 1 week because we are actually treating the rectal part, and the mesh is going on to the abdomen.
So,
can I ask the
Dr.
question?
Kallan, please. Yeah.
Eric, I just wanted to ask you whether you have any experience of using the so-called wonder physics mesh, which the industry is promoting very well. Physics.
Yeah, I do use phasics pretty regularly for a variety of different things. And I have used it in peristomal repairs, mostly for patients who have fistulizing Crohn's and in whom either the patient or their GI provider had concerns about permanent mesh near the bowel. And so, I've used it, yes.
So I think we are just reaching our time of discussion. Any last remark, Dr. Eric, to us through your experience you want to make? 1 minute, any comment?
Again, I'll just reemphasize that peristomal repairs are very challenging.
Recommendation is yes, Eric, I'm stopping you. Sorry, there is a question from audience. So recommendation from the audience, from the evidence is yes, but yes, what I said, your personal preference, surgeon's discretions plays a lot of role. I hope I answered that question. So Eric, please, I'm sorry I interrupted you.
Eric, can I ask you one aspect? That do you think that era is going to come? You will be only para-ostomy surgeon?
Dr. Eric, you don't have to answer all the questions. Don't get worried about it. I'm still the moderator, but yes, I cannot ask no to Dr. Praveen Bhatia.
Yeah, I hope not. I wouldn't be able to handle that.
So is it a closing remark? Is it the closing remark?
Yeah, again, I would just say that these are challenging operations. You have to reoperate on people down the road and set expectations that a recurrence is kind of the natural history of this disease.
I will call him.
Are aware.
I will call him. So I think we just ending a session. Thank you very much for your time.
Thank you.
Thanks a lot. Azad, done a good job. Excellent. Photo, Ramanna.
Yes.
Thank you very much.
Thank you, Dr. Azhar, and all the panelists for a great discussion. We are coming to the last and probably one of the most important and underestimated topics for today's CME. The last panel is going to be on nutritional optimization of hernia surgery patient. It will be moderated by Dr. Adarsh Chaudhary, and I'd like to invite all the panelists on the dais, Dr. Deepak Govil, Dr. Sarfaraz, and Dr. Vaibhav. Thank you.
There are no slides. There are no framed questions. It's absolutely freewheeling discussion.
Can we start?
Of course. Who can stop you?
So first, do you think it makes any relevance to have this discussion?
If you ask me seriously, we should be better having coffee. This is a non-discussion. Hernia and undernutrition is a very rare problem.
Absolutely. So there is no way that a hernia patient can be malnourished according to you.
Malnourished, yes. Undernourished, rarely, with EC fistulas, mesh fistulas.
No, we are not
acute
talking
abdomen.
about this.
But largely it's obesity and hernia. Which is irrelevant.
Hernias are not malnourished, majority of times not malnourished. You agree, Deepak?
Yeah, I think it's.
So you never given nutritional support to a patient of hernia? If you have to think, it means no.
Yeah, I don't think so.
Because very rarely we surgeons say no. We always say I had one case. So it means no. You know, and Vaibhav, you? No. So Vaibhav is a young guy. He won't have that experience. So this session becomes irrelevant then.
Except that you are the host of the show.
Yeah.
No. The answer is yes or no. The session is relevant or not relevant.
If you're not talking about obesity, then
no. Why do you always say obesity? You talk of hernias.
Okay. Then no.
Do you think it's relevant or not relevant?
No, it's
okay,
not.
My question to you: do you think that a patient's improvement of a patient's nutritional status can alter the results of hernia surgery? Because sarcopenia, as you know, muscle wasting, you know, if it can be reversed, do you think that, because ultimately healing occurs with collagen? Collagen, I think, is a protein. And if you give protein, do you think that the results of surgery can be altered?
Clinical importance, no.
No. They can't be changed.
No.
We have an expert in the audience. Diksha has done a lot of work on sarcopenia. Diksha, why does it happen that there is sarcopenia, but sarcopenia cannot be held responsible for results in any surgery? Why does it happen so?
So it makes sense to understand and believe that sarcopenia will affect outcomes after any surgery. It is loss of muscle mass, and it is something that represents physiological depletion of a patient. But then objectively quantifying it and labeling a patient as sarcopenic is something which is very, very varied in literature. So we can have muscle indices, you can take total psoas muscle area, you can take psoas muscle volume, total abdominal muscle area, fat parameters to say that the patient is sarcopenic. But the cutoff values which have been defined are typically from the Western literature. If you actually look at the values across literature, it's about 490 mm square by meter square, which has been described in the Western population. We have done study in our department. More than 80% patients are below that cutoff. So it doesn't make sense to compare values across continents.
No, my question is this. Why is estimation of sarcopenia not translated into clinical outcomes?
So because there's no perfect parameter to identify the patient as sarcopenic.
So you have a patient who undergoes surgery for incisional hernia. Have you ever had any prolonged ileus in such patients that they need nutritional support?
So yeah, ileus, yes, it has happened. The more adhesiolisis we have done, the more the ileus has been. Whether it was correlating with the preoperative nutrition, I can't really say. Did they require nutrition in the postoperative period? Yes, they did, some of them. So I think.
However, what is the concept of prehabilitation? Do you have any idea? What is the concept of prehabilitation? Maybe not in maybe patients who have giant hernias or something. You think makes some sense? What is prehabilitation concept?
Yes, sir. Actually, prehabilitation is now an upcoming concept in ventral hernias. So for an elective repair, rehabilitation is just a process of optimizing the patient before surgery. And like we can control the obesity, all the modifiable risk factors, obesity, smoking, diabetes. And there are variable studies recent by European Hernia Society. They have done a meta-analysis. So the evidence is not that concrete right now, but variable factors that are associated with rehabilitation like obesity, decreasing the BMI of the patient or 7% up to weight loss if we can achieve, smoking cessation. So there are some factors that are associated with that, but rehabilitation as such, we don't have any concrete evidence.
Deepak, you want to make a comment?
Yeah, I think prehabilitation, we in fact have been doing it for our GI surgical cases, and especially for a hernia, we haven't used it. But in patients who have been who are waiting for surgery, like patients of malignancies who are on neoadjuvant treatment, in those patients we use prehabilitation, and there are 3 or 4 components of prehabilitation.
Oh, that's understandable.
Yeah, like
So,
exercise,
yeah, that's
nutrition.
Surprise, when a patient is waiting for surgery, incisional hernia surgery, waiting for some time, do you prescribe them any nutritional support, or you think it's unnecessary?
No, so we don't give them nutrition support, but
And
on prehabilitation, I would say that there is a European Hernia Society project, which is a randomized controlled trial, which looked at approximately 100 patients on each arm with and without prehabilitation, which incorporated nutrition, chest physiotherapy, weight loss, and all of that. And they found in the short term, there were benefits. At the end of 2 years, there weren't any benefits.
Ramana, when you talk of loss of domain, do these patients are more malnourished than other patients because they cannot eat, they have bloating? Do you think it makes some sense in nutritional support? So at least one sensible question.
Yeah, I would totally put these patients on nutritional support. So the nutritional support is two different types. One is a broad spectrum support, like we give Ensure or we give whey protein, and build that over whatever number of weeks we have before the planned surgery. The second thing is specific nutritional support, which is kind of immunonutrition. So that is omega-3 fatty acids, arginine, glutamine. So these I give typically for 5 days pre-op, because a longer period of time hasn't really shown any added advantage.
But Punjani, you do believe something, because in your patients also we have Botox and all.
My patients are poor, so they would not afford all these formulas. But I asked them to take high protein diet. That's how I built up. But I would like to know what product is available with these components.
Yeah. So is there any question I should have asked you, Surfraz, in nutrition?
Yeah, so one thing was that sarcopenic index has never been defined, and it is a very complex subject. That's A.
It's not complex. We've sorted it out for you.
I would like to sit down with you in private.
We published it, we sorted it out. So we've done your homework. You just have to do a CT scan, and all CT scan machines can do it.
So not only that, I think for all 50% of our hernia patients are obese. 50%. And
that's sarcopenic obesity.
Yeah, so I'm going to come to that. So 50% of our patients with hernia are obese. And if we go by the indices that we can follow with body composition, almost all of them are sarcopenic. So when we talk about sarcopenic obesity, where there is muscle loss, but there's disproportionate fat content in the body and disproportionate decreased muscle, I think almost half of our patients are sarcopenic obesity in our cohort. And when we look at sarcopenic obesity, and if you ask, is there any data to show that preoperative nutritional support is going to help? That's what I'm saying, that the clinical data and relevance still
do you think of all people in the audience, it makes sense to do a trial or a study to see patients who have sarcopenia, the chance of recurrence in them of hernia is higher? Do you think it makes some sense to do that?
Yeah, absolutely.
It does. Yeah, it does.
Say it again. Because my point is that you do not have to do any additional investigation. Anyway, they're undergoing a CT scan. You just have to see a psoas muscle thickness. You nothing else have to see. Maybe this may be one of the additional factors, because if we can document that patients who have sarcopenia, their results of surgery are not good, then it might be an argument to use some sort of a nutrition support.
One thing, I don't know if you're talking about this separately or not, but as you rightly said, merely talking about sarcopenia probably does not have great results in correlating with outcomes. And it's possibly a better idea to correlate physical strength and function. So things like...
I was going to discuss this.
You're going to discuss
so that's a very good point. Vaibhav, how do you assess the general status of a patient? Like he talked in the morning, an area of our interest, the fertility index. So all these things, how do you assess nutrition? What do you think? How can we assess grossly, let's not make it complicated. You know, we as surgeons, our IQ is room temperature. So to get into complex measures, how do you assess nutrition in a broad way?
Sir, in a broad way, in a clinical setting, and the simplest way is to do a subjective global assessment. Ask simple questions from the patient, and we can see like what is the dietary changes that he had, any weight loss, any symptoms that he has, what is the functional capacity. We can then see for the signs of edema or any subcutaneous fat loss. That is very easy to see clinically, and then we can stratify the patient accordingly. So that is one of the easiest ways to do it, sir.
So there's a difference. Sorry, please go ahead.
Can I make a comment?
All my patients.
Yeah. No, you first. Go ahead.
All my patients, I make it a point to write down on the history and ask about exercise. What is the exercise you do and how much? Every patient is documented whether he exercises nil, whether it's spare, if he's walking, how many. That's all.
How does it affect your management, or why do you do that? With what intention?
I do it more out of intention of their exercise tolerance for the fitness to a prolonged surgery, and basically obesity, because I know that this patient is not exercising and obese, and there are patients who are walking 5 kilometers and still having a BMI of 36.
Excellent.
So I think the part of rehabilitation which you were talking about, which Vaibhav answered, one tenet of rehabilitation is routine passive exercise. That helps to possibly regenerate the muscle strength, maybe. And indirectly, there is improved appetite because a lot of endogenous factors have been secreted. So if we talk about rehabilitation, optimizing outcome, it is doable in all the cases, particularly here, because overall we have enough time to optimize this patient. So
it makes sense. So talking about the frailty index and all those things, there's an interesting observation that if you take all these sophisticated nutritional indices and you compare with one simple question, unintended weight loss of more than 10% in 1 month, it's nearly the same. So, but we never do that, like various ways of hand grip strength, some sort of documentation of performance status should be done to document. I think it makes sense to tolerate operation and for side effects. What do you think, Sarfraz?
So if I understand this correctly, I think assessment can be done with some tools which are readily available for surgeon, like mini nutrition assessment.
Can I just interrupt you?
Yes.
We need to have a clarity. There are two things. One is nutritional screening, one is nutritional assessment. We first screen and then we assess. The two terms should not be taken individually. Suppose when a patient comes to the hospital, the nurse or the resident screens, and a patient who is screened and found to be malnourished, then is assessed. So we as surgeons do not understand. Screening is preliminary and assessment is subsequent. Like dating is screening and further is assessment. Yeah, go ahead.
No, so I was just making a point that for surgeons, instead of going for history of to understand nutrition, then examination, anthropometric, and then getting into lab indices like albumin and pre-albumin, transparent, hemoglobin. So instead of going to this, we could also do mini nutrition assessment tool, and that is like takes about few minutes, and you could get into an idea about whether your patient is malnourished or not.
Absolutely.
And this irrespective of whether you're talking about hernia or not.
I think all tools are nearly the same. What you use, that's up to you. I agree with you. You want to make a comment on the frailty thing?
So frailty is again a very complex subject with multiple parameters being judged. So I would basically think that a couple of clinic-based, that is OPD-based assessments are very useful. One is I make them perform 5 squats. So I see the time that they take to perform those 5 squats. So if it is just smooth up and down 5 times, then I know that this patient is functionally probably okay. And if the patient is unable to do it or gets exhausted or takes too long, then I consider this patient as frail. The same thing is applicable if you think in terms of subjecting them to a 6-minute walk test. So a 6-minute walk test is an excellent and validated way of screening these patients.
and also to improve that if you give them nutrition, how it improves. So what sort of nutrition, if somebody has to take Deepak, what nutrition do you propose if a patient needs some nutritional support? What is your style of giving them nutrition?
If the patient needs a nutrition support, usually we discuss with the dietitian and there's a dietary recall, like what all he's been taking for the last 3-4 days. Usually they make an assessment, and on the pattern of whatever he's eating, the amount of carbohydrate, fats and protein, whatever he's taking, a further plan is made for the patient. But obviously the requirement in these patients, while we are preparing a patient for surgery, protein requirement is definitely higher, and you give special proteins.
Like the only thing they need is protein.
Yeah.
So the whole discussion has to be based on proteins, because rest we don't know. I don't know about your hospital. In our hospital, the dietitian's contribution to this is very minimal. So you only have to give them proteins, and the quality of proteins that makes a difference. So there are no great questions in this. Anybody wants to make a comment about dietary support, I'm willing to discuss. There is no other further questions. If there any other comment here, you want to make a comment? Yeah.
By the standards of 1 gram per kg intake of protein, I believe that all of us will be classified as malnourished.
Absolutely.
We are never been able
No,
to
yes.
assess.
But I think since we are not pushed onto the stress, patients need 1.2 grams per kilogram, and most Indian patients consume less than 9 grams or 10 grams. So that's the tragedy of it. That's why our results of surgery are not as good. And it is not a matter of anecdotal evidence. Patients who come from other countries, when we operate them, like patients who come from African countries or patients who come from Arab countries, their recovery after any surgery is significantly better than ours. There's a lot of difference. It is so clear. So because it's basically related to protein. Yes, sir.
Yeah, so ultimately you tell us, you have been asking everyone. So how will you screen and how will you assess and how will you treat?
Okay. Our strategy is very simple. We believe in a patient-directed subjective global assessment. That's how we screen them. And we realize it's a very good tool. Simple things like, have you lost weight recently? How's your appetite? How much you eat? And now there are a lot of studies done which have shown that a subjective global assessment possibly correlates as well as sophisticated laboratory investigations. So we just do a subjective global assessment, and that's what unless we are doing some trial where we will do a MNI or something, but generally we just, our nurses do a subjective global assessment. So again,
how do you treat them?
Okay, the problem is that we grade these patients into mild, moderate, and severe. The worst thing is by they come to the hospital, you cannot treat them. You can merely prognosticate them, because what happens is that patients who have severe malnutrition, their malnutrition majority of time results from cancer cachexia or things like that. They cannot be treated. So this subjective global assessment is only to alter results in patients who have mild to moderate and benign diseases. In malignant diseases, it is merely meant to prognosticate them. What is important is if I have a patient of, say, pancreatic cancer or gastric cancer who has got severe malnutrition, I will put 2 drains, I will do a feeding jejunostomy. Whereas if a patient has got mild or low, I will not do a feeding jejunostomy. I might not even put a drain. So that's how it translates. You cannot undo it, because undoing will take weeks. And for cancer patients, you cannot wait weeks. Okay. You should give. We don't screen hernia patients, but it makes a lot of sense to give them proteins. And the problem, to my mind, the issue of proteins is that the biological value of proteins is of extreme importance. Do you know, interestingly, that our satiety in food comes from proteins? Satiety comes from proteins. That's why you cannot eat too much of proteins. And also, the biological value of a protein is very important. By biological value means how much you eat and how much is assimilated. And we also forget that protein absorption needs pumps. And these pumps have to be strong. So malnourished patients have weak pumps. So when you give them protein, they don't absorb, it's passed in the stools. So it's a two-way thing. So a protein should be given of a high biological value, and the best biological value comes from egg whites or whey proteins.
I want to make a comment. Our discussion started with a very all know that there is no law of patients. Just stating that complex hernias, patients with recurrent hernias, and those who come back following resection of the GI cancer is important. We may debate on what is borderline, but then I don't think we can.
The problem of literature in nutritional support is one, that we have not been able to have a laboratory value which gets reversal with nutritional support. The biggest crisis in nutritional literature is that no biological marker changes with nutritional support. To alter nutritional support, we need 6 weeks and 8 weeks. But yes, there is a lot of literature in foregut surgery, at least if you give nutritional support, it decreases. Mortality has not been shown to decrease. Surgical site infection, ICU care, getting off ventilators. So I believe large hernias, possibly putting a Ryle's tube, if they are malnourished, loss of domain, if they are given enteral nutrition, just normal feeding, not expensive ones, possibly might alter their results. Sorry, you go ahead. You are a guest, you first.
Okay. 2 points. One is in the 2015 paper in JAMA, more than 100,000 patients were studied. The rate of complications and readmissions amongst all standard major surgeries were compared. Esophageal, pancreatic, colorectal. AWR was higher than all of them. I think around 38% was the total incidence of complications in AWR. So if colorectal patients can improve, can improve their outcomes with rehabilitation, nutritional.
I'm sure AWR can do.
AWR.
And also, I believe in AWR, there is so much of dissection, so much of tissue spaces are opened up, and you directly talk to muscles. We forget that muscles release myokines. And myokines may be useful, they may be harmful also. So I think if you can modulate the immune response to these patients, possibly there might be recovery. But the challenge for us will be to define which are those patients who need this support. But to my mind, this is not a very bad thing, because we are giving them not expensive, it's enteral nutrition, it has no side effects. But I think it's absolutely, as it seeks a research question which we should take up.
This well studied in colorectal.
We are doing it.
Yeah.
We are doing it. Azhar, you were saying a comment?
Similarly, you were saying that rehabilitation, we are working on that. Regarding nutrition, I was thinking that the area we possibly cash right today, because we are talking about abdominal reconstruction and hernias, maybe in a patient where there is large intravenous fistula. The patient, there is a mesh-related problem.
No, that's a separate. If that comes to an enterocutaneous fistula, we are discussing pure incisional hernias. I think nobody has looked into the question of malnutrition in incisional hernias. There must be some way to look at it.
And one more thing about nutritional support, unless it's an exigency, I would wait 3 to 6 months to really build up a patient comprehensively, pulmonary rehab.
I think you make a very valid comment. For nutrition to have significant alteration, you need at least 6 to 8 weeks to have some palpable differences. But unfortunately, the studies that we do time is not there. So we have only 7 to 10 days. Even 7 to 10 days, nutritional support has been shown to have some changes.
So why don't we have all these patients who undergo now AWR, which is not an emergency at all. So we have a protocol of giving some, rather than assessing, let's give
Oral patient, yeah, it absolutely seeks a trial. In this country, we should do a trial. At the worst, what can it be? It can be a negative study. We have no way harmed the patient. We can identify patients who have loss of domain, who have some size of hernias. Maybe it will do something. One thing,
Yeah.
Surprise, what are your views?
I think overall also, like for all GI cancer cases, there's a lot of neoadjuvant treatment going on, and we get time before surgery for 6 to 8 weeks. So I think we should be utilizing that time to prepare the patients with rehabilitation more and more, especially in upper GI cancers and colorectal cancers.
Yes, sir.
Adesh, I think you have opened a new vision for the field,
And I think it's a really good thing to assess the patient pre-operatively. If we get a simple serum albumin, serum protein test and albumin is sufficient, still you want to support them.
Sir, the problem with albumin is a very poor marker of nutrition. It only reflects chronic malnutrition. And also the problem of albumin is it is an acute phase reactant. In somebody who has sepsis, albumin may be there, but it's a good marker for complications. And especially if you are waiting for 6 to 8 weeks, then it makes a lot of sense to do it because in 6 to 8 weeks, it will be altered. So I think it definitely seeks a trial and it's a food for thought. And maybe you guys do so much of AWR. And so we can see if their hospital stay, wound infection, recurrence can be decreased by some sort of a preoperative nutritional support.
Yeah.
Thank you very much. Thank you.
I think we should all give a round of applause to Vikas, who has done a splendid job. What an exceptionally good program, very tight program this was. Really learned a lot. Thank you so much.
Thank you, sir. I'm really humbled. Thank you. And I would just like to put in a vote of thanks. I really want to thank all the faculty who've come all the way, taken out their time, faculty, from outside, from within, from India, faculty from abroad who put in their time over the internet. So thank you so much. It's been, it's been great to have everybody here. Thank you, delegates, for putting in your time for this learning. Thank you to our residents, who put in their time. Thank you to the audiovisual team from Grover team. Thank you to Alpcot Network. So, it really is my duty to thank everybody who's made it possible. Please remember to collect your certificates. They're on the desk before you leave. And don't forget, we have dinner. We're not done yet. We have dinner after this at the Imperfecto patio. It's just about 5 minutes from here. In case you don't have, conveyance, then we try to help you, help you out with that as well. So let's reassemble and we can leave, I think, right from here. They'll be ready and we can start off dinner and drinks over there, and we can reassemble there. Have a great evening. So, sir, Dr. Chaudhary, sir, do you want to say anything? So, okay. Thank you. Thank you to the department. Thank you, sir. Thank you, sir.
चल विकास चल चल आजा हम लोग लंबी
Well done, well done. Boss. Well done.